of Visakhapatnam, and he is the chief of
and provide you with up-to-date evidence. So what can we expect today? So we are going to have some high energy, intense debates or battles as we are calling for today between the speakers. We are having more than 25 judges who will lead to balanced discussion and not leading to a single viewpoint dominating, practical and real world applicability, so that what you learn can be immediately practiced whether the case is in the OPD, ER, cath lab or the OT. Up-to-dates on the latest and greatest imaging and guidelines and protocols, and improve decision-making pathways so that the patient will ultimately be the beneficiary of this. So why does your presence matter? Because how much ever we speak, you are the frontline defenders against stroke. The decision that you are going to make in a matter of minutes or seconds is going to reshape a patient for the rest of their life. So the aim of this year is not just to give you knowledge, but to sharpen your decision making, expand the cross-specialty understanding, and bridge the gap between the multidisciplinary teams, whether they will be medical, surgical, or interventional. So for our country to truly move forward, we require more stroke-ready hospitals, faster door-to-needle and door-to-puncture times, stronger team-based decision-makings, better training at the periphery so they can handle the case quickly. Then, public awareness regarding the mortality and morbidity of
thrombolysis versus endovascular therapy. So I would like to call the chairpersons, Dr. Rajesh Pati. Yes, ladies and gentlemen, a round of applause. Let's join our hands together. Dr. Sailesh Modi ji. Dr. K. Suresh Kumar sir. Dr. Trivedi Reddy ma'am. Dr. Mitali Kar. We welcome you to this grand event. Now the battle begins with the most defining question in the acute ischemic stroke. The needle versus the neurocat. The speed versus precision. And fibrinolysis versus the mechanical mastery. So are you ready for our first speaker? Yes? So warm welcome and warm greetings to you for making this day, sir. For speaking on IV thrombolysis, Dr. K. Satya Rao, sir, the Chief of Neurology, Medical Hospitals, Visakhapatnam. Please come on to the dais, sir. Our one and only respectful and leading Chief of Neurology Department, Medical Hospitals, Visakhapatnam. Our expertise, undoubtedly, who provides us a comprehensive understanding with latest developments and best practices. So please, we are ready to hear you today with such an important topic of IV thrombolysis.
Good morning, everybody. Dear chairpersons, the legends of the conference today, my colleague speakers, and the delegates. It's a warm welcome from the side of medical work. The neurology, neurosurgery and interventional radiology. Today, it's so auspicious for us to learn something, to exchange our ideas. As my colleague said, I don't say it is a battle. I say it's an expression of the evidence, it's an expression of new things, it's an expression of an experience. We don't fight with each other. We express our experience in our own field. So, with this small beginning, I start my topic. Now, what is this stroke? What is it we want to do? What we are doing, what we can do, and what is expected further. These are the few things which are to be answered. Now, my dear friends, stroke mainly is divided into ischemic stroke and the hemorrhagic stroke. And as you know, stroke is the third leading cause of death and fourth leading cause of disability. Today, if you see the people, many people you might have seen many people walking on the road, or the house, or the meetings, wherever you go, that is a hemiplegic gait. So can you prevent this? Yes, to some extent we can do it, provided we meet all the targets which are aimed at. Now, the management of ischemic stroke and the hemorrhagic stroke are both different. So our main aim is ischemic stroke. So what does the ischemic strokes do? That means there is a sudden block of the artery, which results in the damage to that particular part of the brain, and this results in the so-called either a hemiplegia, facial paralysis, or the hemiplegia, or whatever. You know the acronym is FAST. So these symptoms can be manifested by the hemiplegia. When once it is completed stroke, what we do is this. So before it is completed, the moment the patient has a manifestation of the development of the symptoms, if you bring to the concerned hospital where the stroke unit is there, I mean the stroke unit means an emergency physician, ER department, a neurologist, an interventional radiologist, and a neurosurgeon. This is a group. This is a group in the management of stroke. And the facilities of the post-thrombolysis management in the acute unit. All these things should be there, and a good setup is required for the management of acute stroke when once you thrombolize the patient. Now, what I mean to say in the thrombolysis is every hour counts, every minute counts. Time is break. The earlier you bring the patient, the better the prognosis is. So now, what is it you are doing to the patient? Why you are in so hurry to bring the patient within 4 hours, 3 hours, 4.5 hours, like that? So you can see here, working. Okay, you can see here. the moment the patient has a block in the vessel, that is certainly the core area, that black one, which is the damaged one. So this damaged one, and surrounding that, a blue one, and around the blue one is the normal ring. So what is the blue one? That is what is called as ischemic penumbra. So our target is the ischemic penumbra. Why we are targeting the ischemic penumbra? Because they are the cells which are biochemically active but functionally inactive. So what happens? These cells are not getting complete blood supply. There is a collateral circulation which is supplying to some extent to this area, but it is not complete, hence it is not functioning, but it is biochemically inactive. So what we are doing is, by removing the clot, by thrombolizing or destroying the clot, make the blood to flow to that core area and thereby to the penumbra. When this penumbra is saved, yes, the patient is saved. Now, what is the time required for this? Suppose, if you take the earlier criteria, AHA and ASA guideline, first they thought of 3 hours, next they have come to 4.5 hours. Now, if you bring the patient to the hospital within 4.5 hours, you get thorough investigation and subject you for the thrombolysis. And there are certain guidelines given by the AHA and ASA. The guidelines given earlier are so stringent. We could not thrombolize the patient not more than 5%. These important stringent criteria are earlier head injury, some urethral bleed, sometimes head injury, something what's called patient is an anticoagulant, patient has a seizure, patient has metabolic problem, hyperglycemia, hypoglycemia, or whatnot. Everything is included. Even the age beyond 80 years and the infarct large in size, other contraindications. So we are not able to thrombolize this patient. Just 5 to 6% or 7% when we are doing it. Now we got the smart guidelines. 7 to 8 years back, the smart guidelines have come out. What does the smart guideline indicate? All these things are wiped out. The main contraindication according to the smart guidelines is only intracerebral hemorrhage. If the patient has an intracerebral hemorrhage, either in the MRI or CT scan, it is an absolute contraindication. Otherwise, every person who is fit for the thrombolysis, who is brought in the window period, is eligible for thrombolysis. So if you see this, percentage of thrombolysis, in the developed countries it comes to just 9%. Whereas in US it is coming to 50%, and European countries it has reached to 15 to 20%. Now when do you thrombolize? And what are the important things taken into for the consideration? First thing is window period. If the patient is brought to the hospital within the window period, that is 3 to 4.5 hours. Yes, as given as the time, you can thrombolize the patient. And as we said, the patients with earlier criteria, we are not able to do it properly, and the recent guidelines make us to go for thrombolysis. Now, what are the contraindications? What are the challenges which are to be met with? Now the patient is on anticoagulants, or the patient has a large infarct, or the patient has crossed his 80 years of age, or the patient has come beyond 4.5 hours, the so-called window period. In such a case, how do you tackle it? So we will go one after the other. Now, the anticoagulants. What are the common anticoagulants which are being used either in the neurology, either in the cardiology, or the cardiothoracic surgery, and the physicians also? So these are vitamin K antagonists, thrombin antagonists, and factor V antagonists. These are the common anticoagulants which are being used. When the patient is on anticoagulant, it is an absolute contraindication according to the earlier criteria. But when once the SMART criteria has come into the womb, though the patient is on anticoagulant, see the INR. If the INR is less than 1.7, you can happily thrombolyze. And the other things we will take into consideration one after the other. This, I told you, A class 3 trial indicates a contraindication if the age is more than 8 years and if it is a large infarct. And I told you beyond window period. If the patient comes beyond the window period, that is 4.5 hours, can you do something? There are various trials going on. Some have already published in 2024 and 2025. And this after 4.5 hours, beyond 4.5 hours window period. That means 0 to 6 hours, 12 hours, and 24 hours. Now, the patient has come with an oral anticoagulant. Common is your warfarin. If the patient comes with a warfarin, you have to go for the INR. If the INR is 1.7, less than 1.7, you go for the thrombolysis. If it is more than 1.7, you go to the other methods. So, if the patient INR is more than 1.7, what you are going to do? You can thrombolyze. Give stat intravenous vitamin K, then give 4 packets of FFP and re-examine the INR. If the INR comes down to 1.7, 1.5 like that, happily you can thrombolyze. Now, the thrombin antagonist, that is VIZAG. Nowadays, the thrombin antagonist and factor X inhibitor are commonly used mostly on the cardiology side and cardiothoracic side. And there is no definite antagonist available for us. That is the problem with these things. If you give the WR, you can measure the thrombin level, and if you can get the antagonist, that is edoxacitabine. That's costly. It is available. If you can get it, you can give it and go for thrombolysis. Now, factor X inhibitors. These are also routinely used in the departments, cardiology and cardiothoracic surgery. And it is apixaban, rivaroxaban. If the patient comes with these drugs intake, then you go for the corresponding antidote. That is alpha. I think it's not yet available. If you can do it, you can thrombolyze the patient. Age beyond 8 years and large infarct. Earlier criteria I told you, this is an absolute contraindication. Now, after this new criteria, we are thrombolyzing the patient. Though the patient has a large infarct, though the patient is beyond 8 years, because there is a definite evidence when you give within the period of window period. If you thrombolyze the patient within the window period in this group, there is a definite evidence of improvement in the people more than what is expected when compared to the earlier guidelines. So, you can thrombolyze these people, take something into the cognizance. Now, the crux comes the window period. If the patient comes to you beyond 4.5 hours, what are you going to do? So, they have divided into 3 groups. 0 to 6 hours, 9 hours, and 24 hours. There are several trials which were made and published. There are 12 trials which were conducted in 24 to 25. Those who have come before 6 hours, they were all thrombolyzed. They have taken as a CT scan or an MRI, either perfusion or diffusion-perfusion mismatch. These things are taken into consideration. Sometimes, though there is a diffusion prominence, positive diffusion, and perfusion also shows some hyperintensity, those people were also thrombolyzed. Those people who were thrombolyzed without mechanical, please remember, without mechanical thrombectomy, these people were thrombolyzed and there were very good results up to 6 hours. So beyond 6 hours, there are some people who were thrombolyzed. It is divided into 2 groups. 6 hours and 9 hours group. A small trial, ICAD trial. What they have done, 0.1 milligram per kg burden. And some people they have given 0.25 milligrams per kg burden. Predominantly tenactic place. They prefer tenactic place than multiplex. When you thrombolyze with a tenactic place with these 2 groups, there is only one case which had a symptomatic intracerebral hemorrhage when you treat with 0.25 milligrams. But those people who were treated with 0.1 milligrams per kg body weight of the tenactic place, they have all done very well. There is no hemorrhage. So, they said they are improving well with these doses. But subsequent studies say it is not 0.1 milligrams, 0.25 milligrams is equally good, and the percentage of intracerebral hemorrhage is comparably less when compared to the normal people. This is the evidence which they have given. This is already discussed. So now, particular 0 to 12 hours and beyond this. Again, they have tried with tenactic 0 and thrombectomy on the same side. Those people which have been thrombolyzed beyond 12 hours, most of them gone for thrombectomy. Whereas up to 12 hours, some people went for thrombectomy, few people improved with tenactic 0. So, up to 12 hours, you can go for the management of the ischemic stroke. Mostly, when once the patient crosses 6 hours, you should be very careful, and after 12 hours, you can go for thrombectomy. The earlier guidance, they indicate even at 4.5 to 6 hours, people may be subjected for thrombectomies. Yes, now, what if we are doing? Are we able to thrombolyze all the eligible people? Are we getting all the people to the hospital for thrombolysis? No. Why we are not able to get these people and why we are not able to thrombolyze? So what are the problems or the challenges and how to combat the challenges? What are the reasons why we are not getting all these people for thrombolysis? Because lack of awareness. People are not aware that there is a condition what is called as an ischemic stroke. They know it's a hemiplegia only. Hemiplegia is attributable to so many causes. But these people are the people outside the hospitals, they don't know about the window period or the golden hour. That is 4.5 hours. If you bring the patient, they can compromise and the patient improves. They don't know. So they don't know about the window period. They don't know about the thrombolysis. And what we want to do if such is the situation? What are the main reasons why we are not able to get these patients? Suppose the patient knows it. We have to bring the patient within time. We are not able to do it. Why? Because there are transport challenges. There is no accessibility. There is no unavailability of the centers. Suppose in the 4 or 5 districts, we have only VIZAG, where the stroke centers are existing. Suppose if the patient at 200 or 300 kilometers, they can't reach the hospital within the window period. So what to do? Though you made them aware, you have conducted so many camps, you brought to so many awareness campaigns, you made them aware, but you are not able to get the patient back to the hospital where the service is available. So you need services which make the patient able to attend the hospital. So how you do it? First thing is conduct awareness campaigns, which we are doing regularly in the medical hospital. That's all, it's okay, we are doing it. But how to get the patient? We need advanced ambulance services. If you see the Western countries, the advanced ambulance service where a CT scan is situated there. If the patient comes into the ambulance, then and there they get a CT scan done. They will be able to contact, that is a telemedicine, the concerned neurologist where he is existing there. They send a CT scan, everything is there, they thrombolyze and then bring the patient to the X-ray center. If this exists, almost we use 25 to 30% of the thrombolysis. And one more thing is use of artificial intelligence. If you have the facility of artificial intelligence, as is going on in the Western countries, it solves a lot of problems. Artificial intelligence itself will decide whether the patient is fit for thrombolysis or not, what amount of tenacity is to be given, whether the patient is subjected for thrombectomy or not. Is it a stroke minute or a definite stroke? This artificial intelligence is able to detect and make us treat the patient very well. This is what is happening in the Western countries, and if we are able to get it, not only artificial, we leave alone the artificial intelligence. If we can get an advanced ambulance facility, we are not but helping a lot of people in getting normal, and we will not see the people who are dependent on the family members. And another thing is, we should have the tertiary centers. We have only one in VIZAG. If you have centers in the district headquarters, which is just around 100 kilometers distance, they can easily approach. There, the physician and the neurologist and CT scan facility is available. Then and there, they can see the patient. They can contact a neurologist if he is there, or it is a tertiary center, and just thrombolyze the patient then and there itself. This solves a lot of problem. Now, I want to tell you our small experience in our medical hospital. In the last, that is 23-24, we have total, under single consultant, the admissions were 436. And out of that, the number of strokes were 36. Ischemic is 31%, and the thrombolysis we could do in 9% of the cases. We started doing awareness campaigns, a lot of awareness campaigns. And we are keeping the videos in the social media about the stroke management, window period, the so-called golden thrombolytic agents, which are available for us, they are within the reach of the people. So based on that, now in the present year, 24-25, the number of patients are 487, total stroke 117, ischemic 93, hemorrhagic 24, and we could thrombolize up to 20%. This is the achievement in the medical hospital. Now, thrombolysis in the patient while on anticoagulants. It's a difficult situation. Earlier, in the last year, we will thrombolize 2 patients. One, a double wall replacement, another is aortic wall replacement, where the patients were on anticoagulants and they were brought in the window period. And we found that INR is less than 1.0. As per the earlier guidelines, it's an absolute contraindication. But now, when once the smart criteria has come into the field, we could thrombolize both the patients without any hesitation, and they improved markedly within just 1 week. They could walk out of the hospital within 1 week. This was published in the Annals of Neurology and Neurosurgery in 2 years back. Now, challenging cases. Some of the challenging cases which our experience, which I want to tell you. Here, it's a patient on anticoagulant, a 61 years old male with a mitral valve replacement. INR is 2.1. Here is the problem. We cannot thrombolize because it's INR 2.16. The time is short. Here, every minute counts. The present theme of the stroke is every minute counts. In every minute counts dictum, then we have ran. We have given intravenous vitamin K. We have given 4 packets of FFP, and the INR was brought to just 1.6. Then we could thrombolize the patient. There was a remarkable improvement within 1 hour. Now, one more patient. This patient is brought 6 hours. That is after being operated. 4.5 hours. This patient is brought within 6 hours. So, MRI showed an acute infarction in the right MCA territory and the right ICA thrombosis. The patient refused for thrombectomy. Then I have given 0.2 milligrams per kg body weight of tenactinus. After explaining everything about the ongoing trials, because the ethical issue comes here, because whenever there is an ongoing trial, it is not an indication, but you can have the patient's signature. We have to get the permission from the patient because it is an ongoing trial. There is a definite improvement with this treatment. If we accept it, then we will give it. Patient will explain everything, get his signature and thrombolize. This thrombolize made the patient recover within 1 week and he has gone walking. There is one more who was brought in 7 hours. 6 hours is okay. 7 hours is dangerous. And this patient, it showed an infarct. Then I was in dilemma whether to treat or not to treat. I have explained about the trials, 0.1 milligrams, 0.2 milligrams. I was scared about 0.2 milligrams because it may go in for a hemorrhagic conversion. So then I have tried. I told them the fact. This is the ongoing trial. You may improve, you may not improve, but usually may not be harmful. They accepted for that. I have given 1 milligram per kg body weight tenactinus based on the trials trial, and the patient has a remarkable improvement, and you will see it later on the next slides, few slides. So then, one more patient, a pontine infarct, brought in 5.3 hours. Here, one thing we should remember from the physician side or the neurologist side is, it is not the size of the infarct, it is the amount of deficit which we have to treat. When the patient has a dense hemiplegia, though the infarct is small, please thrombolize. So this patient with a pontine infarct and grade 2 power, I have thrombolized the patient has recovered completely. Now you can see this is internal carotid artery thrombosis, and the patient was thrombolized with 0.1 milligram because this patient came out till now. So this patient improved very well. This is one patient, young fellow. He came into the window period. And there is a internal carotid artery thrombosis, left internal carotid artery thrombosis is there. And they are not willing for thrombectomy. That's the problem. So I have thrombolized with 0.25 milligrams. Middle circular artery is opened, and a good circle of Willis was maintained, and I discharged the patient with a walking movements. We went on this butterfly walk. This is how there are some of the problems which we have to manage. If everything is okay, then okay. Something happened, then the problem is there. That is why informed consent is a must for the people where we are thrombolizing, when we are following an ongoing prayer. It's a must. This is published in the recent journal, that is Clinical Studies and the Medical Case Reports in the last year. So some of the things which we kept in the media, just an advertisement or awareness campaigns. In awareness campaign where the patient was thrombolized, improved within 1 week, and he was talking that he has improved. So this, when you project it into the people and you give it in the social media, it gives a lot of happiness to the people and gives an awareness. So they will do better. This is one more slide where we got a video. This is the patient's thrombolysis where the patient is doing very well. Now this is the awareness campaign in the public meeting which made us to improve our thrombolysis. So the conclusions: timely arrival, experienced stroke team availability, telemedicine facility, advanced ambulance facilities, stroke units to be distributed in the headquarters hospital, and use artificial intelligence. Thank you, friends.
Thank you, Dr. Satyaras, for your enlightening, valuable insights and a great presentation on IV thrombolysis. Your perspectives are to be appreciated, sir. You have shown us the live videos, and it's really an inspirational presentation for us. We request you to have a seat on the dais, sir, for the battle.
Thank you.
So, for the clash of titans on this acute ischemic stroke, I want to call our second speaker on this topic. So, let us shift our gears, explore another perspective on treating vascular issues. Dr. Matthew Cherian, sir, Chief of Interventional Radiology, Kovai Medical Center, Coimbatore. We want you to share your valuable insights on endovascular therapy, offering a different approach to the discussion, sir. We are privileged to have you here, sir.
Okay, so I know Shiva almost screaming from morning about his battle. The first thing I want to say, we don't battle in the hospitals. We don't battle in the theatre. We discuss. We have a tumor board that comes with a consensus statement and what is the best thing that we do for a patient. We have a debate and we don't battle. So first of all, sorry, this is not a battleground. This is a ground when we have just one intention and what exactly is the ideal thing that we could do for a patient. And that's why, Dr. Satyarama got this picture of Shiva pushing you, and putting you in this very uncomfortable position by asking you to talk on something which is 10 years old. And then he asked me to speak and say, what exactly do I have to say about mechanical thrombectomy? So you must understand, there has been a massive paradigm shift in stroke therapy. And it's so radical a treatment that nothing can be debated on this. There's nothing really to even fight about this, So what exactly was the landscape before 2015? And this is the landscape that Dr. Rao was actually focusing on. A landscape when the primary treatment was basically IVT. And that is the only thing that we had to offer because everything else was insufficient. And at that point of time is brain was the biggest mantra. Everybody talked about how can you kill a patient in a hospital within 3 hours. And then they extended and say maybe 4.5 hours. And close to impractical number in a country like India, and that I will show you. Then came the problem with large vessel occlusions. We are not even talking about tandem occlusions when the best results were 30% recanalization. With a certain subset of patient who would hemorrhage. And then we had the early thrombectomy trials prior to 215 when we used a device called the Mercy device. And all the trials that came after, whether the IMS3 or the synthesis or the rescue, all of them showed they were not good enough. Until that point of time, IV thrombolysis ruled and dominated stroke therapy. But that was a decade ago. And a decade ago in modern medicine is almost like 100 years ago. In 2015, there would be this huge transformation that would take place. 5 articles would come back to back in the New England Journal of Medicine, and all 5 of them did one thing. They established the first wave. Established an absolutely new standard of care, which was unrefutable. There was no going back on something. So we had the first paper, which was called the Mr. Clean. It was the first positive trial that demonstrated that an intra-arterial therapy where we could actually use a mechanical device to remove clots was superior to the usual thrombolytic therapy alone. It included a broad range of patients, and it reduced the potential industry bias of even using industry device product, and basically it broke every study that so far claimed that mechanical devices were not basically the right patient to do, right? The study enrolled 500 patients who had suffered stroke because of a block in a major artery in the brain. Now, it was a first positive trial. It demonstrated this one would definitely work. It was a great design. It included a broad range of patients, making it really practical in the real world. It was an investigator-initiated trial. It was not a trial which was driven by a company, and therefore the bias was much lower, and it was a pioneering study because it broke the original mindset. It had its own flaws. One was that 90 days MRS score was assessed by the same group who did the therapy. So theoretically, there could be a bias. It also used a couple of older devices along with a solitary device. And there was also a problem, some of the people in the control device also used the Mercy device. But having said all that, this was a landmark trial, a trial that would change the way we practice. And today's discussion or debate, as Shiva wants to call it, is based on what happened through the first study of Mr. Clean. And we talked about the small bias. Then came the escape trial. Again, the same thing, it confirmed the same thing, that mechanical thrombectomy was definitely superior. You know, what are the main conclusions? Rapid endovascular thrombectomy significantly improves functional outcomes and reduces death in this subset of patients who basically came within that 6-hour window period, right? Now, the thing was, one can say this, and the study was actually terminated early because the results were so good, but one can say statistical bias was there because it was terminated early. We say we used a very stringent criteria because one of the things out there was that all of them had a very strict window period. Then came 3 other studies, the SWIFT Prime, the Extend IA, and the VIZAG. All 3 of them together also came with the same key finding. But the big thing, SWIFT Prime for the first time talked about a mismatch between the core and the penumbra, and therefore they were the first people who said, I think time may not be the only factor. What matters more is there viable tissue, is there salvageable brain? And then came the Extend IA, which again showed that you do it even faster. If you do reperfusion even by 2 hours, you can have even better results. But the basic idea, the conclusion across all 3 trials are basically this, that for a select group of patients who had a penumbra, who came within a window period, caused by a large artery blockage in the brain, endovascular treatment with IVTPA was definitely far superior than IVTPA alone, right? So today's world, if somebody is talking about IVTPA as any form of therapy, you understand you're just talking of something which is 10 years old. And therefore, we have to understand how do you implement this practice across the country, and try to say that whether we should be sticking on the IVTPA. So let's look at the VIZAG. This was even better because it took the same subset of patients who were candidates for IVTPA. Out of that, we did a mechanical thrombectomy and showed class by class, hour by hour. When we did mechanical thrombectomy, there was absolutely no doubt that this was superior, right? So basically that's what we're saying, that there is no way to argue. It's not fair to ask Dr. Rao to come and say, can you have a debate? What we can talk, Dr. Rao, can you please tell us, where do you position IPTPA in today's world when mechanical thrombectomy, without any doubt, is the way to go about in stroke therapy, right? There were some limitations, there was an industry sponsorship in some of the trials, there was some selective enrollment, because again, they were selected to patients who had a window period and a penumbra. But the greater advantage came when there was no time limit now. The DAWN trial became a tissue-based selection and no longer was it time-based. So their criteria was you take a patient with a wake-up stroke, you have a patient after 24 hours, you do an imaging, if there is a penumbra, go ahead and treat it. And they too showed that time was not an important criteria. It's having viable tissue that was a great criteria. So what are we doing? We're coming and saying that wherever TPA does not work, this will still work, provided you have the right technology at hand and you've got viable brain tissue. Advantage of the study, it showed a profound benefit for MT for patients even in a larger window period. It revolutionized the concept of when do we treat patients who wake-up strokes and firmly established the principle of selecting patients based on the penumbra rather than on time, right? They too have rigid protocols because we had to have rigid protocols in case otherwise we have larger set of complications. What are the flaws again? The mismatch criteria only meant a small fraction of screened patients would get it. Not everybody who had after 6 hours would get it. But having said that, this was the way to go. And of course we can say it was an AI-based tool that picked up the penumbra for them, right? Like I said, basically this was the basic thing. We were working on a proprietary software, but then came the diffuse 3 trial. The diffuse 3 trial was 6 to 16 hours in the period. Again the same thing, again a criteria where they use a penumbra, and again they found that this too was an absolutely paper that totally agreed that mechanical thrombectomy was the way to go over. So defining basically the process that we can say, what are the key processes? So the key thing comes is, do you really need bridging? Do you really need thrombolysis at all? I mean, that could be a debate. And the fact is, if you look, there are 3 trials that came, the direct MT China, the skip from Japan, and Mr. Clean, no IVT from Europe. What was their conclusion? They all showed one thing, that it was a non-inferiority trial. When you mean a non-inferiority trial, it's just like saying that the best dosa is available in a shop, say, just 10 minutes from your house. But there is something even better available 2 hours away. Non-inferiority is saying, if you compare the problem of traveling 2 hours, compared to traveling 10 minutes for this dosa, is this dosa inferior or non-inferior? Okay? So maybe this is not the best. But considering the fact you save a lot of problems, especially in India, you save 50,000 if you save thrombolysis. So for example, in our hospital, if a patient comes and is a candidate eligible for MT, they don't get thrombolysis. We save that 50,000. We realized in our own study that there is no definite advantage. But if we're shifting a patient from another center, where they're going to travel by ambulance for an hour or more to come, then probably yes. And that's a question that can be debated. We can talk about it, but definitely not where do we do MT at all. Okay? So basically, like I said, it was all of them are non-inferiority trials, and so they may have a little bit of efficiency, but overall in our center, in our personal experience, we found more of fragmentation that was taking place when actually we did IVT inside in patients who came to the hospital in an RBC clot, and we stopped doing that completely. Another problem, we don't like to combine thrombolytics with 2B3A antagonists. We have a patient who finally finds it's got ICAD, and now we want to give, cangrelol to the patient, and we are uncomfortable when the patient has just received a thrombolytic a few minutes ago. And we can talk and we can debate, but we don't give it. And we find that there has been no problem and probably less complication. But this is not enough. What about pushing the aspect score? We said that an aspect which is 6 or more should be the only aspect that is taken. And then came this whole set of studies for taking, can we take large cores? Can we take a core which even crosses 30 cc? Can we go up to 70 cc? None of these are candidates for thrombolysis. And then came the rescue, the Japan limit, the selective global, and what did we find? In all of them, again the same thing, there is a definite benefit. But having said that, again in India, we have a challenge. These studies show one thing, all these patients went to rehab and after discharge. So unless you have a rehab facility and a committed patient and a family that can actually avail and spend money for the rehab, in fact, may not be a problem, may not be very, very useful. But having said that, the fact is, even here, it is an absolute yes to mechanical thrombectomy if the environment permits it, which is an absolute no to a patient for thrombolysis. Okay? So basically, the flaws and limitation basically are just this, that the benefit comes the cost of increased hemorrhage, meaning patient and family counsel is more critical, and also the selection is dependent on careful patient selection and understanding very, very well. There is a lot of commitment from the family when you take large clinical part. The MRS 6 comes to 5, the time comes to 4, the 4 comes to 3 and 2. You remember there's a subset of patients who really do not benefit, and that counseling is important, but it is there. So what exactly is the future direction? Today, do we have a debate at all? Even today, you can see yes for a patient with a window of less than 6, IV thrombolysis can be used. Debatable if it is already in the hospital, definitely indicating the patient is traveling and is coming. But remember, it works better when the window is shorter and shorter. Late windows, mechanical thrombectomy without any doubt is the way to go. Larger aspect score, mechanical thrombectomy is the only way to go. Bridging versus non-bridging is a question that you can debate and could be a consensus statement of your hospital. Now I want to show you our annual stroke matrices, February 24 to January 25. Total stroke calls we got is 1,404. Acute infarcts, 757. Mechanical thrombectomy was done for 72 patients. But I want you to understand this thing. We had a mobile stroke unit with a CT 7 years ago. We had to shut it down purely because we had a challenge because the government was not supporting it. And we had a problem with arguing and fighting with the patient who pays for therapeutic place on the roadside. But I want you to know, at that time, our big thing, our onset came down to 320 minutes. Before the MSU, you see, it was about 5 hours for a patient to reach a hospital. When we did use the MSU, the mobile stroke unit, we could bring it to 2 hours. That is where thrombolytics can dominate. So technically, if you want to run thrombolysis as an important parameter, the government has to support in a system like mobile stroke units where you can bring this point, reduce it from stroke to arrival or stroke to the needle to 2 hours if you have a mobile stroke unit. Otherwise, there's no debate about this morning. After 5 years, it is still 302. We have done everything that Dr. Rao talked about. We are put on the social media, we are advertised, we screamed on the mountaintop, but still, we have a challenge. It will still be 5 to 6 hours before we come, and we can say it may be your hospital. This is the data that comes from the PRAN study. You look at the PRAN study data, the window time for arrival to hospital was 215 plus minus 200. That means you're hitting close to 400 and 500 minutes before patients reach hospital. So this is a problem in India, will continue to be a problem in India for many, many, many years unless we have something radically different like a mobile stroke unit happening, and therefore I personally believe the role of IVT in India is really small because the big challenge of getting patients in time to a right hospital that can do the right imaging. So finally, the proof of the pudding is in the eating, right? So let me show you cases. To show you how fast, how effectively, over and over and over again, we can show stories of success. Here is a patient who's on ischemic heart disease and double platelets. Again, a contraindication of thrombolysis. He comes to us, and you can see on MR the diffusion restriction giving us an aspect of close to 7. And ASF shows the very large penumbra that is existing. You see the occlusion on this angio is replicated on the DSA, a stent retriever that is taken across, a huge clot that comes out, and you have a patient that is completely clean of his block. The patient recovered 24 hours later to a very significant level. And we would discharge this patient in a week. A 37-year-old, right hemiparesis, NIHS stent, wake-up stroke since wake-up. He comes to us, you can see the interesting finding of a blooming clot. I don't know why this is the point of that. You can see that out here. This blooming out there is an RBC clot. And today when we see something like that, we do an extremely super fast procedure where we use a low-cross technique of using a long sheet, a suction catheter, and an offset. And we have this out in a matter of 10 to 12 minutes from the time of puncture. You can see the result. And we know that in all of them, they will finally do extremely well because the core volumes are so less. Okay? Aspects 9, no hypertension vessel. Now what about this case? Okay. Now, this is of course the previous one. Here is another case, 68-year-old man. He's come with giddiness for 6 hours and right-sided weakness. His MR shows these little infarcts and in the cerebellum and the tectum. He's got a blooming thrombus in the basilar cord. And here it is. You just go up there, do a mechanical thrombectomy, you restore vessels. Both in the anterior and the posterior circulation, they give us remarkable benefits with extremely good outcomes in the vast majority of patients. Now take a look at this. 53-year-old male, 2.5 hours, slurred speech, facial palsy, fantastic case for thrombolysis, right? But when we go and look at this patient has a large penumbra on the ASL, but the key thing is we don't see the blooming on SWI. So what exactly are we treating? We go there, we do a suction because now we know from experience these may be fibrin-rich clots, and this is the clot that comes. What will thrombolysis do there? Nothing. Not at all. But the advantage of mechanical thrombectomy, you can take out the clot, you can fix the problem, whatever the etiology it is. It is not just limited to RBC clots anymore. And this patient will do well. But I want you to understand, this fibrin clot can be a very difficult problem. The problem, you take a stent retriever, it just rolls out. It doesn't pull it out very often. That's why we tend to use a suction catheter, because it can kind of suck it out. But very often, even with the suction, it doesn't fade. And what do? We can put 2 stent retrievers, like what I'm showing here, one and another one, and we can engage them and pull both of them out together as they get meshed between each other. Thrombolysis cannot do stuff like this and can never do stuff like this. And therefore, we are far, far ahead of thrombolysis in giving you much higher rates of recanalization, right? So look at this guy, he's come to us. You can see the occlusion of the M1 on the right side. It's pretty obvious, right? Right there. And then, this is the finding. There is no blooming on SWI. We do the study, an infinitus, vector, with suction, nothing happens. So we take a dual SR technique. You can see out here the 2 stent retrievers that are going up, and then we actually mesh it, and you pull it out, and we get the clot out. I want to show you the finding and the final result. See that? This is this kind of clot. And these are not RBC clots. They are rubbery and difficult. But having said that, this dual centrifugal can do an amazing job to many complex situations which initially we find it difficult. A T occlusion like this. The problem is you take a centrifugal and put it across, one piece is to break up and go forward, sometimes makes the procedure more complex because then we have to go and try to take this clot out. The advantage of both centrifugal is you can pull them both together. And this is a case where we showed exactly that. Here's a patient, an ICA top clot occlusion over there. That's a very large ASL defect that you see over here. And what have we done? We have gone, you can see the occlusion on the ICA top. Huh? And as we go up, you can see what happens. We are taking the injection. We have got the two stent retrievers on two sides. This doesn't work. That's a chunk. And you can see, for some reason the mouse is not working, so so you can see what's done, and the first pass we get a result like this. See, we are evolving every day. We're getting better devices, and now within the end of the, in a few months from now, we're going to get the 9-0 suction catheters that are going to be even greater, better, and we can have more evolutionary technique. What about tandem lesions, which there's nothing you can do with thrombolysis? Here's a patient who's come to us with a critical stenosis in the ICA, a clot in the ICA, and a further clot up on the ICA top. This volume can hardly ever work with thrombolysis. But today we can open all of it. Like you can see over here, the MCA is open. You can see the whole vessel is opened up here. You can something change the battery for the next speaker to be useful. And then you can see a stent, and we are completely fixed. We have fixed the underlying problem along with the clot itself. And that's the way we should be thinking of treating, rather than just thinking of thrombolysis as a one-stop solution. Okay? And these are 24-hour seeing that things are good, right? The patient is well. Here is a 60-year-old patient, comes to us again with the Basedow syndrome, PCH stroke, and you can see another issue. The issue out here is the vertebral artery is hypoplastic on the left side, and on the right side you can see an occlusion of the origin of the vertebral artery. Can we treat these with thrombolysis? Absolutely no. But we can treat them all on the endovascular route, and that's exactly what I'm going to show you. So what did we do? We went down, we crossed the lesion, through that, we took a long sheet, we went ahead, did the procedure, and finally you can see we have crossed it. Okay, you can see that, it's all crossed, and then you have a final result when you have got this segment open, and then you open the base of that top, and you have given it back a normal flow. Can you get that? And these patients do well. So what am I trying to say? 10 years back, thrombolysis is the answer. 10 years later, we got a whole lot of stuff. The thrombolysis can sometimes support maybe during transport, but otherwise, as a therapeutic option, its limitation is very low and maybe to some small vessels offer some problem solving. So, showing another case. How do you treat patients that come like this? Here is a patient that comes to you, and you can see a critical narrow here. Treating with thrombolysis is not going to solve the problem. We go ahead, we do a second suction, and you see what happens. It opens, and a little later it shuts down. We got a stent retriever, and again it thrombosis. Now what we do in this case, we run intra-arterial tyrofibano cangrelol right into this. Keeping the stent open, we call the same technique. But the bottom line is what? We can get this vessel completely open by this combination of technique. Very difficult lesions. Lesions that don't respond can all. Our recanalization rate in the center is close to 85% today, touching 90 when we use a dual stent retriever technique. At the end of the day, 24 hours later, it looks good, the patient is fine. What happens in ICAD? You have a lesion like this. We do a stent retriever and open it. But very soon it shuts down because the plaque itself is denuded. We run candelol or tarifuse into this drug and we get the vessel open. But that itself is not enough because it will shut down again sooner or later. So we go ahead and do an angioplasty. Today in a center, the patient holds to angioplasty for 45 minutes. We consider this enough and do an elective stenting later. Otherwise, we place a stent and we come out. For example, see this patient. You can see the typical appearance of a very narrow vessel on the MCU. What do we do for this patient? We go ahead, we take this patient up, we treat the trach with empty, but you can see that there is this tight stenosis even now. So we do a balloon angioplasty, and at the end of the day, you see the result is good. It's holding on. We treat the underlying pathology, and these patients do extremely well, provided they don't have a problem like a bleed, and they are not so common. We all know that. The infarct has not progressed, right? And the patient did well. Look at this one. We do a study, we find a flaw. Look at this stenosis. This is this large. It's not going to get solved with thrombolysis. You've got to fix the problem. We go ahead, we get it open, but we find the residual stenosis significant. We do a balloon angioplasty, still suboptimal. We go ahead, we place a stent, and now we got a perfect result. Why don't we do stenting for all of them? Because we don't like to keep them on a dual antiplatelet therapy at least for 24 or 48 hours. So that's one reason we do it more as an elective procedure or a bailout procedure, right? So finally, is there anybody here who thinks that there is a great role for IV thrombolysis in today's world? There is a definite role when you transport a patient. When you don't have a facility of mechanical thrombectomy. But wherever there is a possibility of mechanical thrombectomy and the patient fits into a criteria, today we are talking about large core, 24 hours, as long as there is no bleed, we believe that this is the way to go. And this is the way every hospital and our country should work. So once again, Dr. Rao, my apologies. I did not come to hang you this morning. This was a job that Dr. Shiva asked me to do, and I just did it. But the bottom line, truthfully, we evolve. We evolve as we learn and we understand more. And one of the things that we learned in the last 10 years is we have come a long way. And today, mechanical thrombectomy is the cornerstone treatment in the management of ischemic strokes. Thank you so much. And like I said, once again, patient care is not one man's decision. Patient care is a consensus of multiple like-minded people working together for the better good of the patient. Thank you.
May I request Satyarao sir to please come and ask one question to Matthew sir, and Matthew sir will ask one question to you later. So as a theme of the battle, for one question sir. Matthew sir.
There is no battle
Matthew
for
sir,
us.
can you come to the podium for that one question?
There is no battle for us. I just accept what we have done. I have expressed my experience and my studies, and he expressed his studies, and both of them, we are coinciding with each other. At least in thrombolysis, and he is not fit for thrombolysis, thrombectomy. He says the thrombectomy because he faces that situation and the availability of the facilities and the fitness of the patient for the thrombectomy. He said, yes, he is right for that. When the patient is fit for thrombolysis, when he is not fit for thrombectomy, I do my work. Yeah, I am just fitting into my shoes. So there is no question to be asked to the other speaker. We accept each other, I think.
So, in Dr. Dalai, there's no question. In India, you have to have thrombolysis. Not everybody can afford 5 lakhs treatment. And we can't tell the patient because you don't have a 5 lakhs treatment. So Dr. Rao, in India, you have a bit, I think we should focus a little bit on the socio-economic burden of mechanical thrombectomy in India. And that's not a question. That is your cornerstone. Till we have a system where the government takes place to everybody, thrombolysis, which is more 10% the cost of stroke therapy, cannot be removed. Because in a studies from China coming, probably it's not as bad as we thought. So with appropriate imaging, it actually shows it's just a small thrombus burden. I understand supporting you. They're going against Shiva's policy. But
So-
definitely in India, I think we still have a role because it's a lot more cost effective. The big challenge in India is we need to see patients fast. So I truly believe the government of India should invest more on mobile stroke units where we can get a patient in an earlier window, which could make a big difference. I mean, that's the suggestion I could give. And I think Andhra government has been looking. Tamil Nadu government, though we got the first stroke unit 7 years back, first in Asia, got it working and running, we actually had to shut it down purely because it's not easy to have a fight on the road. There is a debate, battleground. Seriously. The battleground, who pays for the thrombectomy place?
So unfortunately, the warriors have become friends, so there is no battle. They go for a holiday together because there is no more war here. So let me take you far away for a holiday. So thank you so much, both of you. Any question from our chairperson or audience? Anas, please.
To Manas,
Anas, I will ask a difficult question.
It's working.
Yeah, it's working.
Yeah. I have a question to both of you. What do you do when a patient is not fit for his coming time, not fit for thrombectomy or mechanical, either or thrombolysis? Like,
So Manas, define not fit. Why is he not fit? I did a local anesthesia.
no. If a patient, like in hospital setup, somebody has either brain surgery or a femoral neck fracture surgery,
All of them are
had a
fit.
stroke on the same night, and what do you do? Because
So
you cannot
Manas-
give thrombolysis within 24 hours.
So fact is, all these patients, yeah, I can understand about thrombolysis. Immediate post-op, you don't want to thrombolyze. But for mechanical thrombectomy, nobody is not fit. The only thing not fit today is you can't pay any money. Other than that, it's a local anesthesia procedure. It doesn't really increase the risk to the patient in any form. But the problem we have is the patient, like you said, he had a surgery the night before and now we can't lyse him. But they're all candidates for mechanical thrombectomy. We have done mechanical thrombectomy without even heparin. So
And is it safe to give Carotid?
very, very safe. It's not at all difficult.
The surgeons may not.
All we need is some
accept
terrible
that
contrast.
To have intra bleed and all those.
I think it's all about risk versus benefit. I think that a large, see, a patient with a M1 occlusion or an ICAD occlusion, what are you going to do? The whole hemisphere is going to infarct. I mean, then it's going to be really worse right now. So I really don't think for mechanical thrombectomy there is any great contraindication except a patient who's already got a hemorrhage. Other than, or like a hemorrhagic infarct. Or other than that, theoretically, or a very complex neck anatomy with a very, very hostile, those also we circumvent by doing a direct electric position. So actually there is hardly, when a patient is sick, the family are willing to take the risk because without it it's worse.
Any indication where you feel that technically thrombectomy is not possible? The patient is
Yeah, so the thing, the only place where I can think of is a very hostile neck, Other than that, or a patient who is so uncooperative and the anesthetist refuses to give anesthesia. Like somebody who's tossing, turning all the time. But I have never seen that happen in a hospital. I have never cancelled a case in a hospital because he's not fit.
Yeah, means you have a lot of experience with neck anatomy being normal, you can do it, but not that every intervention you
No, that is a different matter. That is the technical expertise of that person. When you're talking about contraindication, no contraindication, there are more contraindications for thrombolysis than for mechanical thrombectomy.
I'm not talking for thrombolysis, but I'm talking for acute thrombectomy, surgical thrombectomy, which a lot of papers have come in acute setting. People who are not fit for either thrombolysis or mechanical thrombectomy endovascularly, then we do not suggest a surgical thrombectomy. So
I think-
why you are against surgical thrombectomy?
I think the answer is there in your question. As you said, as you asked the question to Matthew sir, that not everybody is competent to navigate through those tortuosities. Not every surgeon is competent to do mechanical thrombectomy like you
It's
said.
not true. It's not true. So this is a
No, one second.
Please give a mic to Basant sir.
Are you talking about surgical thrombectomy? Is it?
Yes.
Yeah,
So the third option is we don't offer to the patient and we just let the patient go.
How do you do that? I mean, just for
We just do a small craniotomy, open the
Vasan sir,
MCA.
please take the mic here.
yeah, maybe.
Very nice. I think this is much more important than the next session, which is much less percentage. These were complications of endovascular treatment.
Huh.
You know, the catheter getting stuck,
Yeah,
the patient getting in a
And we had nothing else at that time to offer.
Sorry?
No, we had nothing to offer.
Yeah,
We
so
didn't
the
have a
patient
good
had already, I mean, endovascular treatment. Of course, the material had changed, the expertise has improved. So there's a lot of, I'm talking of, I mean, something which is dinosaur age.
Yeah.
But 87, we did, and we talked about it, we published it, MCA embolectomy, ICA embolectomy, I still remember Dr. Rao had done it, and the patient developed a stroke because the MCA one patient got blocked, and ICA they could not retrieve the catheter, and both these cases we had not great improvement that they became normal, but they had some recirculation. So that's the point there. But it's much more risky, I mean, there's no question about it. Of course, if you can do a mechanical thrombectomy endovascularly, I mean, that's the way to go. I think surgical is very, very much more, you know.
No, I think Dr. Manas, surgical thrombectomy should be the last resort if nothing else is
So,
possible.
only my point, I'm not promoting surgical thrombectomy. What I'm telling is cases which are not fit, and especially in the hospital.
I mean, what you're saying, that is also a possibility.
It should be offered, and people came last month from China. They have done 52 cases, and they had 70% good results. And
I mean, I think I never knew it. I don't think I don't know if anybody in my
We also
hospital can
operated,
do emergency
Carotid.
surgical thrombectomy.
A patient had a stent, and then the stent got stuck, so we had to do an emergency carotid and had to remove the mechanically we had to take out the stent because the stent didn't open fully because they suspect. So thrombectomy is coming up now acute, and especially it's more important in countries like India where facility for shifting the patient is not there and facility for endovascular mechanical thrombectomy is not available at every nook and corner.
Honest, but I have to accept what Shiva said is true. I think it is more easier today to find an interventional radiologist or a neurologist or a neurosurgeon who does this procedure than a neurosurgeon capable of doing an intracranial MCA thrombectomy. I think that is going to be a lot more difficult.
I don't agree with that. There are a lot of neurosurgeons and they can be trained to do at every district hospital mechanical thrombectomy. Then having a facility of
Perfect. That's a wonderful discussion. So we just close it here. If there's any questions.
So everything depends upon the availability of the financial status, so patient's acceptability, adaptability and availability of the surgeons and the interventional radiologist. If everything does well, thrombolysis doesn't work and the patient is fitting for thrombectomy, yes. Otherwise, surgical, anything between them to discuss and get it done. That is the only way. Only thing is the financial status of the patient, the support by the government, which is needed, as we said. We need it. We need it. If these things are there, we can progress fast. Thank you.
So great time ahead for stroke treatment. We have neurologists who are capable of doing it, interventionalists who are capable of doing it, as well as surgeons are coming in. So thank you so much. Do we have some momentum?
Hello?
So I would request Dr. Shubhendra Dalai sir to present a small token of appreciation, a memento to both our speakers, Dr. Satyarao sir and Dr. Mathu Cherin sir. I would request our chairpersons, Dr. Rajesh sir and Dr. Dalai sir to present a memento to Dr. Mathu Cherin sir. Thank you for your time and inspirational insights. This is a symbol of our appreciation and gratitude, sir. I would request our chairpersons, Dr. Triveni Reddy ma'am, Dr. Sailesh Modi sir, and Mitali Kar ma'am to present a token of appreciation to Dr. K. Satyarao sir. I would request Dr. Dalai sir to present mementos for our chairpersons on the first battle of acute ischemic stroke. Dr. Sailesh Modi sir. Dr. Triveni Reddy ma'am. Thank you for your time. Dr. Mitali ma'am. Thank you so much, sir. So let us move on to the second battle. Are you ready? So brace yourself for the second battle on intracranial aneurysms. The neurosurgical clipping versus endovascular management. So the clash of titan continues with the scalpel versus stent, open corridors or endovascular elegance. A debate that continues to shape the aneurysm management globally. So first I would like to call upon to the dais, the chairpersons for intracranial aneurysms. Dr. K. Satyavaraprasad sir, kindly come on to the dais. Dr. Lakshman Rao sir. Ladies and gentlemen, please give a round of applause for our chairpersons. We welcome you, warm greetings. Dr. Rashmi Sharaf ma'am. Dr. T. Suresh sir. And Dr. A. Mohan Rao sir, kindly come on to the dais for our second battle, intracranial aneurysms, neurosurgical clipping versus endovascular management. So I would like to call upon our speakers, our legends for the second battle. So for the neurosurgical clipping, we would like to invite our renowned expertise, Dr. Basant Kumar Mishra, the head of Department of Surgery, Section Head for Neurosurgery and Gamma Knife, PD Hinduja Hospital and Medical Research Center, Mumbai. With his vast experience and expertise, Dr. Mishra will share his valuable insights on neurosurgical clipping. And let us call our second speaker today. We are honored to have the master of minimally invasive procedure, renowned expertise, the endovascular management, Dr. Gaurav Goel, Director and Head Neurointervention Surgery, Medanta Institute of Neurosciences, Gurgaon. Kindly join us for this discussion today. Speakers on the corner for the battle. And the chairpersons can shoot the questions to them.
Good morning. Very little time and very notorious. Is there a timer somewhere? No. Then you have to warn me before 5 minutes or something, so otherwise it will be difficult. Yeah, thank you, Dr. Dalai, for this invitation. I think I learned a lot more than what I'm going to let you learn from this talk. Much more important is ischemic stroke is much higher incidence, and hemorrhagic stroke is about 1/3, and subarachnoid hemorrhage aneurysm is about 5 to 10% of it. But let me share with you some of our ideas. I have no conflict of interest. Now first, what is the evidence? Aneurysm, the paradigm shift is significant. After the ICAD study, these 1-year results were better. The morbidity was better in the endovascular, but not at 5 and 10 years. That changed the paradigm completely. Aneurysmal treatment became endovascular all over the world because of this ICAD study in 2002. The problem was ICAD took a very select group of patients, small aneurysms, anterior circulation. But it was, kind of added to all because of the industry, I think, tremendous industry influence. And all aneurysms had thought as ICAD aneurysms, which are not true. And the next major study was the double-blind trial with the BRAT, the special group in the United States. Up to 10 years, there was no difference any time point between endovascular treatment and microsurgery of aneurysms. The Chinese study, Lee, there was no difference. And the more recent study from Swedish prospective cohort actually showed the microsurgery of aneurysms were better than endovascular treatment. Now this 10-year study of BRAC, this Phoenix Special Group 2019, it was published in one of the most major neurosurgery journals. As you can see, 1/3 patients which were in the endovascular realm has to be crossed over to because they could not be such treated. Retreatment rate was much higher in the endovascular group, and the complete obliteration rate was much less, significantly less in the endovascular. And this is from one of the best centers in the world in the United States, not from Timbuktu. So just to give you an example, more recent, this was in 2023. This was a gentleman, Indian origin, who was in US, had a subarachnoid hemorrhage, and called one of the referral center of vascular center in the United States. Aneurysm was coiled, and within 1 year, he had a recurrence of the aneurysm. So this is the real world. Unfortunately, in India, there is no audit. The patients do not have any money to go back for any further treatment, and they have a false sense of security once one endovascular treatment has been done. It's good, but it has to be followed up. And you see, this is the aneurysm. I don't think there are many young neurosurgeons who will learn from this. But this is what can be done, and this was the aneurysm, that was the aneurysm. Now while doing it, still, you see, this is still, in spite of the coils, this is still prone to rupture because the part of the fundus is still open, so we clipped it. And that was taken care of. But this was still a complex aneurysm because the coils were part of the aneurysms were by the coil. So we had different maneuvers we had to do to have a complete occlusion. And this is the real world. Many aneurysms which are endovascularly treated do regrow, and they have to be followed up for life, which is unfortunately not done. And this is 2024 national cohort study from a Scandinavian country. And the microsurgery was preferred for MC aneurysm and all Fisher grade flow, that is high-grade subarachnoid hemorrhage. Treatment modality was not associated with any outcome measure. Whether endovascular or microsurgery did not change the outcome. What changed? The poor grade of the subarachnoid hemorrhage patient, the higher age group, and patient had a ischemic neurologic deficit. That was the determinant for worse outcome. Now this is another one again, 2024. At 6 months, only age, admission score remained significant predictors of the outcome, whether you do endovascular or microsurgery in aneurysms, subarachnoid hemorrhage. This is an older study from China. Again, you see the clipping versus coiling. The outcome was favored in clips, long term, and this is mortality, no difference. And this is another study, long-term study, again I think it was in 2024. Re-rupture of target aneurysms are more common after coiling and should be considered in the pre-therapeutic decision-making process. Now this is 2024 again, you see that it's much better in clipping than coiling, the long-term rupture rates, and the clipping versus microsurgical, coiling versus microsurgical clipping in MCA artery. You see the complete obliteration rate is much, much higher. So in MCA aneurysm, actually there is no doubt. Even in ICAD, the MCA aneurysm study showed, even in elderly people, in MCA aneurysms, the microsurgery group did better. The one study which changed the paradigm of the treatment of aneurysms. And this is 2025. Now this is JNS, this year. The surgical clipping should be considered the primary approach for unruptured MCA aneurysm. Many centers across India, unfortunately, still give the primary treatment protocol to patients who come with an MCA aneurysm as endovascular treatment, unfortunately. Now this is the further, to go to the details of this, the complete occlusion rate significantly favored clip, this is MCA aneurysms. The clinical outcomes significantly favors clip. And complications, again, much worse in the endovascular arm than all statistically significant. This is this year's study. So there's no question that microsurgery of aneurysms is more definitive, more durable. There is a higher procedure-related morbidity, and that's a fact. So if you can change that, then microsurgery of aneurysm is going to stay. Now for that, the neurosurgeon has to be properly trained. I think one of the ways to do it is to have centralized aneurysm treatment. Unfortunately true, and it's not available in India. Everybody tries to do everything, so that's the problem. You have the wide opening of the sylvian fissure, avoid retraction as much as possible, and sometimes even with the best advances of the endovascular arm, you still need this procedure, which is called a revasculation. This is a patient with a high flow bypass, and you need to sometime occlude the parietal artery, and to have a recirculation, you need a high flow bypass so that the patient doesn't have ischemic insult. And paradoxically, at least in my practice, we much more skull-based approaches we do to avoid retraction in the brain, so drill out bone and reach the aneurysm without retracting the brain. Unlike in tumors, skull-based tumor, where we do less and less skull-based dedicated approaches, we are doing more and more skull-based approaches to get that few millimeter of extra space to avoid retraction and to reduce the morbidity, because the retraction, contusion injury in the brain is the main cause of morbidity post-op. So I'll give you some examples where, in spite of the best advances in endovascular arm, we still have patients who cannot be such treated. Now this is a wide-necked proximal ICA, superior hypophyseal aneurysm, failed endovascular treatment. Of course, this was some years back, so the newer techniques of the flow diverters were not available. And so this is what was treated with what is called the Dallas technique. So suck it out from the neck. We had a control in the ICA. You can see this collapsing. The critical thing is we need to see that the aneurysm is completely occluded, and that is where we can score. The microsurgery can score on an endovascular arm. So we do the ICG, which is the more recent last 10 years or 15 years advanced. And once we do see that, and we see that there is some residual aneurysm, so we have to refashion our clips, and we have a complete occlusion. There is no residual aneurysm. And this is aneurysm cure for life. This is treatment which is for life. Once you have opened the aneurysm, you have demonstrated that aneurysm is not open anymore, it remains closed. Because the clips are outside the aneurysm, it closes it. All endovascular devices, coils, flow diverters, your endosaccular devices, are going from inside. So there is always a potent area for revasculation which is not there for aneurysm which are clipped from outside, or you have occlusion of the parietal artery and the bypass. Then an aneurysm like this is a lady who presented in coma, bilateral MCA aneurysm. This aneurysm had ruptured, large clot, small circulating component, all vessels are coming out from this. Extremely difficult for any endovascular treatment. Patient was very sick in coma, but we operated, evacuated the clot, did the clipping, and then after 6 months, patient of course left with hemiparesis on the left side, but otherwise functional, and we did the left MCA aneurysm. So he said both MCA, complex aneurysm could be clipped. Now this is an aneurysm, multiple aneurysm in another center, had endovascular treatment from the ruptured MCA aneurysm. Now within a year, this aneurysm regrew, and then this patient, of course, she had not ruptured again, but she was on follow-up imaging that was there, and she came back to us for definitive treatment, which we did. Now the patient had already coils inside. The clipping is a little different than the usual clipping. The usual clipping, we tried to put a clip at the neck if possible. Now in this particular case, we can't do that because the coils are sitting at the neck, and part of the neck with the clip doesn't take. So we have to have a little bit of maneuvering there. We put a fenestrated clip so that part of the fenestration, the coils which are sitting on the neck are in this fenestration. But there is another problem because the coils go into different compartments. So even after the clipping with taking care of the main part of the aneurysm which was circulating, there was another nipple-like projection which was still patent, and so we put a mini clip through the fenestration, so we have a complete occlusion again with a definitive cure for life. Now this is another gentleman, young man who had subarachnoid, ICH, intracerebral hematoma, went into coma. This is from Kerala, and he had a decompressive craniectomy, survived, and was sent for definitive treatment to us. The whole right ICA was diseased. This is the biggest aneurysm I have, the 8 centimeter aneurysm. He also had an unruptured basilar top. So we advised treatment. He wanted a bypass, open up the aneurysm. He ran away, not unusual in our country, to come back after 1 year with progressive hemiparesis and severe headache. So when we did, we opened up the aneurysm in the metafossa, decompressed it, and put a radial artery high flow graft from PCA to M2, and then sent for endovascular treatment. Failed again because PCA could not be separated out. So we went back and coiled again. This is after both the treatments, after a gap of about 3 to 6 months, I think, after the first treatment. Before the discharge, after the second surgery, the bypass for the ICA, clipping of the basilar top, and that's the patient before discharge from the hospital. Now this is a more recent patient, a gentleman who had post-traumatic severe epistaxis, repeated, because he had a pseudoaneurysm from ICA which was bulging into the sphenoid sinus, and this was, patient came, he was blind on the right eye, he had left hemiparesis, he was obtended. So I was very kind of worried to do some microsurgery in a sick patient, so we asked our endovascular colleague to take care of this, very, very eminent endovascular colleague from Mumbai. He tried everything, he sent back the patient to me, he said, can't do it, because there is a fracture segment lying in the wall of the aneurysm. And he said, if I put a flow diverter, the artery may give way, so you have to do something else. So we did a bypass, again, same thing, high flow bypass. The only difference in a pseudoaneurysm like this is when you do a bypass for a cavernous giant aneurysm, you just need to ligate the carotid ICA in the neck and you do the bypass, that's enough. For a pseudoaneurysm, you do the bypass, which we did, and, we do the bypass, which we did, and then you need to still go and tap the aneurysm. You need to ligate carotid in the neck. You also need to put a clip in the intracranial carotid proximal to the ophthalmic aneurysm so that the high flow bypass, that's the trying to drill the anteroclinoid there, and once we did the anteroclinoid, we put a clip proximal to the ophthalmic artery so that we trap the ICA segment between the neck and intracranially proximal to the ICA. That's a clip there, so that the blood from the high flow bypass doesn't go into the pseudoaneurysm. These have no walls, so they can bleed again. And that was the, this in fact, I was surprised when we reviewed the literature, there was no case reported for a pseudoaneurysm with a high flow bypass from a post-traumatic pseudoaneurysm. So this was a short report from neurology India. This is another patient, subarachnoid hemorrhage, fusiform aneurysm of the left ICA, failed endovascular treatment because both the PCOM and anteroparietal critical artery was inside the aneurysm segment, and so we went on to treat it again, a more recent case, but this is a different type of clipping. Normally when you put fenestrated clips, the clip blades are parallel to the parent artery. Here, the clip blades are perpendicular to the parent artery. The fenestration take the carotid. And why is that? Because between the clips, we want the patent normal vessels like the PCOM and the anterocorridal. And I just want to show you for people who are vascular people who are here who understand the configuration of the clips is a little different than the usual fenestrated clips we put it. Today we have this adjunct of ICD, fluorescent angiography, and this is a disease artery. So we put some cotton, we put some glue there to reduce recurrence. You see the blades are all perpendicular to the parent artery. Normally it is parallel, the normal course type of aneurysm treatment we do with fenestrated artery, and that's the full stop. Now this is yet another case where endovascular cannot be done in spite of all the advances. This is a patient with myomed disease who presented with a subarachnoid hemorrhage because the adult myomed have aneurysm, pseudoaneurysm, they develop there because of the collateral vessel, and this patient presented with subarachnoid hemorrhage and P1, P2 aneurysm, also had myomed disease and IC occlusion both sides. So we clipped that artery and we did a STNC, superficial temporal middle cerebral artery anastomosis in the same setting. Again, not possible in endovascular arm today. Presenting with this schema, very unusual. This is a lady who presented to our neurologist with infarct, and fortunately they did an angiogram which showed a very small circulating component of M4, very distal MCA, the last kind of distal MCA. There was a clot inside that, and we opened it up. Temporary clip, we leave one vessel so that some part of circulation is going on. We open that, we took out the clot, and we do inside to what is called bypass, that close the artery with tenor sutures so that some circulation is continuous to the patient's probably is penumbra, you talk about it, that can be helped. And interestingly, patient got admitted, this was about 15 years back. Came back yesterday with head injury, we did an angiogram, there was no occlusion anywhere, the vessels were all intact. Now this is yet another patient, again this gentleman in his late 60s who had this small circulating aneurysm with a large infarct, and at opening you see the MCA bifurcation, huge aneurysm. From those calcified, we opened it up, took out the clot, something like an endarterectomy and clipped it. Again, cannot be treated by endovascular means. Some other again, this is a gentleman, with all his vessels were diseased. The right ICA, the left ICA, the posterior circulation, everything was diseased. We call it pan-dolichocephalic arteries. Now what do you do treatments? The patient came with progressive visual compromise, more on the right side. We didn't know what is the best way to do it, and this is the customs in charge in Mumbai. Be careful when you come back. I travel a lot, you will catch me. So we sat on him for some time, till he forced us to do something. After a year, we did the same thing, high flow bypass. ECA to M2, ligated to carotid in the neck. Problem is, this is only buying some time. We followed it up for about a couple of years. After that, he lost to follow. He's probably dead from this disease. But we bought some time. The vision got stabilized for some time till the time he was following with us. Now, this is the standard of care, proximal ICA unruptured aneurysm. Standard of care all over the world today is endovascular treatment. Rightly so. I think this is less invasive, and that's the way to go. Unfortunately, the problems are never reported. And this is one such patient from Mumbai. The endovascular treatment very well taken care of, flow diverters. 3 months down the line, visual compromise, progressive visual compromise on the left side and right side, became blind. In spite of steroids and all the treatment they have, they don't do anything, the patient remains blind. Another patient, ACOM aneurysm, similar problem, worsening of the vision. Nothing can be done about it. Yet another patient, giant ICA proximal aneurysm, unruptured. He came with one vision compromise and multiple flow diverter, multiple sitting, went back after some few months, hemiplegic bed bound, not reported. Now this is more recent patient from Mumbai, a 62-year-old gentleman, 2019, has visual compromise on the right side. This ICA proximal aneurysm, this is the circulating component, it's actually much bigger aneurysm. So they put a flow diverter. After 2 months, they became blind on the right end. And then they started losing vision on the left eye, so they put another flow diverter. So became blind after some months, both eyes, he became blind. And then, this was 2020, 2022, I think it was 2022, he presented with epistaxis. The aneurysm circulating component is very, very small. There is hardly anything, but there is a large mass there, which is not unusual. The aneurysm kept growing because there is some circulation going inside. And now he is present with epistaxis, blind both eyes and presenting with epistaxis. And he was sent to another endovascular, very experienced, who said, no more, we can't do anything more. So he called me up, he said, Basant, can you do an emergency? Because he may be dying from hemorrhage. So we did an emergency against everything, ECA, M2, high flow radial bypass graft. Of course, he remains blind. He subsequently developed hydrocephalus, so we did a shunt. Now he's functional but blind. And this was reported in JNS, I think last year or maybe 2022. Yeah. So lessons, flow diabetes is very good, but not without risk, unfortunately, not reported and not if at all. So if there is a large giant aneurysm in the anterior circulation with visual compromise, if you are competent, I think it's better to decompress, and that's what is done here. Clipping, we would send him for endovascular treatment, and this was done. We did a protective bypass. The time taken for aneurysmography takes time to avoid ischemia, and that's what we do. Now this is a young, in his teens, distal ICA aneurysm, failed endovascular treatment, and unruptured one. So we did the clipping. Again, it's a little difficult. The aneurysm is very thick, so no clip would sit there. So we are, with a bayonet forceps, we are trying to hold the neck so that we can apply clip. This is standard way of putting fenestrated clips. So parallel to the parent artery, multiple clips, first proximal to distal, then distal to proximal, trying to occlude the aneurysm. It's a huge aneurysm, and they are perforated. The anterocoronary is at risk. The perforators are at risk. So in spite of all our efforts, we had at the ICE small circulating component. We left it, and that's the advantage of having another technology we have, because that can be treated. We started off with this, we ended off with this one, which was sent to our endovascular clinic for coiling, which is much easier now. And this is another very dramatic child, 2.5 years, with heavily thrombosed, calcified, basilar-top aneurysm. About 13, 14 years back, he came to us, obtunded, hydrocephalus, not hydrocephalus, we did a shunt, child became asymptomatic. This is a huge aneurysm, heavily calcified, basilar-top, one of the most difficult cases. So we asked our endovascular colleague to take care of it. As I said, it is 14 or 15 years back. So the technology at that time was coils, which was done nicely. 17 coils, the aneurysm was totally occluded. And for 48 hours, we were all very happy. And then patient started deteriorating. We did a CT scan, shunt was working. The patient went on a ventilator. His father was a pharmacist, so we talked to him, very high risk, and took him for this the skull-base approach, OG, people, neurosurgeons would understand that, extradural aneurectomy, very, very extensive surgery, without opening the aneurysm, which is much easier there. And then the ICG, and this is the immediate post-CT, and this is the DSA, and this is 3 months he had a partial third nerve palsy which completely improved. 3 months follow-up in my clinic. So the old-fashioned clipping, a disappearing art, unfortunately, can include most aneurysms. And this is the last resort one had. I haven't done it for the last 15 years. This last child from Bangladesh, the basilar top with all vessels coming out from the top, which we did a hypothermic cardiac arrest. The patient came in altered sensorium and a child. She remained altered sensorium, but she's communicating with parents. She's swallowing. They sent me an email about his condition. So my final slides. To my mind, the current indication for this presentation is not an attempt to condemn endovascular treatment. Endovascular treatment has saved countless lives, and it's an advance. There's no question about it. But it's a call for balance, recalibration of clinical equipoise, preservation of a complete and robust therapy. Aneurysm treatment is a robust therapy. It's a complete therapy. Please don't dump it. Environment of co-evolution and then competition may be the better way to go. And for intracranial aneurysms is definitely better, and the evidence is there for MC aneurysms. Preferable, more definitive and durable for anterocirculation aneurysm if you are competent. And giant aneurysms, it's equivocal. Individual expertise will decide whether posterior circulation aneurysm should clip or coil. Finally, I'm very thankful to Dr. Dalai. He has put in slide. Please join us. Young neurosurgeons, we are taking care of 100 young neurosurgeons. This probably the last meeting. Professor Sami, neurosurgeons who know his name, he told this will be my first international meeting, last international meeting I'm going to Basan. So please join. You may not have a chance to listen to him again. And Professor Chen Spexler, who is the doyen of vascular neurosurgery, a giant, is one of the pioneers, and he's coming as the honored guest. Thank you very much for your attention.
Thank you, Dr. Mishra, sir, for an outstanding presentation that shed light on the complex
penetration rate, of course, was very low with the endovascular group because only 30% of the patients had a follow-up. So you are looking at a very small number of patients and trying to decipher data coming out of it. Now, we have one ICAD 2, which was started in 2012 and recruited for 10 years. The plan was to recruit around 1,800 patients. In 10 years, they could hardly recruit 200 patients. So that's the reality of life now. Patients do not want to be randomized for coiling and clipping. And most of these centers, they struggle to randomize patients, and the trial has to be concluded or terminated prematurely because there were no enough patients. After 10 years, the investigator said, enough is enough, we can't get more patients. So they published the data based on what they had, and the significant differences were more MCA aneurysms were part of this ICAD 2 as compared with ICAD 1. Larger aneurysms were part of it, more poor grade patients were part of it. And even if you look at it, the absolute difference was 6%. If you look at MRS 0 to 1, the absolute difference is 3%. So, as compared with the ICAD, that was 8%. So, it was not statistically significant, but overall it was not powered to that. But if you look at the mean length of hospital stay, EVD, shunts, symptomatic spasm, everything is more in favor of coiling, and the de-gating rates were similar, failed retreatments were similar, and if you look at the angiographic outcomes, yes, the coiling will have more recanalizations as compared to clipping. I think that is a given thing now. And retreatments were in both groups, not only in coiling, 22 in coiling and 10 in clipping groups. So to conclude, they found that despite not having the power, the outcome didn't show any significant differences. And less chance of vasospasm, much shorter length of stay, fewer EVD than shunt, and angiographic vernier outcomes were better with clipping. But re-bleeding rates are same, and anyway the numbers and follow-up length was too small, so much not has changed from ICAD 1 to ICAD 2. But what also we learned is the frequency of spasm is less with coiling, delayed retreatment rates, frequency of seizures, long-term bleeding risk, and 10 years outcomes and quality of life. This is all better when you do coiling. So a lot of data around that which shows, which compares the chances of spasm between ICAD 1 and 2, showing that chances of spasm is less with coiling, chances of seizures is less with coiling, and that is, if you are doing more of MCA aneurysm clipping, the chances of seizure goes up as compared with coiling. So, and these are also important considerations to take into account when you make these decisions. So retreatments, yes, they are far more common with coiling, but retreatment does not mean deterioration of the patient. So there is no change in the ranking scope for these patients. The quality of life, which is what we eventually want. So if you look at the ICAD data, 18 years, the chances of a patient alive with a favorable ranking score is higher in coiling group as compared with clipping group. And that, I think, with cognitive impairments, it becomes difficult to sustain life. So quality of life index also needs to be taken into account. So lot we can discuss about the ICAD and GRAD, about the numbers, the functional outcomes, retreatment rate, recanalization rate, but eventually the re-bleeding rates in both of them is remarkably low. Even in GRAD, there were just 2 patients who re-bleed from the coiling arm in 10 years' time. So that's a remarkable achievement. But what we also need to remember is when these trials were done, in 94 and 2002, and let me take you back into the memory lane, this is what we were using in 94s. Okay, remember the computers, what we have, floppy disks forgotten. So that was the era these trials were started. This was the first cellular phone. And the internet speed was in kbps, not in GBs. And when the BRAD was done, these were the smartphones and few of the devices which we don't use now. So similarly, we had in the endovascular arm the devices which were first generation when the ICAD came, and even with BRAD, a lot of hardware was in the preliminary stage. very difficult sometimes to do complex challenging cases where you cannot take your guiding curve, you cannot cross them, you do not have adequate stents or flow diverters to work with. And then came the explosion of technology. So now we have everything, and it keeps changing every 3 months and 6 months. And now with the AI being the buzzword, it is actually guiding you where to park your catheter, are you touching too much inside the Aneurysm, how much coils to pack. People are now doing remote procedures. So the first transatlantic stroke therapy was done last week, and more and more patients can actually get the benefit of the best of the hands doing an AI or robotic interventions. So few of the microcatheters and microguide wires are super soft now. They are very torqueable. So and there are not a lot of endovascular people in the room. So, but the idea is we can go as high up as we want. And some of the times earlier we will have rupture of the aneurysms because we are dealing with the neck tortuosities. Today we park our catheters sometimes so close to the aneurysm that you actually don't need a microcatheter to coil the aneurysm. The coils have changed significantly. We have now 3D coils, nano coils, the detachment systems have become faster, very much effective, and you are able to treat very small aneurysms very distally with a lot of precision and confidence. So we have now small 1 millimeter coils also, which you can safely put inside the aneurysm. So earlier all these very small aneurysms where the ICAD and were concluded were impossible to even think of coil. Distal access going to deep within the pica territory to occlude the aneurysms, or even for moya aneurysms, we can have catheters which can navigate very distally to occlude these aneurysms. So one patient of moya, you can see a perforated artery pseudoaneurysm. You can go up, use a liquid embolic to occlude the aneurysm and secure the inside. So for vasospasm, we have drugs now to dilate, see the aneurysm better, and do the complex endovascular planning. In fact, the rescue treatment for vasospasm has to be done whether we are doing coiling or clipping, because it's very important that the patient should not die of these deficits. So from the early 90s, where we were using only balloons, and those were single lumen balloons, now we have double lumen balloons. That means they are far more flexible, you can exchange, and the usage of balloon has jumped significantly high. So in ICAD 2, if you see, more than 83% of balloon usage was seen. And that has also been our practice when we were doing coiling 15, 17 years ago. The balloon usage was 15-20% because it was difficult to take these balloons up. These days, you can take the balloon very distally, you can navigate, over-inflate confidently around the aneurysm, you can do double balloon if the branches are incorporated, and even unthinkable things like cracking the balloons into small PCOMs at an acute angle, which were not possible before, is now possible. So I think it has been a great game changer the way the balloons have evolved in the last 7-8 years, and that has made the life really simple and it protects from re-rupture. So few of the examples where you can come across the ACOM to secure the neck of the aneurysm. You can swirl these balloons inside the aneurysm, so they are not very hard balloons or super soft balloons which you can use to do that. So the technology has moved in every front, even for stents, for these dysplastic aneurysms which we were treating with stent and coil, and they were difficult to see. From there to now, to look at these small aneurysms, very shallow aneurysms at ACOM, you can treat them by using 2 stents, using a wise stent for configuration, and you can get a good result around that. So that's a follow-up of that. And we have moved away from laser cut stents now to braided stents, which are far more visible. You don't need to do 2 stents now. You can shelf it, which means you can just push and lean on the stent, so it creates a shelf around and it can tackle the wide neck aneurysm in a much better fashion, and you can get a good occlusion there. So whether it's an ACOM, wide neck MCA, so shelving using these braided stents have become a standard of care. And what is also more important is the compatibility of the hardware. So you can put these stents through balloon. So sometimes we start a case thinking we can do a balloon coil. If the coil loop starts collapsing, We are not in a soup anymore. We can use the same balloon, deploy the stent, and secure the aneurysm inside. So multiple things, as I said, our understanding, the technology has evolved, and as I was trying to show with balloon, these devices are so soft, you can cross easily from ACOM, PCOM, and try to achieve what was unthinkable and unachievable when these trials were conceived. So we are now using complex words like T-stenting, where we place 2 kissing stents to secure these wide neck PCOM aneurysms, where you leave a small residual or you need to put a flow diversion which you want to avoid at acute phase. You can do again a T-stenting, put 2 stents to preserve the arteries and put coils across. And what these stents also does is they have mini flow diversion effect. So even if you leave a small residue behind, progressively it will lead to the occlusion. So here we have left a small bit of residual aneurysm, but there is a braided stent. We know it's a mini flow diversion effect, and in follow-up you can see the complete obliteration of these aneurysms. So many such patients where you may achieve a 90% or 95% good outcome angiographically, and when you follow these patients up, you will find that the stents have done a progressive occlusion to lead to a complete 100% occlusion. And then of course we have flow diversion, which has really expanded and changed the way how we used to think about difficult aneurysms. So from blister aneurysm, where bypass used to be the key, flow diversion has completely taken over. We have published our data a few years back. There are a lot of trials around it. But these days, I think if you see a blood blister like aneurysm rupture, you put a flow diverter and it works with a very good success rate. So small aneurysms, blister aneurysms, I think the flow diverter is the key. So if you look at this ICAD terminus, very small aneurysms, they are ruptured, can be very easily treated with a flow diversion technology. So, and I think this is the way, I think it's no more debatable for these ultra small or blood blister aneurysms that flow diversion is going to be the key for that. Now, what about fusiform dissecting aneurysms, where I think a couple of years back, before the flow diversion, bypass was the only key. So this ruptured aneurysm, again, fusisaccular involving the M1 proximal region, was treated just with the flow diversion technology. So this is immediate, this is after a week, this is after a few months, and I think this is after a year. So this is 3 months, and this is 6 months. So we can have these progressive obliterations going on, and whenever we see such aneurysms with a broad neck incorporating the branch vessel, we know the aneurysms will go once you have placed a flow diverter, but it will be a slow obliteration. So we have to be patient, keep following this. But the chances of re-rupture from these aneurysms is very, very small, and we can safely keep following these patients. Basilar apex, dysplastic, just place of flow diverter, and in follow-up we can have complete obliteration of these aneurysms. For large secular aneurysms, again, same thing. We can pack it with a couple of coils and flow diverter, and so we can have good outcomes and results. For large secular aneurysms, again, as Dr. Mishra said, it's now becoming a standard of care to put a couple of coils and a flow diverter, and more often than not, you will have a good functional outcome. Yes, there will be few occasional random cases where you may have growth of these aneurysms and may require surgical bypass, but most of these aneurysms do very well after flow diversion required. What about branches coming out? And that's always a question. So look at this aneurysm with a PCOM and anterior parietal artery. PCOM was coiled, anterior parietal artery was treated with a flow diverter, and look at the way the anatomy has changed. The anterior parietal artery is now seems to be arising from the ICL follow-up, while it was arising from the middle of the aneurysm when we treated it. So I think there's not much more to it than what we see, and the flow diverter pre and post pictures looks very dramatic when done in a right fashion. And for most of the complex cases done with flow diversion, the time taken to treat them is very small now. So these days, all these standard strict approach, it takes no more than half an hour, 45 minutes to do these flow diversions. Recurrences, though looks odd after coiling, can be very easily managed by putting a flow diverter and can have good outcomes. So retreatment does not mean worsening of the patients. Yes, it's more cost prone, that's the problem. So couple of more cases of flow diversion, and flow diversion is not limited only to the ICAs now. We have small flow diverters which can go through those coiling microcatheters, which we are putting up in very distal location. So this was our first case which we did 7-8 years back of distal flow diversion. That's a 1-year follow-up. And now we are increasingly treating bifurcation aneurysms with flow diverter, such as this blister aneurysm at ACOM. And a few years back, surgical wrapping was the only option. But now you can easily put a flow diverter, come back after a few weeks or months, and you will have a good outcome with complete obliteration of these blister aneurysms. So again, similar looking case, we cover it. You may occasionally see a branch getting thinned out, which we are covering, but this is always taken care by the electrophysiological collaterals. So the angiographic outcome, we follow these patients. Another MCA looking, bad looking aneurysm. I think most of the centers will do clipping of this. So we treated with flow diverter twice, and the patient had a good obliteration there. We are pushing the envelope now. We are doing more and more awake flow diverters. In the United States, they have started a project of doing flow diversion in a daycare in selected group of patients. We are reaching distally into M3s and M4s, and increasingly treating these aneurysms also with flow diversion. So I think reach is not an issue. We can take our catheters as high as we want, as distal as we want. For these pica dissecting aneurysms, again treated with a flow diversion, with a good follow-up and good outcome. So I can show you multiple distal small things, but the idea is again that the reach is possible, the access is possible, and remodeling is possible. Now you may argue, okay, you can do it, not everybody can do it, but the beauty of flow diverters is it keeps evolving. We are now talking about indirect flow diversion, where you don't even need to enter these arteries. So for this pica aneurysm, you don't need to go into the pica. You can place a flow diverter into the vertebral artery, and because of the flow hemodynamic modification, when you come back and follow up, you see the aneurysm has resolved completely. So another patient, superior cerebral artery dissecting aneurysm, we can do a PVO, we can go inside into a flow diversion, or we can do an indirect flow diversion covering the superior cerebral artery, which is, mind you, very simple to do, can be done in a 15 minutes procedure to put a flow diversion for an indirect work, and that's the follow-up with the complete resolution of the aneurysm and flow modification. So what about these distal P3, P4 aneurysm? Two aneurysms, one direct, one indirect. Again, you get this, we tried BTO, we can't do a BTO, there is no collateral. So again, we treated it with a flow diverter. Direct one will go away immediately, the indirect will take a few months. So it's a 9-month follow-up and a year follow-up now. And the aneurysm is getting smaller and smaller and will get obliterated slowly. A complex ACOM with anterior choroidal artery, again treated with coils and some flow diversion technology to create the scaffolding and getting the cure. Again, like once we have put the flow diverter, the aneurysm may not disappear immediately. In fact, sometimes it starts to grow. So this is a lady in 2014, normal angiogram. Then she had an aneurysm, treated with flow diverter technology. And eventually at the first follow-up, actually the aneurysm started to grow. We just need to stop one of the antiplatelets, and then the aneurysm started to settle down. And that's what the literature and data shows, that you need to be patient when you are doing these flow diversion follow-ups. Sometimes the aneurysm obliteration rate takes time, and it can increase significantly from 5% to 95% and eventually to 100% if you are a patient enough to do. Okay, so intrasaccular, last bit about it, we have contour and wear. And if you don't want to give antiplatelets, you don't want to do these complex procedures, you want to do it faster, in a selected group of patients, I think it's a good choice. So this is one of those cases, multiple intracranial aneurysm, polycystic kidney disease, she needed transplant in a growing aneurysm. So long story short, we put an intrasaccular device and single shot procedure, no antiplatelets, patient underwent a kidney transplant, and that's the follow-up. So trifurcation of the ACOM, put an intracerebral device in one coil, get complete obliteration of the aneurysm and follow-ups. So I think the intracerebral device is really helping to avoid antiplatelets, and few of these patients now, like for this patient who needs to undergo for a liver transplant, residual ACOM aneurysm and complete hepatorenal syndrome, pulmonary syndrome, we cannot give a general anesthesia. So in a awake patient, doing contour coils, securing the aneurysm, and sending these patients for liver transplant. Small aneurysms, large aneurysms, all of them can be treated easily with these intracerebral devices with good complete obliteration, multiple aneurysms. In fact, if you do get a hyperacute emergency like a rupture aneurysm on table, you can just deploy these devices and you can get a complete cure and control of the aneurysm. So again, it's a good bailout technique to do if you have a rupture of the aneurysm. So when do we opt for surgery? So I think main indication is a big hematoma and a mass effect. When you anyway need a surgical evacuation of that hematoma, I think we do send these patients for surgery or something like this. But if the hematoma is resolved, patient does not have symptoms due to that, we still opt for coiling of these aneurysms. Or if there is complex aneurysms, like a lot of them which Dr. Mishra showed, where you don't have really good answers of multiple branches coming from the fundus, you need bypass for these patients or complex clipping associated. So we do send these patients for surgery, thrombus, mass effect, growing aneurysm. I think there is definitely a need for an experienced bypass surgeon to tackle this. But something like this, complex aneurysm, if you start to do flow diversion for such aneurysms, you will have bad outcomes. So I think mass effect, thrombus, growing aneurysms, we need to do that. It's not that the clipping is not without its own issues. So we do see recurrences, we do see infarcts and rebleedings and everything. So one of our patients, again, we couldn't do endovascular at that time. We couldn't do an occlusion because BTO was negative, sent for clipping, trapped the branch, got an infarct. Another patient treated outside, clipped for an MCA, branch got trapped, occluded, large infarct. And this was an aneurysm which was clipped in 1998, came now after 16 years with a large recurrence which had to be treated. So both modalities will have these recurrences. We need to follow these patients in whatever arm we do. Yes, clipping will have far less than coiling, but it's not zero. And we have enough of such patients where the aneurysm was clipped at ICAD bifurcation, and in long-term follow-up, 10-15 years, you may get a recurrence which can be easily then treated by endovascular routes. What also happens in our country is we do not always do DSA before clipping these aneurysms, which I think is wrong. So one of the young ladies, ruptured aneurysm, this terminal IC aneurysm was clipped outside. In a follow-up, when we do an angiography form, she also had an MC aneurysm. And when we look back at the CTA, you can see it was also there and it's growing. So I think it's imperative whatever we do, we need to evaluate these patients properly before we decide on the treatment modality. So the common arguments of coiling having higher recurrence and retreatment rates, I think it's not true. And higher retreatment does not translate into worse long-term functional outcomes. I think the retreatment rates are dropping as we are using the new technologies, and rebleeding rates are also very low as compared with what we saw with the ICAD trial. And the functional outcomes are better with coiling as with clipping. Cost is going to be always a factor, especially in a country like India. And I think for me, the most common indication for surgery is large hematoma, mass effect, branches, and of course cost to a certain level. But when we talk about cost, we also need to talk that, I'll come to that. I just want to share my personal journey that, we hardly clip aneurysms at our center now. Though we have very renowned vascular surgeons, Dr. Chha was one of the prominent vascular surgeons who started it. But we have our own data and results which we published a few years back, and I think the success of endovascular arm is also dependent on our neurosurgeon colleagues, and they supported us very good and I think that's why we are the endovascular first center now. For cost, I always say patients are opting for TAVI, mitral valve clippings, liver transplants, everything is going on. So I think there is always a scope for both. Yes, in India cost is a sensitive issue, but also we need to also look at this psychological impact, quality of life, and that's where I think Violin scores will play. Thank you so much.
I would like to call both the speakers near the podium for the battle.
Hello.
So, thank you very much, Varun and Vishal, for a wonderful presentation. And we know that both are extremely skilled in their work, extremely good cases of boiling and pro-dilution and all that. And we saw very good cases of surgical treatment from you. So now I'd like to know from you, which are the cases you think go for endovascular treatment?
Unfortunately, we don't think anymore. The patients are actually, the thing is, what Gaurav, a very nice presentation, Gaurav, very, very good data. The patients are actually referred from the GP directly to for boiling. And that's the real world scenario, at least in Mumbai. And the difference is dramatic in a private center and a public center. In centers like PGI, Chandigarh, NIMHANS, AIMS, they are still clipping 349 a year. Whereas in private centers, I mean, Gaurav showed the data which is very, very low. But I think that's an exception. That's, we are not that low. The numbers are definitely very significantly down. To my mind, a patient who is a bad-grade patient, a patient who has a post-circulation these are probably should be the first candidates for endovascular treatment. Of course, you have to give the option now. Somebody who is a young fellow, who has a MCA aneurysm, and we talked about the patients who have hematomas. Now there is a trained patient going for hematoma evacuation and this goes for endovascular. I think illogical for me. I mean, the problem is the craft is lost. More and more, the moment you say that the patients are told that you have a big opening of the skull, they're scared. And I will do through a reading that's what, you know, the argument which is said. The problem is follow. The critical is follow. The data which is ICAD 18 years, you have to read the full article. It's actually not 18 years, it's 10 years follow that. But the title is 18 years follow, which is not true, which is 10 years follow, number one. Number two, the patients who died, if you go to each cause, none of them died of aneurysm. They all died of other medical illnesses. So you have to see the fine print. And the BRAC data, the patient, I mean, this is not too long back. It was 2019, I think the first publication was 2019, I can't remember. It's 2010. The 10 year was 2019 probably.
So BRAC was from 2003 to 2007?
Yeah, so 2019. But US is always maybe 15 years or 10 years advance than us. So for today, we are talking of 2025 in India, probably maybe 2010 in US. That was the technology there. Of course, things are changing. We have dramatic differences. The availability is significant. I mean, cities like Bombay, Delhi, and Hyderabad, probably VIZAG, I don't know about it. But Chennai, the metros, the technology almost at par in any part of the world. So yes, things are changing. But my point is, don't dump it. There is a definite role for microsurgery. Unfortunately, the people cannot get trained because there is no surgery in microsurgery. You have 3 cases in neurosurgery. I mean, how can a young neurosurgeon get trained in a microsurgery when you have 3 aneurysms over a period of years microsurgery? And if you are operating less and less, the senior neurosurgeon will not be giving microsurgery, for example. That's the problem. So the patients who need microsurgery, those who fail endovascular treatment, they are more complex. And if you are not treating simple aneurysm, you won't be treating it. And the complications will be higher, the mortality will be higher. So it's a kind of a problem which we are going to face. In the December neurosurgery focus, I'm the editor of that neurosurgery focus on aneurysms, microsurgery. Anybody who's interested, please type on.
One more question for you. Since we discussed about giant aneurysms and we have shown a lot of surgeries for giant aneurysms, because in today's scenario, we all are believing that the giant aneurysms, the endovascular is increasing day by day. We saw cases from both the sides. So I would like to know how easy or difficult the surgeries for giant aneurysms are, one. And secondly, I would like to know from you that we have aneurysms which are treated by flow diverter or in acute settings. We are using a lot of flow diverters in acute settings now with antiplatelets. And suppose we need to do shunt or treatment for hydrocephalus. So how easy or difficult it is to put a shunt for these aneurysms onto an antiplatelets?
Yeah, it's difficult, but I think you are so very nice. There is a train for the Bristol aneurysms, especially, which was initially thought we can't treat by flow diverter because you need for this double antiplatelets, which people are treating. I have the personal experience of people. I mean, we have a group, so we discuss, and there's a lot of flow diverters put in the US for Bristol aneurysm. There are ruptures which is in the we have the group discussion, but it's not been published, but it is there. The risk is there. You are putting and which is not going to close immediately, and is an acute aneurysm. And unfortunately, the Bristol aneurysm is a higher risk of re-rupture than other sacral aneurysms. So there is definitely a risk problem, number one. Number two, giant aneurysms, the recurrence rates, unfortunately, is very high in endovascular. And this endosacral device, to the best of my knowledge, I have no practical training with that, but I understand there is a limit to which size you can put endosacral. It's only 10 million, right? So none of the giant aneurysms can be treated by endosacral devices, right? So the recurrence rate, in spite of the flow diverters coil and the recurrent retreatment. Now what Gaurav said, very nice point, that the retreatment does not worsen the outcome. True. But the retreatment costs money. Retreatment, taking the patient in another hospital again. How many patients in India, even the best centers in the world, come for follow-up? Very few. I don't know what is the follow-up rate of the best centers in the country today. We have, I mean, probably, Kerala was probably different because, follow-up rate was very high. But other parts took 30%, in spite of us sending letters and asking, giving a letter, postcard, with stamp, still the follow-up rate is 30%. And the follow-up rate on aneurysms which have been endovascular need to be followed for life. So for an MC aneurysm or a PCOM aneurysm in a young man, I think it's illogical for me to treat by endovascular coiling. If the expertise is there, Imanas is there, probably why should we go for endovascular? And I think no logic behind it. Of course, in the posterior aneurysm, people are very few people are confident about it. Oh, I can do it.
Everyone is coming for the giant aneurysms and flow diverter, and at the same time VPNA flow diverters.
So I'll start with the last one, with PCOMs and all. So I agree with most of what you said. The cost is going to be higher when you retreat, and you always face challenges when you're calling these patients for retreatment or follow-up. So all of what you say is true, and especially in a country like India, it is absolutely true. But I also see the other extreme of which I tried to show, that it's not zero after clipping either. That, so you see those recurrences, and sometimes it's the other way around, that once you have clipped it, you have this assurance that it will not come back, so you don't even ask the patient to come back. So the follow-up rates are low. Even if you look at the ICAD 2 data, the follow-up rate is horrendously low for clipping, and they do only CT angiogram, which it's impossible to read as decanalization from that. So I think we need to achieve a better equipoise and not treat just based on cost or whether the patients will come for follow-up or not in certain situations, especially in metros and the kind of people we deal with. So that's one thing. But coming back to the giant aneurysm part, I think basilar top giant aneurysm, I think is a different disease altogether. I think we should segregate that from rest of the aneurysms. So whatever we do, whether we put a flow diverter, whether we do plain coiling, I think it will have a worse outcome. But yes, that's a different disease altogether. It should be dealt in conjunction with the neurosurgery team, whether if they can do a bypass or obliteration, how the patient is presenting, that's a different disease. But for ICA giant aneurysms, I think the success rate is far higher as compared to our old methods of stent coiling or plain coiling. And there will be again, 5% of these patients who may have a degrowth despite whatever you do. But most of the patients, actually in our own practice and in our own experience, we find that they have a good outcome just by the endovascular means.
With the understanding from a surgical point of view and endovascular point of view, and myself being an endovascular person, I feel any aneurysm, both the options should be given to the patients. And cost definitely matters. I practice a lot with the government setup, and I know even patients want to go for endovascular, just even though cost is more, they want to adopt the money and they want to go for endovascular at times. But I still strongly believe that there are cases where clipping is one of the best options in the given scenario for the patient. So I think we need to make a balance in every single case and then take it ahead from there. Because there are situations where even after coiling we need EBTs or we may need shunts or we may need any kind of equipment in those patients. So I think the balance is required. But for giant aneurysms, I strongly believe now that endovascular is going a little different way, just the surgical part is really going down, at least in our practice that we are seeing. But your hands.
Different cases for it's definitely much easier for endovascular. The problem is the recurrences. And patients who have a visual compromise, I think to my mind, at least my personal experience, client aneurysms with a visual compromise, if you have a complicated aneurysm, it's better to decompress rather than. Because if this C loses, that's blindness. I mean, that's gone. Nothing can be done about it. Doesn't matter what you do. All these new drugs, everything, nothing else. Patient is blind for life.
So with this, I think I would like to know about.
So this discussion is going on since 1 decade. So actually, this is not a battle. This is a teamwork. As the organizers created hype so that the delegates keenly observe what is going on. So as usual, this as you told, it's in cricket. So usually, whenever Ashes series or India-Pakistan, they will create a hype that it's a battle. Actually, it is not a battle. So when coming to aneurysm clipping, as neurosurgeons, we prefer it is the definite treatment. So just like a snake in the house, so killing of the snake is clipping, whereas coiling is just keeping snake aside. So, but we always prefer that since 1 decade, the vast developments are going on in both fields, in coiling and clipping as well. So it's a teamwork, and initially the neurologist and neurosurgeon and interventional neuroradiologist should decide which case to be coiled and which case to be clipped. So then it will be a good atmosphere, and that will be very helpful for the patient management. Thank you.
Thank you, sir. And in this hall, we have legends belonging to interventional radiology and neurosurgery. And I had the pleasure of introducing to the audience two great legends in cerebrovascular, Dr. Manas and Dr. B.K. Mishra, and Dr. Uday and Dr. Gaurav from interventional radiology. Let me conclude the session by saying that both the procedures, one of them, the surgical part is a time-tested one, has been there for many decades, and the interventional radiology of late has refined itself over the last few decades and has stood the test of the time. So basically, the important thing is the person involved in doing the procedure, does he have the intelligence and necessary training to perform that kind of a procedure. In a center where I am trained, Dr. Manas was doing around 6 to 8 aneurysms a week, and we had the opportunity of seeing the best hands at work, and eventually we got trained under him. And we feel quite confident, like BK Viswasana was telling, that if a surgeon is trained well, and if he can deliver the outcomes as good as that claimed by interventional radiology, then differing on the aspect that you would have to cut open the skull, the surgical part is much bigger a procedure compared to the 15-20 minutes or 1 hour interventional procedure, should be a reason to say that surgery is any inferior compared to interventional radiology. I think currently the way they are placed, both of them are equally capable of handling any aneurysm anywhere. It is just the training part. The person who is doing it should be trained and have a stable and patient mind to perform that kind of a procedure. I hope both of you will agree with me.
Absolutely, absolutely.
Thank you.
Thank you.
It is a great inspirational insights, both from the speakers and the chairmen. The battle begins, finally chairpersons are making it compromised. So, now I would like to present mementos as a privilege for your time and appreciation for our first speaker, Dr. K. Satyavarprasad sir and Dr. T. Suresh sir. Kindly present a symbol of our appreciation, a memento for our first speaker, Dr. B.K. Mishra sir. Really an incredible presentation and explanation. Thank you so much, sir. I will call upon Dr. Lakshman Rao sir and Dr. A. Mohan Rao sir. Kindly present a symbol of appreciation, memento to our Dr. Gaurav Goyal sir for a great presentation. So finally the battle is like Mumbai versus Gurgaon. Neurosurgery versus neurointervention. Thank you sir, thank you Gaurav sir for a great presentation. Now I would request Dr. Rashmi ma'am to kindly present the mementos for the chairpersons for their great insights, valuable insights and making the battle compromised.
Hello? Even program run event. లేదు సాయంత్రం 5:30 అయిపోతుంది.
Thank you so much for the questions and the discussion. Dr. T. Suresh
చేస్తాను
sir,
ఒక 5 నిమిషాలు చేస్తాను.
thank you for your valuable insights.
అదే చేస్తాను.
Dr.
నేను
Lakshman
ఉందా
Rao
లేదా
sir,
మీకు కన్ఫర్మ్ చేసుకొని చేస్తాను.
thank you so much for your time and presence. Dr. A. Mohan Rao sir, thank you so much sir for presenting today on the stage for this discussion. I would request Dr. T. Suresh sir kindly present a memento for Dr. Rashmi ma'am also. Okay, ma'am is the next speaker, so we are going to felicitate her then. Thank you sir. Thank you for the discussion. So let's go on to the third topic. Are you ready or getting hypoglycemia? So let's go for the ICAD, intracranial atherosclerotic disease. So Dalai sir doesn't want this to be a topic, it should be a battle. Yes? So the third topic is about ICAD, intracranial atherosclerotic disease. It is about best medical management versus endovascular management. Atherosclerosis inside the brain, one of the toughest adversaries in the stroke neurology. So let's see who wins a powerful medical therapy or a skilled endovascular management. First, I would like to call upon the chairpersons for the third battle of ICAD, the intracranial atherosclerotic disease. Dr. T. Mohan S. Maharaj sir. Krishna Haskar sir, Dr. D. Sunita ma'am, and again I think Dalai sir has to replace as one more chairperson. Dr. Dalai sir, kindly come on to the dais. And I would like to invite our speakers. Our first speaker, the legendary renowned expertise, luminary in the field of neurosciences, a beacon of excellence in neurological care, Dr. Vikash Kumar Mishra, Clinical Director, Head of Department Neurosciences, K Hospitals, Bhubaneswar, who is the speaker for the best medical management of ICAD, intracranial atherosclerotic disease. Let us welcome Dr. Vikash Kumar Mishra with a round of applause. And our second speaker, a legend, a true pioneer, a renowned expertise, brings a wealth of experience for our event today, Dr. Rashmi Sharaf ma'am, Chief, Division of Interventional Neuroradiology, KEM Hospital, Mumbai. We are honored to have you here today, ma'am. She shares her latest approaches on endovascular management of intracranial atherosclerotic disease in advancing the treatment of neurovascular care, which is rapidly evolving today. So let us set this battlefield. So our first speaker is ready with his best medical management for the ICAD, Dr. Vikash Kumar Mishra. Thank you, sir.
Good afternoon. My special thanks to Dr. Sundarai for this wonderful lecture. It was really a fight between the learners and the committee stands good. Now, I have assigned to speak on the ICAD best medical management. If we look at the stroke, before I can go to the topic, we need to understand, is it the same worldwide? Is it the extracranial and the intermediaries are the same? Is it the same the kind of risk factors people are having? So taken all together, it's very interesting in the present world how best the medical management actually feels and what do we stand up. I go through my the topic, I go through the incidences and risk factors, using the randomized trials and the treatment that is being thought of, and what is the basic guideline that speaks to treat the patient with the diseases. If you look at this, intracranial atherosclerotic diseases are peculiarly different from others. One, worldwide population, the presentation is different. In the Caucasians, I will see it is around 8 to 10% only. But surprisingly, it is very high in the Asian populations and African Americans, or Hispanic populations. If you look at it, India, in that both scenario, starts with a very huge number of patients of ICAD, particularly 20 to 55% of the population. The stroke patients are actually ICAD variety. And next is the China, be it Thailand or Korea. In all these places, it is found that the incidences are more in the Asian and African American populations or Hispanic populations. In India also, there is a variation between north and south. The incidences are more in the north than in the south. As far as the literatures are concerned, we are not very sure because there is no direct large-scale data kind which is available for us to comment on it. West of the ethnic and racial makeup of the world population is one of the most common causes of stroke, and the high prevalence is in the form of pre-stroke. So the incidences of pre-stroke are more and more in patients of ICAD than the other varieties. So it is more prudent to understand why it's so and how best can be prevented. Looking at the mechanism of stroke in those patients, if you look at it, there are 4 major varieties like traumatic occlusion, artery to artery occlusion, blast artery occlusion, or is the hyperperfusion of stroke or hemodynamic perfusion impairment. So out of which arterial occlusion or embolization and branch artery occlusion are the commonest varieties that is seen in these patients. Once we look at the stroke recurrence rates, according to the most common subtypes, the most well-discussed trials, if we look at the active population of patients with on apixaban, the Aristotle study, the relative risk of having a stroke, re-stroke within 1 year is around 1 to 1.2%. Whereas in the carotid stenosis who are undergone stenting or versus the carotid data in the CREST trial, it develops around 2% in the 1 year risk, 2% patients with stenting and 2.5% in the patients with endovascular. Similarly, the small vessel diseases, the recurrence rate is around 2.5%. Congestive heart failure with ejection fraction less than 15% is still CVA. In the work of analysis, it is around 5.9%. Whereas in the sample trial, which has seen the carotid diseases, more than 70% of stenosis under the medical management, the rate is around 14.9%. So it is prudent to say that the incidences of re-stroke is very high in some patients. Now, question comes whether it is a stenting or a medical management. Lots of debate keeps on going and it keeps on happening also. Let's look at the data that we have right now. Most famous versatile 2 decades back compared between the warfarin and the aspirin groups in the symptomatic stenosis. In the infantile atherosclerotic disease, particularly groups by the warfarin and aspirin was pitched against each other. There are around 239 patients in the warfarin group and 280 patients in the aspirin group, and they are recruited into the study. What but less than 70%, the risk is only 78%. So why is it so that the risk of recurrence is more high in more stenotic cases? Various causes have been depicted, but we need to understand the volume of problem. Those who are recruited in the 70 to 99% of category, those who are recruited without 30 days of onset of the disease, the recurrence rate is 22.9% at 1 year. And more than 30 days after the recurrence was done, then 9% is the cases of recurrence. If you look at the second year, there is a marginal increase of around 2% only, in the 25%, whereas the risk remains the same in the patients those who are recruited with beyond 30 years. So why is it so improved? Because the initial medical management has probably stabilized the plaque and the conditions remain stable and the incidences of stroke rates gets reduced. The second most famous sample trial, which looked at the stenting plus aggressive medical management versus medical management alone, and what it showed, what they think is that 99% of patients were recruited to study and non-disabling stroke of the eye in the last 1 month, and they are followed up for 4 months. The group patients seen was 451 with the stenting group 224 and medical group had 227. What's the subanalysis was made in the primary endpoint with the stroke of death after 30 days or stroke in the same territory beyond the 30 days. It is found out that stating group at 14.7% compared to the medical group, which is 5.8% within the first month. However, in the year 1, 2, and 3, the incidences remained 19.7% or 20 to 23%. It kept on increasing. Rather, it got stabilized. But the incidences in the medical group always remain low, and this group what it is showing as 12.6% to 20.9%. So what is more significant is that the medical management, aggressive medical management group fared better than the constating group. Similarly, the cases randomized trial is the largest science trial. They recruited 182 patients in the medical therapy, and stenting plus medical therapy had 76 patients. When the subanalysis was made about the risk of stroke or death, the incidences are 8% in the stenting group, whereas only medical group is 40%. So it is not statistically significantly different, but it indicates the age of stenting over the medical therapy. So medical therapy is first in this case. So medical management, as far as we are concerned right now, in the medical management is similar to stenting. However, there will be exception selected cases which might be speak in the next topic. Now the second question comes to check from the there are trials that have been made till now. If you look at the chance trial, was used like or patients, and they recruited around more than 5,600 patients. And the aspirin group or the combination group, what it showed that the combination group, what the clopidogrel and aspirin group, patients with minor stroke of DNA, when they are combined treated and treated with the 24 hours of the onset of the disease process, the risk of recurrence is lesser in the dual active group and than the aspirin alone. The chance 2 trial now speaks about the inclusion of the ICAD or aspirin versus clopidogrel aspirin in the two groups. 6,400 patients have been recruited, and to look for the symptom onset within 24 hours, the patient are given with the anti-platelet drugs, and the outcomes are different. Where the recurrent stroke rate was little better in the ICAD or aspirin group, but not significant. Whereas it has fared better in patients with stroke of undetermined origin, etiology, and the small arterial occlusion, they fared better. The patient who is not on ICAD group. Same is the statistics showing where there is the ICAD aspirin group showed the recurrent stroke is low as, whereas stroke of undetermined origin, they fared better in the ICAD aspirin group. CS+3 trial recruited 925 patients with the lacunar strokes where silestazole was included in aspirin or the clopidogrel, and it is found out that dual active platelets did fairly better than in the ischemic stroke group versus the aspirin groups. They got better. Safety concerns like dual active platelets had more chances of bleeding comparison to the other group. So to suggest that dual active platelets in this group were fairly better than that of the other groups. Similarly, Catholic study looked at the progression of the intracranial arteriosclerosis, changes, the stenotic changes in the MRI at the 2 years, and the patients, 165 patients were included who had more than 50% of stenosis after 2 weeks to 6 months from the onset of the disease. And the company showed that the progression of stenosis was up to 9.6% in the silestazole and aspirin group, than that of the aspirin group, which was 5.6%, but it was not statistically significant. So silestazole per se didn't do any favor to the group of having restenosis. And the secondary endpoints like hemorrhagic strokes were not significant in the combined group. Similarly, the study published in 2016 where the ticagrelor versus aspirin. Ticagrelor did do well in the study, but it was not very statistically significant to suggest that it can replace aspirin. So, to suggest that patients with ticagrelor versus aspirin, it doesn't give an advantage. Similarly, when the ticagrelor with aspirin versus clopidogrel with aspirin was challenged in the randomized placebo-controlled trial, which included around more than 6,400 patients into the two groups, 3,200 almost each. It was found ticagrelor and aspirin group did fairly better in the clopidogrel and aspirin group within the first 7 days of the stroke recurrence. Similarly, the more famous Artemis trial, which has been published by now again, by 2024 it was published. They looked at the clopidogrel plus aspirin versus aspirin in patients with a mild to moderate stroke. It showed that dual antiplatelet therapy favors incidences of recurrence, so the chances are less in the first 7 days. Now, there is a ongoing trial by our own team from NIMS, and other centers like Sri Chitra, HPTI, and Mara, where they are looking at the long-term safety versus dual antiplatelet therapy in patients with stroke due to intracranial atherosclerotic diseases. This trial is now, the recruitment is about to be finished now, and it shows that we'll see how the antiplatelet effects, even for a long time, what is the outcome will happen in this situation. Captiva trial, again another much higher trial, which is looking at ticagrelor with aspirin versus introduction with aspirin and clopidogrel and aspirin. In the 3 arms, they're going to figure out which one is better. The randomization got over, the recruitment got over by the December 17th of the 2024 last year, and they're going to follow it up for 12 months, and the result can be out by the end of this year. One of the meta-analysis which published in the JAMA Neurology in 2019 suggests that dual antiplatelets do favor fair chances of having less of recurrent strokes, particularly looking at the chance and point trials together also. It suggests that patients who are on the dual antiplatelets may be better than the aspirin alone. There are several trials which have been published from time to time with chance point or Socrates trial, which has been changed. This partial there are several such trials which has now established that probably dual antiplatelet at least in the first 90 days is going to be beneficial in patients of ICAD. And is there any role of heparin or heparinoids? Probably no, because this study presented that the low molecular group had more of bleed and incidences and didn't have any benefit of having a reduction of the stroke. So it is still out to make a judgment, but dual antiplatelets for the first 90 days probably safer and better choice in most of the cases. Now, what is the important component of the ICAD is the risk factor management. Starting from the VARUN trials, Aneurysm, and rest of all the trials, they follow the one risk factor management in the form of managing blood pressure, managing cholesterol, diabetes, and pitch characteristic. In the Chinese study, which looked at 17,000 patients, it is found that hypertension increases the chances of re-stroke twofold. There are more than 2 dozens of trials which have been made, but still the jury is out to think which anti-hypertensive medication is better than the other. However, controlling blood pressure is one of the paramount important things in the management of the ICAD recurrence. So, in the terms of stroke trial, published in 2010, has established that there is a U-shape curve, and those with systolic BP of less than 140 do fare better than the other groups in the extra low or in the high groups. The VARUN subgroup analysis suggested that systolic BP of less than 140 are the better groups, cholesterol less than 200 are the better groups, and it is established that aggressive management is the most important factor when treating patients of ICAD. Similarly, the VARUN study was missed that in the vascular region section, lower blood pressure can worsen the outcome. So one should be careful about managing the pressure in the post-circulation strokes. Looking at the cholesterol and stroke recurrence in ICAD patients, it is found out that the 10% reduction in the LDL is estimated to reduce the intima media thickness by 10.7% per year. And intima media thickness is a strong predictor of the development of carotid stenosis. In the clinical trial, it is established that LDL cholesterol less than 70 does affect for the secondary prevention of the stroke. The SPARSIP study, which looked at the atorvastatin as the main drug to reduce LDL cholesterol less than 70, and 80 mg atorvastatin was given to the patients and followed up for a long time. We suggested that atorvastatin itself is a strong indicator of having a good LDL control with the atorvastatin in the first 90 days is a much more beneficial and subsequently can continue depending on the LDL level. So another study which the LDL target again establishes the same factor that those who were the group A less than 65 mg per deciliter versus group B with 96 mg per deciliter, the primary endpoint is the major cardiovascular events, and it is shown that the incidences of recurrence of the stroke or vascular events are much lower in the group A, that is the what you see in the red line. It is much better outcome in the patients with lower risk. Here the study which recruited 460 patients, that imaging-wise they have started to show how the atherosclerosis or the stenosis part is improving. When the patients were added on evolocumab to the statin group, and you see evolocumab with statin compared with 68% LDL reduction, that is compared to the 34% where the evolocumab was not added. And it's, in the angiographic studies that presented, where you see the first one is stenosis, where the tight stenosis which has improved. In the next follow-up period, after 2 years, the reduction is significant. This trial has talked about the 5 detergent in preventing stroke, the 45 mg of biochemicals added up the patients, and a total of 876 patients participated in this group, and had 377 stroke events, and in 390 patients, they were followed up for around 5 years' time, and it was found out that the recurrence of the stroke is reduced in the group which is identified antigen, but it has the p-values are very significant, though in 0.01. Biochemicals was effective in the secondary prevention of ischemic stroke, but the largest studies and other parameters has to be followed up to suggest that it is going to really help us out. In the Cyprus trial, the physical activity or the exercise was taken up in a very neat way, where suggested that those who are out of the target area of the systolic beyond physical activity, and as well as those higher than LDL and SDL, they are more likely to have recurrent vascular event at the end of 3 years. But those who had a greater physical activity had the decreased likelihood of recurrent stroke, and it was the strongest predictor of recurrent stroke as per the aggressive medical management is concerned. So needless to say, wherever possible, physical activity and physiotherapy has to be instigated in such patients, and physical activity has in this graph suggested that this is has an impact on the outcome. Before I conclude, I would say hyperlipidemia needs to be treated with LDL cholesterol, keeping an eye on the LDL cholesterol less than 7 mg per deciliter. And in a patient with hypertension, one should always try to keep a systolic blood pressure of 140 or 50 about 140/90. And in the diabetic patients, 130/90 is a fairly better blood pressure for preventing the recurrence of the strokes. as far as the anti-thrombotic agents are concerned, dual antiplatelet therapy is safer and better in the first 90 days to prevent recurrence than that of the single antiplatelet agents. And the diabetics, physical activity and sugar control along with the idea of keeping HbA1c less than 7 is a fair idea to contain the resurgence of the stroke. And the lifestyle modification with the activities, a minimum 10 minutes of moderate intensity aerobic activities like walking or biking or exercises of the arms and legs are recommended for the patients to have an impact on the prevent recurrent strokes. So with that, I would say ICAD is an important part of the ischemic stroke, and more so because of the recurrence of the stroke. The vestibular imaging, transcriptional Doppler, microembolic detection, and functional imaging may be required to understand more the ICAD disease and to find out the proper solution to that. Antiplatelet agents, particularly the dual antiplatelet agents for the short term of time, has got a beneficial role, and the clinical trials are still undergoing to understand the impact of the endovascular in such patients in the selective group. Where to say, I think my counterpart is certainly going to throw more light into it. With that, I say thank you all.
Thank you so much, sir. We express our sincere gratitude for an outstanding presentation. Your expertise and generosity in sharing your knowledge, which is truly inspiring us, sir. Please take a seat on the dais for the second speaker. So our second speaker, our legend for the panel, Dr. Rashmi Sharaf ma'am, on the latest approaches on endovascular management for ICAD disease.
Good morning, everyone. And after understanding about the medical management in depth by Dr. Mishra, I will be taking the so-called back ahead about whether to go for endovascular therapy or not, or is the medical management enough. I would say any battle is half won if we understand the disease and if we understand the technology and skills that we have, we can get the things forward and have the battle in our hands. So first trial which was there, about multiple trials that we have, VASIT was one trial which clearly explained that 7 to 10% of ischemic strokes can be because of intracranial atherosclerotic disease. And they also mentioned that 15% reference rates are there in this in ICAD disease. So these diseases have to be managed well, either medically or by endovascular routes. So warning signs are there in almost 20% of the patients in the form of TIAs. It clearly mentioned that if the disease stenosis in the intracranial arteries is it's more than 70%, then the recurrence rates of the stroke in 1 year is higher, close to 18%. Those with less than 70% stenosis have the stroke risk of 7 to 8%. So from this trial, it was made very clearly understandable that patients who are having high-grade intracranial atherosclerotic disease, that is having 70% or more stenosis, they need attention. And that is how all the focus of the neurologists or neurointerventionists moved towards the intracranial atherosclerotic disease. Then trials, so there was severe trial after this. Again, it was not too much in favor of intervention because that time the technology was not advanced and we didn't have devices to take inside the brain easily. We used the stents which is used for heart to take inside the brain. Those stents are not designed for brain. They are designed for coronary arteries. Though they function for the atherosclerotic disease, but the navigability is not as good, and so the trials results were affected in the initial years. So many trials happened after that, but the most important landmark trial which affected the practice of endovascular management was the SAMPLES trial. So around 2011 or 12, the results or preliminary results started coming out, and this was the standardized trials comparing the aggressive medical management versus endovascular stenting for the intracranial atherosclerotic disease. So this trial was very stringent in the medical management. Very aggressive control of various factors were done. Robust trial, more than 451 patients were enrolled. And these were the parameters which I think Dr. Misha has already covered very well, that how to control various risk factors and the treatment targets. With very strong follow-up and very strong stringent medical management, and at the same time, the endovascular arm was not very strong in this case, and it showed results that there were 14.7% complications in surgical arm. Huge number. In any neurointervention, the risk should be less than 4 to 5%. The moment risk of the procedure goes above 4 to 5%, you should think twice whether this procedure should be done or not. So 14.7% led to premature or abrupt stoppage of the trial, and now there was a thought process. Big setback. We all were doing lots of ICAD stenting, and we suddenly stopped doing because the referral stopped, the neurologist felt the aggressive medical management was good. And then we started seeing so many recurrences, and when the patients were coming with recurrence, the arteries were occluded, or they had bigger infarct, more morbidity, and that time doing intervention did not have much role. So we started thinking about the pitfalls of the Sampras trial. The biggest pitfall of the Sampras trial was good credentialing of the operators of endovascular arm was not done. The centers were not credentialed well. The number of cases required to have enough experience to use a newer device like Wingspan. It was a new device that time which had a technological lot of involvement where exchanges were involved, so wires movement were very critical. So there were a lot of perforations in this study. Plus there are many other factors which were confounding in the study, but it put a stop to endovascular, and it clearly mentioned that unless patient has a second stroke on aggressive medical management, the endovascular treatment should not be done. At the same time, multiple other trials on Wingspan or registries were going on. None of these had such high risk of stroke or death at 30 days. Other registries were well below 10%. Even Japanese surveillance, post-marketing surveillance was done in the next 2 to 3 years. Their rates were also less than 8 to 10%, and they said it is safe in their country. So there was something which was not okay in the Sampras trial, and that's why the investigators, the endovascular arm doctors of the Sampras trial, they decided to do another trial with proper credentialing, proper training of the endovascular person. He should have given number of cases, the center should have this number of cases. With all that, the WEAVE trial was started. And this was a sigh of relief because there were many patients who were very moderate after the second stroke, so doing stenting had no meaning. So what did the WEAVE trial? This trial was prematurely stopped because this had a result which was much better than expected. So the expectation that was kept was at 4%, that the result of endovascular treatment should not be complication or problem should not be more than 4%. In this, the complications were 2.6%, well below 4%, and so the trial was stopped and endovascular arm got some relief and they started doing intervention. So this was about the WEAVE trial, but at the same time, the CASIS trial started. So I'm talking about the trials which are comparing the medical arm with the endovascular arm. CASIS is a Chinese trial, and there are lots of ICAD interventions are happening, and so they decided to do this trial, and they believed that the outcome of the trial was the surgical, the endovascular has no added benefit compared to medical in controlling the risk of strokes at 1 year. But was it? It did have its own fallacies, but there are more data coming in, and we've tried, they took the follow-up at 1 year and it became a woven trial. I'll talk about it. Before that, I'm just showing one article here, and this article is NOVA trial, which was about drug-eluting agent and balloon-mounted routine bare metal stent for the ICAD. Here you look at the results of the surgery. There was 5.3% or 7.6% risk of complication with these stents compared to 14% with Sampras. So even with balloon-mounted stents, the risk or complications of the procedure is much lesser. So that is what we also believe, that the risk or complications were not so high. So then came this woman 1 year result to understand that why cases had all this, and they realized that the risk or stroke rate at 1 year was not very high. If they remove the risk, if you remove the risk of the first 1 month of the VIZAG trial, then the remaining 11 months, the risk was only 5.4% of stroke after 1 year, which is understandable because of the multiple other variants like the hypertension or all other risk factors working in these patients. So with VIZAG and COVID trial, it was clearly understood that intervention does have a role, it's not without a role, and the best medical management is not the only way to go, especially in the area or in the region where we are US and Europe. In our practice, the epidemiology of ICAD is very different. We are seeing lots of ICAD compared to what they see in the Western population. They are like almost 8% and we are 23 to 50% in South Asia, that is in the Indian subcontinent, which is way higher than what they are seeing. Hypertension, diabetes, tobacco chewing, hyperlipidemia, these are the risk factors. So ethnic difference is here, so our decision should not be based only on the SAPRIS trial or CASIS trial. Our decision should be based on what we are seeing in our practice. So here we are seeing patients with younger age group, patients in hyperacute stroke presenting with hyperacute stroke, they have almost 30 to 40% of ICAD associated with it. So we have difficulties in doing mechanical thrombectomies because we encounter ICAD and then the results of our mechanical thrombectomy become different from the Western population. So approximately 2,000 to 2,500 angioplasties and stenting are performed per year in India, which are elective and acute stenting. And around 5,000 mechanical thrombectomies are being performed in India every year with underlying ICAD in around 35% patients, which is a huge number. So is ICAD really a concern in our setup? Yes, it is, because the recurrent strokes are higher and the second strokes are more morbid, which are proved by various trials and have been proved by our results as well. And these are the various studies, Jessica, the Veritas trial, they all have shown that the recurrence rates are very high. Especially the mechanism of strokes that we see in our practice, they see a lot of perforated strokes in the Western population. We see artery to artery embolism, in situ thromboembolism because of the plaque rupture, and there are hemodynamic or deep watershed infarcts in our practice with multiple mechanisms coexisting. I'll show you our KM data which will be supporting all these findings. So we have realized those factors which increase the stroke recurrence, that is degree of stenosis, hypertension is a very important cause, poor collaterals, watershed territory infarcts, and impaired distal perfusion. Various studies from India now clearly mention that we have ICAD as a very prominent disease and prominent cause of stroke in India. So with this background, I would also like to tell you that with MT, that is mechanical thrombectomy in ICAD, is very challenging and outcomes are not good at times because the patient is lysed, patient is on, we load them on dual antiplatelets or give tirofiban and they tend to bleed. So though a lot of trials are now happening in Reboot and rescue ICAS, but still we are having bad results. I will show our data with the background of this case. So this patient came to me some time ago, 53-year-old male with hypertension as the only risk factor, and look at the scan, there is one infarct in the pontine region which was possibly because of the stenosis, and there is vertebral which is showing high-grade stenosis, and look at the angiogram, we hardly see the intracranial posterior circulation, and all the 4 arteries are diseased. So we explained them this it needs to be treated, but the family was discussing, and because it was only one stroke, they waited for the second stroke, and unfortunately he did not live in the second stroke. So second strokes are debilitating in our setup, especially in posterior circulation. So I'll come to the data that we have analyzed in our setup. Ours is a tertiary reference center for the Western India, and we see close to 1,500 to 2,000 ischemic strokes in our OPD or casualty per year. DSA stroke, but only 2% show moderate, so they can be managed with medical management. In our set of cases with hyperacute stroke, there are 25% having underlying ICAD. So we did, this is around 200 patients over the last 15 years, and we saw that the males were more common than females. And what interestingly that we saw in our data was that we had patients less than 50 years, approximately 32%, which is quite a huge number. Previously we used to see patients above 50 to 60 years showing ICAD or stroke-related features. Amongst comorbidities, hypertension was the commonest risk factors in our data. Anterior circulation was more than posterior circulation. And when you look at the distribution of location, the middle cerebral artery and the posterior circulation are more common than the suprachoroid ICA. So then we looked at the stroke mechanisms in our study, and we found out that majority of them had artery. And this is why we understand that we are seeing patients, because these are the subset of patients who are going to have high recurrence rates. We also assessed the length of the stenotic lesion, and we found that there is a Maurice classification, and risk of recurrent strokes are higher when the length is more than 5 millimeter. In our series, 78% had more than 5 millimeter length stenosis. So based on our practice, I use more of drug-eluting coronary stents for intracardial. So we had 70-30 for self-expanding. So now how do we choose our patients? That is patient selection criteria. We choose if they are symptomatic, high grade, more than 70%, repeated TIAs or second stroke, which is the usual point of referral. But if they come with TIAs or very small strokes with poor distal flow and collaterals, with contralateral occlusion, we go ahead and stent it. We don't wait for the second stroke to happen in our practice. And in posterior circulation, more than 90% stenosis, in posterior circulation with TI, stroke or asymptomatic, we go ahead and treat them, because if you don't treat them, natural history is really bad. They come with very bad strokes. And stroke with ipsilateral occlusion and contralateral high-grade stenosis, we tend to treat them. Now, timing is very important, because Sampras had more complications. Sampras treated most of the patients in the first week of stroke. The complications or the reperfusion needs are higher in the first week of stroke. So we normally, if the infarcts are small, we treat after 1 week. If they are big infarcts, we wait for 4 weeks so that we don't have reperfusion bleeds. And hyperperfusion symptoms at the time of presentations, if they are there, we go ahead and treat immediately. So now coming on to the cases, so that we understand why it is not important to go for endovascular treatment in ICADs who have debilitating stenosis. So this patient is a 50-year-old male, hypertensive. He had 3 episodes of giddiness, ataxia in the period of 1 month, and you can see every stroke. He was started on dual antiplatelets after first episode itself. 1 week later, second episode, and 3 weeks later, he had third episode, and that is the time he came to us. And this is what we find: there is VA osteostenosis, and we go inside the brain. There is high-grade basilar VV junction stenosis. The patient has had 3 strokes, 2 on dual antiplatelets. So with this understanding, and these are tandem lesions. There is lesion distally, there is lesion proximally. So we have now very advanced techniques. We have devices which can go deploy the balloon. We inflate with the balloon and deploy the stent through the same balloon, and we deploy the self-expanding stent, and patient has been stable since then. It's I think 2 or 3 years now. Another patient, 67-year-old male with diabetes and hypertension, multiple strokes over 5 months, 8 to 10 TIs per day for last 1 week he is having. He's on dual antiplatelets. So he comes, we do the DSA, and there is hyperperfusion in the brain. Patient was, as we described among various trials by Dr. Mishra, he was on NOACs plus single antiplatelet when he came to us, which we switched to dual antiplatelet, and look at the lesion. This is what we are seeing in the Southeast Asian region, long, extensive lesions, which they don't see in the Western population so commonly. The entire basilar disease, 2 segments are having tight stenosis, so we had to go ahead, do the angioplasty for both the stenosis segment and put a self-expanding stent, which we have beautiful ICAD self-expanding stents now. And this patient, believe me, has come walking 2 or 3 times in my OPD just to show me that I don't have giddiness. He won't get up from the bed before the procedure. Now coming on to the next patient, he is 57-year-old, diabetic, hypertensive, 3 episodes of left-sided weakness with good recovery over 1.5 months. When he came to us, he was having tingling and the numbing sensations in the left half of body. He was on dual antiplatelets. And you can see there are infarcts in almost all the scans. All the scans show infarct. These are 3 strokes that he had. And this is the DSA. You can see there is high stenosis in the MCA. And we go ahead, we put the balloon mounted stent here. And there is good deployment of the stent. This is post of diamond CT. I want to show you here that all those blood infarcts are enhancing. So we have to have a very good control of blood pressure post-procedure because these infarcts can lead. These patients have multiple infarcts by the time they come, so we have to be very, very careful. Again, Sampras blood pressure control was not good, so that's why there was a lot of post-op bleeds in the next 1 month. So that has to be very well controlled. Now another patient, 67-year-old lady with diabetes and hypertension. She had episodes of TIAs during which she used to have difficulty in speech, and this was going on for 1 month. She came to us, that time she was still preserved, and you can see that there are multiple little infarcts on flare, and MCA is not visualized in one segment. We know that this is high-grade stenosis. And look at it, there is so slow flow in MCA, and when these kind of flow pictures you see on the DSA, they are an indication to treat, and they are the cases where recurrent strokes are very high. So I would like to emphasize that DSA should be performed in patients of ICAD so that we can understand the hemodynamics. So you can see the long segmentation, but we have amazing distal access catheters. We can take balloon mounted stents way inside and deploy, and since then she has been stable and good flow in the MCA territory. Now another patient, elderly, diabetic, smoker, and he came in hyperacute stage with altered sensorium, weakness, aphasia for 5 hours, high NIHS, CT aspect of 7. And you can see that infarcts are still in not established territorial. These are embolic infarcts, very classical of ICADs. And you can this is the MR for fusion imaging, and which shows that the whole hemisphere is hypoperfused. When the hemisphere is hypoperfused, they are high risk of getting repeat strokes, and they are also the same patients who have high risk of hypoperfusion bleed after the procedure. So you have to do the stenting, and you have to monitor them very closely after the procedure. Very bad arch, and look at the anatomy, one of the most difficult anatomy that you can encounter on a hyperacute stroke at night. And there is hardly any flow in the MCA, very high-grade stenosis. So we had good devices, we went up, and the wire was not going ahead, and we were not seeing anything. Somehow we took a very small balloon to make some space so that we see the distal artery. Then we saw more, and then we took the bigger balloon. Taking balloon mounted stent was impossible. We did more plasty, and then we deployed the self-expanding stent. And this patient has remained very stable over almost 1.5 years. This was a CT scan. There was a small bleed in the overall part that he had, but he did well. And now the family wants every atherosclerotic stenosis in his body to be stented. He had high-grade B osteal, we have stented that, and he is doing good. So we see ICADs in emergencies, and that time it becomes very difficult to treat them and load them on dual antiplatelets. They discomplete. Look at this. I think people can appreciate this image. And this is an ulcerated kind of plaque in MCA. We don't see them regularly, and this is what we see in the South Asian population. And that's why stabilizing them is very, very important. Look at the lesion that it looks. Patient having repeated strokes, we have to put a stent, balloon mounted, and patient is stable. Now another patient, 54-year-old female, tobacco chewer on dual antiplatelets, and she is getting strokes, and you can see her arteries are already diseased everywhere. So we had we came from the radial aspect, now we have the radial axis, very good for vertebral stenting. Look at the multi-level stenosis. So again, I want to show that we can take multiple balloons and we can plastic them, and we have various stents. This patient, we put one balloon mounted stent distally, and through that we put the and the whole lesion was stabilized and she does not have any more strokes. In fact, she's a farmer, she grew jawar and she brought it for the whole department and she's so fit now to do all the work. Another patient, 50-year-old male, who can be brain, multiple infarcts, multiple glantic area and left MCA is not well visualized. And in the angio, you can see there is a clot overhanging in the ICA, patient coming with acute stroke. So we go ahead, we do plasties, thrombectomies, solitaires, but at the end of it, we see stenosis like this, and we have to be careful, we have to follow them up, and if required, we have to put stents in future. And this is what we are worried about. This patient, I did not load, I did not do anything, only I had to give some tirofiban, and there is hemorrhagic conversion of the infarct, so patient will be reasonably well. So going on to the another patient, again, posterior circulation stroke in emergency, diseased artery, and we have no choice. So this is what happens, you open once, you do thrombectomy, and it shuts down. Repeated shutting down because there is an ICAD with a ruptured plaque. So it is a rough surface. Immediately it attracts platelets and the thrombus forms and it gets occluded. So we have to go inside and put stent and load the patient on antiplatelet. So there are 2 stents placed in this patient. So I'll show you another patient. He has hepatomegaly. He's a liver disease patient and he came with this stroke. We did not want to put him on blood thinners, so we did the angio and there was distal stenosis. So again in our practice we are seeing the M2 stenosis. After the thrombectomy we took a shoot and we can see there is M2 stenosis and we don't want to put stents as joys. Plus he was a deranged liver disease patient with deranged profile. So we did the plastic, we gave him some tirofiban and he's stable, he's undergoing treatment for this. You can see there's repeated occlusion unless we do a proper plasty and keep them open. So when we see these kind of diseases, we know that we have to act much more than just giving the dual antiplatelets. So I'll show you another patient where we had suprachoroidal ICA occlusion, big chunk of thrombus, and we do the repeated thrombectomy. There is MCAs occluded open, and then we realized that it's suprachoroidal ICA because initially our DAC was distal. When we took our guiding behind, we realized that there is high grade stenosis, and then we had to do the plasty and see what happened after doing the procedure. This patient had repeat bleed the next day and we did not make it. So when we treat them with ICADs, with mechanical thrombectomy, results are not always good. These are the telltale signs. So various factors lead to our decision making, the size of infarcts in acute situations, and depending on that, we load them and take our decision of whether doing only angioplasty, which is submaximal, or doing a rescue stenting. So I had a case last night, actually I have not slept whole night, I had a new acute stroke. I'll show you that case, and it was an ICAD with hyperacute stroke. Before that, I want to show you that about MRI vessel wall imaging. It's a very good tool, and it's a very good tool to understand the disease that we are dealing with, the ICADs that we are dealing with. We are doing these more regularly in our patients. So this is a 52-year-old male. He came to us with slurring speech, very high profile patient, and he had 3 strokes by the time he came to us. This was his angiogram. 52-year-old male with hypertension and the risk factors. Okay, and see stenosis, and we want to put the stent. But then we thought, I'll just take one more minute. So this was the patient. We thought, okay, we'll go ahead and we will do the treatment. Then my junior consultant said, let's do the vessel wall imaging, which we are doing for other patients. And at the same time, I want to show you the scan. The patient's relative also came to me with the scan, which was done 4 months ago. Arteries were completely normal. In 4 months, ICAD did not evolve to this situation that the M1 and also partly ACA is also stenosis. And these were the multiple infarcts. So we thought, okay, yes, we will go ahead with the vessel wall imaging. And this is what we got. There was circumferential enhancement of the whole artery. And these are the points or the parameters on which we decide our vessel wall imaging. And this fell into vasculopathy, and we had to stop, tell them that, okay, we are not doing stenting and we are doing conservative medical management. And we raised the blood pressure because on too many antihypertensives, we have to keep blood pressures high in these patients, systolic high, so that the perfusion is maintained. At the same time, in the same week, this another patient came, 50-year-old lady, who had headache
and TIS of the left side of body. Again, she has a T kind of lesion. This was before the first patient, so I was like, we have to do vessel wall imaging, this can be vasculopathy. And when we did the imaging, all features were very classical of atherosclerotic disease. It had eccentric thickening, partial or minimal enhancement, all the features. Patient who also I saw around a couple of close friends of mine. Now I suggested them that endovascular treatment can be done, but because he's a doctor, he read about a lot of articles, and he said, no, best medical management is what I want to go with because of the articles. And they are waiting, and I hope that he doesn't get the second stroke. But yes, this is one of the cases who is at high risk of repeated stroke. Now I'll come to the last night case. So this was a CT scan with evidence basilar. There was basilar which was partially seen in the middle segment. And this was the MR when he actually presented to us. That CT was done yesterday morning elsewhere, and he was still conscious. When he came to us, he was unconscious, very high NIHs. And these were the scans. There was evolving diffusion restrictions. And very small one in the pons. So we went ahead, took the patient, and this is a loopy vertebral at the middle of the night. Right PCA is speaking, so we don't have to support from the PCA as well. And he took the devices and took the angio. You can see the telltale sign of ICAD, which I showed before, a narrow tapering end of the occlusion. So we went ahead, we put the retriever just to see how is the flow, and this was what we saw with the stent trigger in place. Big chunk of thrombus distally, high stenosis in mid-basilar. Now there is no way to take this clot out till we open the stenosis, otherwise it will squeeze and spread everywhere. So we took out the stent trigger and then we took a balloon. We did the plasty. After the plasty, you can see there's a thrombus there also at the level of stenosis, and the PCA is occluded now. So we took the stent trigger again, distally, and now we took out the whole clot. And before plasty itself, we started tirofiban infusion, because we have seen once thrombus starts forming and then you start tirofiban, it becomes an irreversible phenomenon, and we end up putting stent. So this was after 15 minutes. We took shoots after half an hour, and we gave the tirofiban infusion. As of now, he's been planning to get extubated. CT is looking good. And this is the clot which came out from the distal area, distal to the stenosis. So it is so difficult that these cases with high-grade stenosis, when the plaque ruptures, there is embolic phenomena, there is decreased flow and thrombus formation. So we should act before we land up in this kind of situation. So with this, I would say that the ICAD, when you see a stenosis with hypoperfusion or embolism of four collaterals on TSA, stenting is beneficial. Perforator strokes, you may think of doing medical management, because when we do stenting, if you believe that slow plowing will cause more stress, is what we are doing in many patients, but yes, these are the patients who can be managed medically for some time. Avoid stenting in the first week of stroke. It makes a lot of difference. Operator experience is very, very important, because it causes a major difference in outcomes. So training is very important in taking these heavy-duty systems into the brain. And the advancing technology has made it really feasible for us to get better results with lesser complications and have long-term. Many of our patients of those 200 have not put the follow-up results here. They have very good, stable results over 1 to 2 years. The stents are open. In-stent restenosis rates are not very high with drug-eluting stents in our practice. And BP control is very, very important. And at the end of it, it's all a teamwork. Thank you very much.
Thank you, Dr. Two great presentation. Because I may request you to come to the podium so that there could be one question from the side. You can go there on your guys. Let the experienced man start the question to Rasmi. Yes.
What right now generators testing is good work, right? But till now data suggests that stenting has not added up any value to the aggressive vessel management, because the Santos trial ending up in Cassis trial on China. What you have shown is actually it's a good work, good individual work. But again, add to the patient's value or not is a million-dollar question. Till now the data suggests that it is not of use. Or rather, this more harmful in subgroup patients. You have done the subgroup analysis of the sample study, say that operator, the author himself, the main lead in the study, the sample study, himself was commented that those who had done the study there were the big sets of names in US where they have lots of oil and stenting and everything. How can they could be, because in the analysis of the sample data they have suggested that probably they are inexperienced endovascular persons. He himself refutes that because they are the most reputed people in this endovascular clinic. As far as the raging data is concerned, probably stenting is yet to be seen as that rescue thing. In some limited cases, what we said as the apparatus, long segment basilar artery or other sense of carotid artery, stenting can help. But overall scenario is the utility of endovascular treatment is probably still not very accurate as far as ICAD is concerned.
So the point well taken that samples trial is something which is system to everyone, but those people, the centers that you are mentioning, the subgroup analysis, wingspan was a different technique of stent. You have to do exchange mechanism. Not everyone is very much accustomed to the exchange mechanism because the wire tip has to be kept in vision and you have to be careful about the tip. So those good operators that you are talking about, they only got together and they did the weave trial. And in the weave trial, it was found out that the risk is 2.6%, 157 patients. Number of data is not less data, it's a good number. But here it was more control on the endovascular arm. There was more focus on the aggressive medical management. And the endovascular arm was not taken with that focus or that interest. And many centers which were not used to wingspan stent is a different stent to use. Now we have a technology where you don't have to exchange. And once you don't have to exchange, the risk of complications becomes significantly low. The ICAD stents which are there now, they are not requiring that much of skill which wingspan required. So that's why the results of studies now are much, much better. 2.6% is the result of the weave trial, which is very, very good compared to samples. In fact, around samples also I showed there were multiple wingspan registries going on. None of them showed as big a complication as samples. Samples had lots of other pitfalls. It would take an hour to talk about those subgroup analysis. The wingspan itself showed 4 to 5%, 6% at different centers. So as you rightly said, how do we then define consensus for stenting? I would say that wingspan first of all is not available with us here. So we have devices which are much more easily navigable. We don't need to exchange, and the disease that we are dealing with compared to the Western population is very different. We have much more recurrence of strokes. We should try and develop our own data rather than relying on their data because we have better results and there are a lot of studies which prove that the complication rates are less than 4% for endovascular arm, except for certain complicated situations where this could be higher and that may increase the numbers.
So now is not about the complications of complications in separate study of you are recommendation. But it has not contributed, that is more important. What you are saying is a big chart. It is the perioperative procedure of risk of the complications are less. That doesn't add to the value that prevents the recurrence of stroke or not. It is significant. That is more important. Second, as far as you talk about the European studies, the TASIS trial, the Chinese study, there are number of patients, but that also has failed. Probably you are a better person to answer this question of how it is different.
So I have shown you one slide of that COVID trial, and that COVID trial shows that 1 year stroke risk is only 5.4% in patients who were treated by endovascular stenting, which is very low compared to the other trial that TASIS or samples that you want to talk about. The risk of strokes was way higher, 9 to 10% risk of strokes at 1 year. So at 1 year, the risk of strokes are much lesser, and especially in our population, we are dealing with plaque rupture. Our cases are where plaque ruptures, and the moment you put a stent, it stabilizes the plaque. And once you stabilize the plaque, the recurrence rate, like in our practice, the patients coming with repeat strokes than we have. We do have patients who come with repeat strokes. They are less than 2%. So our plaques are different, our morphologies are different, and I think that the technology that we have, plaque stabilization, is happening really well. And 1 year stroke risks are lower in Southeast Asian population in the endovascular arm, especially with the movement trial. It is very well proven, and we need to do more trials to understand that.
Do you know whatever the Japanese and Chinese have projected? It's not very spectacularly different. At most, we can say the stenting is an additional support system for the ICAD patients, which I agree that in certain cases, difficult cases, maybe that's zero. But to replace it altogether, I don't think. If it is that kind of fibroid,
Can we have Dr. Gaurav?
Dr. Gaurav?
Sorry to jump in between. So, only, I think both of you made very good points, and data is getting into points. But I think primarily, again, the problem is because we are consolidating everything in one go. So, if samples, like, how many patients do call up and say, have you eaten the medication, have you exercised today, what's your blood pressure, what's your sugar level? And samples for 90 days, the nurse called each patient every day, recorded that data, ensured that they are exercising, they are working, their blood pressures are in control. We don't have time to see the patients who are waiting outside in the OPD, forget about the patients doing this rigorous follow-up. So I think that is one issue. And as Rashmi said, like in VARUN trial, it is shown that if you take away the perioperative risks of step prayers or leave or whatever, and just look at how these patients progress over a year, the risk of stroke does get reduced as compared to medical management. But having said that, we are also not suggesting to do it as a first opportunity in every patient. But somebody with a 99% basilar artery, we wait on it to die down on us and patients to crash. I think that also needs to be taken into consideration. So I think 70 to 90% is a different disease, 90 to 99% is a different disease.
But would you not go for the collateral circulations in such patients, even if it is a 99%, the collateral circulation is actually making the patient mobile. So in that patient, instead of, it's just a discussion, sir. If that case comes tomorrow, I get my endovascular person to see. They are sitting there. You will say, I will put a slit, I say, will fine. But I am saying, in such a patient, is it not to look at the aggressive medical management and keeping an eye on the collateral circulation alone, rather than just focusing on that 99%?
So, point where we can fair Rashmi can answer that. She is the debater.
See, there are multiple studies which have been done on hemodynamic mechanisms of ICAD, and it has been found where the distal flow is less and patient is depending on collaterals. The recurrent strokes are very high, and the plaque rupture incidences in Indian subcontinent is very high. So in those scenarios, we know in our practicality that we are going to see this patient as a hyperacute stroke after 3 to 6 months, 5 months or 1 year. We don't know the time when this patient will come back with hyperacute stroke for sure. So if you have a collateral support, that is all the more indication that we should go ahead and put a stent, unless until there is an anatomical configuration which suggests that procedural risks are more than 4%. Suppose the arteries are arising, too many perforated trunk is arising from the level of stenosis, and we know that most of our anatomical results will show that yes, complication risk is high, then we may withhold, otherwise you can go ahead and stent. And a point about the CASIS trial, in China, the ICAD numbers are unimaginable. They do 50 to 60 ICAD stenting in a month. That is the number. So they do lots of stenting for the moderate stenosis as well. And we already know that in moderate stenosis, medical management is also very good. CASIS trial is not a very well-defined trial like SAPRIS. It is not very well-defined in terms of percentage. That is what big report of CASIS trial. So many patients are of moderate stenosis. That's why medical and endovascular has not given any added benefit to the repeat strokes at 1 year.
Can I ask you a question? After stenting, do you still give aggressive medical management or stop?
there's no question of stopping Aneurysm.
Yeah, so this stenting is just additional.
Additional, that's what I said now. Stenting is an additional one step plus the additional.
So there is nothing called controversy. Medical management, you have to add stenting. But I just want to know one answer. You said the recurrent severe stenosis rate is only 2%. The recurrent stroke rate is different from the re-stenosis rate. I want to know because I was just discussing with a cardiothoracic surgeon. He said following coronary stent, the re-stenosis rate is almost 15 to 18%. What is the re-stenosis rate in intracranial stent?
See, the re-stenosis rate that has been studied with, the studies have not been done there have been comparison for bare metal stents and drug-eluting stents, and all those studies do show the re-stenosis rate, which is going in the range of 10 to 15% also in certain cases. But re-stenosis is not just a phenomenon because of the stent. There are multiple patient factors also play a role, like diabetes is under control, lipid profile is under control. So we do see the re-stenosis rates, and we are at times, I'm talking about the significant re-stenosis, which is like requiring retreatment.
So what do you do for those group of patients? You have done in this medical management, you did stenting, they again come back with the re-stenosis or recurrent stroke. What do you do for them? Do you put them alone?
If that patient had got a re-stenosis, then you have one choice, I will go for a stent. Because you have to, at least you have to give one layer of support to the patient.
Yeah, now we
because if the practice medical management is optimized, most of the cases the problem is not optimized. The patient has not taken medicine, the patient is not come for the follow-up, which is more common in the Indian scenario. If that optimization is ensured or assured, like the patient has got a stroke patient has come, day in, day out to see such patients. Patient has come and stopped medicine for 3 months. Patient has not taken the insulin or sugar medicine because insulin, once it starts, it will become a habit for him. So once they go back, then you can't suggest that what is to be done. But if the optimization is ensured, that yes, Aneurysm management is followed in such patients, like examples, what they need, not for the 90 days, actually they gave it for 3 years. Medication was supplied free, all this physical activity and all these things were supplied and followed up. 3 years, the system was company and GJ of some company was interested in that. We are not following in that way, so I am not ready to suggest answer if the optimization is attended or not. If attended, this is critical for next Aneurysm.
No, you have done first medical management, when you add stenting, 20% come back with re-stenosis. Why don't you suggest bypass them? Because that's the right indication.
Even
why they leave the patients? Bypass. That is what has helped many patients.
What you are saying is right, but it has been also the studies proven that it doesn't do any better for the patients compared to the
So that was the old 1985 study. But
So Dr. Manas, I can understand your question. So you're going towards the AC,
when this phase, ECIC bypass has a role. And its patients should not be told that nothing can be done. And there are papers have come that in those cases, EC bypass has helped. We cannot quote 1985 study that EC bypass doesn't help, and wrote that patient that told that EC bypass will not help to go back.
Frankly speaking, in our practice, we do give the option of the bypass to patients who are like having very high risk of endovascular procedure. At least one patient I can remember, it was an MCA stenosis, and I knew that if I do something, she will have big stroke. And she was coming with repeated GIs, and we sent for bypass, and Dr. Misha was the consulting surgeon for that patient. But at the same time, the risk of the procedure of STMCA bypass was also not less in those situations. That patient eventually did not go for bypass also, but yes, bypass is a very, very valid option in patients where endovascular treatment is not possible. So if re-stenosis has happened, we can do angioplasty, we can put a second stent to them. In fact, last week only I had a thrombectomy where patient had drug-eluting stent in MCA, he stopped his antiplatelets and for 3 years, and when he came to us, when we took the catheter, we aspirated and there was high-grade instant re-stenosis. We did the angioplasty and with that, patient was stable. So we can do endovascular treatment if re-stenosis happens, but whenever endovascular treatment has high complication risk, we always take an opinion for surgical bypass, and I feel it's a wonderful option. for those patients.
What my point of emphasize is that the risk of endovascular or surgery, which are similar, and one should not tell that surgery has a higher risk in endovascular, you go for a second endovascular procedure. But the reported complications.
Maybe we can start with trial.
Yes.
So, anybody from Shrita, you have a question?
I am Karnataka cardiologist surgeon. The point when you mentioned that stenting can cause plaque stabilization, I am not able to understand the concept because I know medical therapy only can stabilize the plaque. How can a stent will stabilize the plaque? Because if there is a plaque is there, if it's about to rupture or ruptured, usually stent will further make the implant process more. I don't think stent can stabilize that. Only medical therapy can stabilize the plaque. That is the, I think, described concept. But because what is it?
Dr. Parekh, so basically when there is a dissection and you have a flap coming into the lumen, putting a stent is going to stabilize.
Yes, dissection I understand. But implant plaque or a plaque rupture, I don't know. Maybe Dr. Hemant can tell because they are putting a lot of stents cardiology.
So when we place a stent, okay.
It's a wonderful debate. I just enjoyed a lot in cardiology, but I was in brain almost on the half or 1 hour. Actually, debate is not much finishing. I think I would agree with both of your strategies. Because we deal with a moderate to severe stenosis. Naturally, we have the major data to support medical treatment is the best way to approach this, especially manageable stable patients. But when you end up in some kind of complications of the symptomatic world, I think rusty approach comes into the real picture and the light does a wonderful work the same way. What I'm talking about plaque stabilization, especially yes, the plant is different morphology inside. The morphology itself has a lot of walls on the wall itself. And you have aggressive attention to what Dr. Parekh is trying to convey. Absolutely, the effect of statin as well as the antiplatelet, they do come to fight the inflammation, no doubt about it. But as the way was specifically highlighting, when you have a ruptured plaque, dissected plaque and obstructing lumen, definitely that will have mechanical therapy on that. So coming to proton pain, I think I agree with both of you. But if I'm the patient, I'm recurrent illness, referred to the stroke, and instead of having medical therapy on, I would prefer Dr. Leslie's help, and that should motivate everyone.
That's ultimate.
As you mentioned, there's a advanced reservoir imaging. So as you have told the role of advanced reservoir imaging. So which patients will get subjected to that imaging and what is the advantage, diagnostic advantage or there should be a patient selection for undergoing all these things, advanced imaging, or is it waiting for all the recurrent strokes?
So reservoir imaging initially started when we were seeing patients of vasculopathy or vasculitis. So we started doing reservoir imaging for those patients. When we were seeing younger patients with intravenous arteries, and we wanted to understand what is going on in the wall of the arteries. And that is how the reservoir imaging started. And we then saw the T lesions, kind of the T lesion that we see, suprachoroid ICA, ACA, MCA, stenosis at the level of bifurcation. So they are really very confusing lesions because they can be also because of vasculitis, they can also because of atherosclerosis. So later on, as now we are seeing many younger patients with strokes and many younger patients with diabetes, especially post-COVID. I don't know why. We are seeing patients at 3 years old with 3 years of diabetes and patients coming with strokes. So we are confused. Now we have younger patients who have atherosclerotic disease and who are coming with stroke. So we are using reservoir imaging more now in our practice, especially in 30 to 50 years age group. When we have any confusion that it is not classical intracranial atherosclerotic disease, either by history, if they don't have any comorbid conditions, or by image, by the angiographic finding, it is not very typical of atherosclerotic disease. Then we are doing reservoir imaging, and it gives us a very clear answer that whether we have to put the stent or we not. At the same time, we are also learning the nature of the plaque. With the 3-Tesla imaging, you can see hemorrhages in the plaque. Like we are talking about the plaque which is vulnerable or which can have cause recurrent strokes. So we are finding that especially hemorrhage is something we can see in those small vessels, vessel wall imaging. So we are trying to see that whether there is eccentric thickening or there is enhancement. So patterns are being assessed to understand that the recurrent, I think the future is to understand whether the recurrent strokes frequency is more than the particular narrowing or not, and based on that, stenting can be given. So that is the future of ICAD. Those trials are still confusing. I have my own trials, he has his own trials to support the fact, but we have to have science behind it. So vessel wall imaging is giving that science to us to decide about this. Second thing is intravascular ultrasounds. We have OCTs, which are still, the probes are not there in India, but they are there in other countries in the research process. Once they are there, you can do intravascular ultrasound, you can understand the plaque, and then decide to put the stent whether it will be done or not. That will be the science. That will take a few more years.
That's a very fiery debate, but Dr. Dalai sir, I think we should use this platform to come to some clear consensus and guidelines, because I think we can't put these spirited debates bedside in front of the patient. Okay. So I think we need to have those clear-cut recommendations and consensus. Maybe next time we can develop a platform where we come to some consensus guidelines. And I have one question for you, Rashmi Shah. In one of the slides you mentioned about the timing of the endovascular is exactly when it should be done. But most often it happens that you do a mechanical thrombectomy and you come across that the patient is having stenosis or recurrence. So you still wait that 4 weeks of waiting period to do it at the same time.
That time was for the patients who presented with stroke which was not in the acute window period. They were not called hyperacute strokes. The patient who had a stroke and they came after the window period, or patient had a TI or some small ligaments.
So anyone who comes to the window period and you are planning for thrombectomy, you can plan for a endovascular procedure at the same time.
Yeah, I showed you many cases where you have no choice of shutting down. If we leave it as such, patients will have big strokes. So we have to put we try angioplasty, we try giving tirotopan infusion, and then if it doesn't work, we still have to say we have to put this. We have to take the risk.
Thank you for the speakers. I want everybody to give a round of applause for them for having 80 minutes of continuous talk. Everybody sees through what they know. Both of them are talking about medical intervention at the same time. Manas also told that surgery is also important. As a previous conclusion, Suresh, the expertise of that field is more important in decision. And finally, very nice and thank you very much. You have gone through all the studies from WASIP to CAP2 and the REAP to the and AHA and the studies. All are very nicely explained. Thank you all.
You may say I am a dreamer, but I am not a dreamer. So we have come to a conclusion and we agree that how we manage ICAD. I think great debate by both of you. And we'll break for lunch. That will be for 1 hour. And we'll exactly gather after 1 hour for the next exciting session by Professor Manas against Professor Uday. That is going to be a high-octane debate after lunch. Thank you so much.
Thank you so much for a very big discussion. This is really a big discussion. I think the organizing and chairpersons are happy as they put it as a battle now. It went till all the multi-specialities. So I would request for a token of appreciation memento for both the great speakers, Dr. Mohan Maharaj sir and Dr. Veeranath sir. I would like you to present a token of memento as an appreciation to symbolize our gratitude to Dr. Vikas Kumar Mishra sir for a great discussion, Clinical Director and Head of Department Neurosciences, K Hospital, Bhubaneswar. That's really a great discussion, sir. You have answered all the questions. Then we would like to call Dr. Krishna Haskar sir and Dr. Sunita ma'am to give a token of appreciation, the memento, to Dr. Rashmi Shah ma'am for a great discussion and answering patiently to everybody. Thank you ma'am for diving into all the complexities. It's a great discussion. Dr. Rashmi Shah ma'am, Chief Division of Interventional Neuroradiology, KEM Hospitals, Mumbai. Now I would request Dr. Dalai sir to give mementos for all the chairpersons. Dr. Mohan Maharaj sir, kindly take our token of appreciation. Thank you for your time.
Dr. Krishna Haskar, sir. Thank you, sir. Dr. Sunita, ma'am. We appreciate your question and thank you for your time. Thank you so much. Now we will proceed for a lunch break. So the morning session has been incredibly insightful. Let us now refuel, recharge, and again come back as we are having great battles in the next session. So we prepared a delicious meal, variety of options, even the dining preferences. So make your way to the dining area.
Hey, check this. Check 1, 2. Check this. Check. Check 1. Check 2. Hey. Hey, 1, 2. Check. Check 1, 2.
On surgery for brain arteriovenous malformations, Dr. Manas Kumar Panigrahi. We welcome you, sir, onto the dais. HOD and Senior Consultant, Neurosurgery, KIMS Hospitals, Hyderabad. Our expertise and has extensive and vast experience. Undoubtedly here today for enlightening us the latest techniques and strategies in managing this complex lesions. We welcome you, sir, with all warm greetings. After shifting the gaze for the Clash of Titans, I would like to invite our second speaker to speak on endovascular management, Dr. Uday S. Limai, Chief of Neurointervention, Leelavati Hospitals and Research Center, Mumbai. So it's Hyderabad versus Mumbai. Sir is known for his exceptional skills in minimally invasive neurointerventional procedures, contributed significantly to the advancement of neurovascular care.
Good afternoon. I'm surprised that a lot of people are there to listen after post-lunch. I have not come to fight or do a battle with Dr. Uday, but it's time for us to battle with our sleep post-lunch siesta. And So I have changed the format of presentation. I am not presenting a didactic lecture of supporting my thoughts of surgery. I'll present 5 cases and ask the panelists what they will do. And I'll stress on Dalai and Dr. Uday, what they will do. They will do surgery or not. All of us know that AVMs can be present 2 types, ruptured and unruptured. And if it's unruptured, one can do observation, can do microsurgery, do embolization, or do radiosurgery. And I'm sure Dr. Patra will always tell I will give radiation for all cases. But if it's ruptured, then one cannot observe. One has to either do microsurgery, embolization, or this patient came with sudden onset headache with large bleed. I'll just ask, start from Dr. Uday, what you'll do, just one choice only, what you'll do for this, surgery, embolization, or radiation? Can you give the mic to them? Patient come to emergency with hematoma and sudden onset headache and with a large hematoma.
Working? That's working. You can speak, sir. Light is not on, but it'll...
Yeah, we'll start from that side otherwise.
Yeah, so when patient is in emergency with acute bleed and probably neurological deficit and the scan shows this, the first thing that we should do is give contrast to prove that this is what our topic of debate is. It
Yes.
may be something else and it may just require observation or maybe surgical evacuation or decompression.
Yeah,
So
and
first thing is to try and diagnose why there is bleed.
Yeah, this patient is a non-hypertensive patient and the bleed was not in the classical site of a hypertensive site and it was coming till the ventricle. We thought it's an AVM, we did angio, it was turned out to be an AVM. So your preference will be surgery after knowing the diagnosis or endovascular embolization?
It completely depends on how good or bad the patient is doing. If it doesn't seem to be too much life-threatening mass effect, but it is developing.
Yes.
So if patient, of course, has been referred to you and you decide that this patient needs to live first before the AVM is treated. And so decompression would be my first choice and stick to decompression only.
And
Decompression
no
or
excision
evacuation
of
of him. No, don't go to the AVM is what we would do.
Okay.
Can we see the angiogram?
I'll show you.
Can we see?
So, no, this shows an...
thinking that it is a bleed which is non... I won't say that it per se needs decompressive craniotomy. If there is an AVM which can be tackled by endovascular method, we can do that and still observe for any sign of mass effect.
Now this patient has come to emergency in GCS of 12 and already mass effect is there in the scan. You can see the mass effect. So what will be the CT brain angio and what we'll do? We'll do endovascular, do surgery, hematoma evacuation with AVM excision, or as Dr. Uday said, he'll just do suggest hematoma evacuation, no AVM excision.
What is my thought process is even if you do an angio and embolization, we are not excluding a surgery, surgical excision of a residual AVM if that is left, or even a clot evacuation. All these are possible after embolization. So I won't mind doing an angio if required an embolization in this case. Quickly.
Yeah. Dr. Satyabara Prasad, surgeon.
First we have to see the angio. Angio, and depending upon that, if it is superficial, evacuation of the hematoma as well as excision. Simultaneous surgical.
Okay. So that becomes cost-effective treatment because with one surgery, one can give the treatment as well as the mass effect comes down. And embolization means you have to stage it. If you do partial only hematoma evacuation, then again one has to go another procedure of embolization. So what we did was we we excise the AVM along with hematoma evacuation. And so that was so this is one indication in AVM. When they come with hematoma with mass effect, the first treatment option logically becomes surgery. And most of the time, AVMs, 75% of the time, they present with bleed. Only 25 to 30%, they come as unruptured AVM. We have confusion in treatment when they come unruptured, whether to treat with radiosurgery or treat with embolization or surgery. But but most of the cases of AVM come with hematoma as an emergency, they will need surgery. And we do not suggest a delayed treatment because the chances of rebleed also is there. And the chance of mortality in the first hemorrhage is 10 to 30%. And if it's a rebleed, it doubles, 20 to 30%. So if you just do hematoma evacuation and do embolization, you are having the risk of rebleed during the hospital stay. So the mortality with the first hemorrhage is 13%, with the second hemorrhage is 20%, and third hemorrhage is 25%. So one has to prevent this rebleed. That is why one has to do an early treatment. It's not like an emergency like an aneurysm, but AVMs also rebleed in the same admission. The second group is the unruptured. 30% of the AVMs are unruptured, and usually they present with seizures or headache or a progressive deficit, and 10% can be asymptomatic. So this asymptomatic group, probably one can go for observation, but if they come with seizures or headache or progressive deficit, one has to offer treatment. What modality is what panelist will decide. The natural history of AVM, if left alone, like if you observe an unruptured one, which are symptomatic, then the risk of hemorrhage yearly is 2 to 4% if that has not ruptured. But if the patient has come with a rupture, the risk of hemorrhage within the first week almost triples. So that is why one needs an early treatment. So one has to, when a patient comes with a first hemorrhage, the recurrent hemorrhage rate is 6 to 18% in the first year, and it declines over a period of time. The easiest way to calculate the risk of hemorrhage is 105 minus the age of the patient. And this is a simple equation. So the higher the younger the patient, the higher the risk. So if a younger patient needs an early treatment, an elderly patient, one can think of radiosurgery or conservative treatment. Normally we think that large AVMs should have a higher risk of bleed, but it's not true. That is, logically we think the larger that's more dangerous, but it's not true. The smaller the AVM, the higher the incidence of rebleed. Hence, small AVMs which are easy to treat or easy to excise, they can be treated as an emergency also. The location also basal AVMs, like in the basal ganglia, periventricular, they are difficult to surgery, but they have a higher risk of bleeding. Hence, they need to be treated, and these are the cases where radiosurgery or embolization is suggested because surgery risks are higher. Now, there was a study of Aruba trial in 2014 of unruptured AVM, and they took 116 cases, and then they reported, they compared with 107 patients who had medical treatment. And the complication rate was 33% in the treatment group and 10% in the medical group. And they concluded that probably observation is better in unruptured AVM. So this is what was they concluded observation is better, but then there are a lot of controversy in that study because in that many of them had only embolization, many of them have surgery. Surgery was only done in 10% of the cases, 10 cases of the 107 cases. So the conclusions were not acceptable. So among the unruptured AVM, the commonest presentation is seizure. Now this is a 23-year-old girl came with intractable seizures, and we did an EEG and confirmed that epileptic zone is surrounding the lesion. So what will suggest then for this patient? Dr. Patra, patient unruptured seizures, 23-year-old girl.
If volume is less, we can go for the stereotaxy.
Radiosurgery. Yeah, but this child has come with intractable seizures. So we have to offer treatment for the intractable.
Medical
So
management.
whether with radiosurgery, because medical management has failed, he has come to us. And when MRI was done, it found an AVM. So just giving radiosurgery will control that lesion, but seizures control.
Seizures may not be controlled, it will take time. But we can medications with
You can comment on that.
Dr. Shivaram, neurologist. So first we have to localize whether the seizure cause is that one or not.
Yes.
Because in most of the patients, even after removal of AVM, we see the patients are still suffering with seizures.
Correct.
So for this patient, first localization is important, sir, for that seizures, intractable seizure. If at all cavernoma is the only, that AVM is the only reason, then probably we have to go ahead with the management of that AVM.
Yeah, so that's what means here the patient doesn't come for headache, he has come for seizures. Seizures has to be controlled. By doing this embolization, radiosurgery and radiation, the seizure will not come down.
Yes.
So first we do a pre-surgical evaluation, confirm that seizure is due to this place, and then when we operate, we excise the epileptic zone around the lesion, because the brain around the AVM also is epileptic. Unless we remove that, the seizure will not come down. Hence, embolization and radiosurgery will not work. So one has to remove the AVM along with the epileptic zone of cortex surrounding that. So it has to be done with a corticography intraoperatively. So if the patient comes with only one seizure, you can give anticonvulsants and give radiosurgery. But if intractable seizure, surgery is the choice in this case. So, but this was in the motor cortex. So this was the MR angio, and so we did with navigation. Doing the MR angio was integrated with the navigation, and surgery was done. Patient had a temporary post-op weakness which recovered. I will not show surgery and all those. So he had a weakness, but he was seizure-free for become 1 year follow-up. He was seizure-free. The seizure risk with AVM treatment, with conservative treatment, there is controversies in treatment in the literature, and whether one or two literatures has commented that the seizures get controlled with medical management and radiosurgery, but most of the literature, they have concluded that microsurgery had the highest risk of seizure freedom when compared to radiosurgery in patients with intractable seizures. Case number 3. This is a 28-year-old pregnant lady in second trimester, comes with a ruptured AVM, and this was the MRI. Dr. Anil, pregnant lady with a bleed, second trimester. What will you suggest?
Not even DS, she's second trimester, right?
Yes.
Intervention is probably, what do you say, sir? Intervention in second trimester?
You know, I have completely a contrasting opinion here. We have done many pregnant women with neurovascular disease, aneurysms, as well as AVMs. And nowadays, since last 5 or 10 years, I'm of the opinion that we don't have to intervene early. We can either terminate the pregnancy if that is required by the gynecologist, or we can have the full-term pregnancy, let her recover, and then we can treat this. Previously, we used to feel that it's a ruptured AVM, so we have to intervene early, but of late, in the last 5 or 10 years or so, I have completely reversed that strategy. We wait, we observe, and then we do the treatment later. It's not an aneurysm which is acutely ruptured.
In an unruptured, I agree, but a patient has come with a ruptured AVM.
No, my suggestion is that once you have such a patient who is in second trimester and ruptured, why not to look at the angio architecture? Like, for example, a patient is having an internodal aneurysm or aneurysm in the feeding artery, or there is a stenosis in the draining vein, or there are multiple high flow fistulas. Then there is a high risk for this patient to rebleed, where we might consider the intervention of whatever kind may be safer than waiting. Because I have seen patients who have very critical stenosis at the draining vein, they rebleed within a week, within 2-3 days even.
Yes.
So without looking at the angio, I won't say that I will wait.
Correct.
Or I will intervene. So I will look at these features. Is there an aneurysm in the artery which is feeding the AVM? Is there an internidal aneurysm, couple of them? Or there is a stenosis in the outflow vein? That will make my decision easier to intervene or not.
Yeah, so this is what, instead of presenting the theory, what he told was, you do an angio, and then if you have an internidal aneurysm or associated aneurysm in the flow-related aneurysm, or if you have venous stenosis, then they are high risk to bleed, have a second bleed during pregnancy. And as we know, that in pregnancy there are cardiovascular changes, they have a higher chance of rebleed than a non-pregnant lady, and especially during the delivery. Hence, one has to do a calculated risk, or if you try to observe, then patient has to understand and take informed consent that if there is a bleed, that he has taken the consent along with the physician. And if he doesn't want, then second trimester is the best time to intervene. Third trimester is not a good time. And second trimester, as Dr. Uday said, there are few papers who have come that one can do embolization also in second trimester, but with the potential risk of the radiation-induced damage to the fetus.
Yeah, that's the problem. That's the major problem.
Yeah, that is what I was thinking, and we operated this case, but I was looking at the literature, the few papers, they said they did not have any problem with the fetus. But then there are only case reports and small series where they did embolization during the second trimester.
Even for exposing a patient for radiation, a pregnant lady to radiation, second trimester is the safest, is considered for anything. You want to expose a lady who is pregnant, you want to expose radiation for whatever reason, then second trimester is the safest. And third trimester become cumbersome because of the large abdomen and all. So that's why second trimester has been reported as safest for embolize.
So compared to embolization, as it involves radiation-induced damage, we thought surgery is safer, and we offered surgery, and we operated this patient. So this was he did not have any risk factor in the angiogram, but then because he was pregnant, we didn't want to have a rebleed during the pregnancy period. And this was an easy surgery because it's a focal nidus. This is case 2022 operated. This is again a 48-year-old lady came with this MRI with only headache and seizures, which was controlled with anticonvulsant. And this was the MRI. You can see that the AVM in the temporal and the sylvian area. And this was the angiogram. Angiogram showed that in addition to the AVM, there was an aneurysm also. You can see in the ICAD, there's an aneurysm here. So, Dr. Uday, what we'll do? AVM with an aneurysm, it's not intranidal, it is in the flow-related aneurysm.
Yeah, so this is completely a different aneurysm than an intranidal aneurysm. Yes. Because for a long time we have believed that intranidal aneurysm can be a result rather than a cause of the bleed. So if the aneurysm is on circular bliss, I would put that as first priority, above the AVM.
Yes, if it is unruptured. But if it's a ruptured, this is an unruptured one, yeah. So you will treat the aneurysm first, followed by AVM. Okay. Any difference in opinion? Or you treat both? Why not you don't treat both together? Dalai?
Look, when we are looking at an AVM, which has a large aneurysm, which has a propensity to bleed, so we understand that that is the risk factor for the AVM to bleed and make the patient sick. So if you have taken care of the aneurysm, the risk of the AVM without that intranidal aneurysm or aneurysm on the feeding artery is very, very low. So it is always easy for us to leave the patient for some time after treating the aneurysm. And we love to stage the procedure so that the risks are less, the duration of treatment is less. So it's very easy for us to just treat the aneurysm, leave it, because the AVM without the aneurysm has become safer, and take it in the second session.
Yeah, but the aneurysm is a flow related. It can again regrow, is it not? Because the AVM is there.
It takes quite some time, as you know. It is not going to
so you will suggest radiosurgery for the AVM or not?
We suggest, but it's a large one.
Or surgery?
It's a large one, so we won't, yeah, surgery is also a good option whenever there is possibility. But
And-
radio surgery
and
for
if the-
this big AVM is not a
If
good
the
option.
patient had come with a rupture, with an aneurysm, what one will treat, the AVM first or the aneurysm first?
Aneurysm first,
Not the AVM.
not AVM.
This patient, if it had come with a rupture and the angio shows AVM with an aneurysm, what will treat, the aneurysm first or the AVM first?
Aneurysm first.
Anybody else has a difference of opinion? No, I'm talking of the ICAD. This patient has come with his parenchyma, not in the subarachnoid hemorrhage. Yes. No. So what one will treat? Which one?
You're making it more obvious that, okay, the AVM has bled, let's just attack that one. Yeah.
You will tackle AVM first.
Yeah.
But aneurysm will do it simultaneously or not?
Yeah, but now here again, if you have an AVM which has bled and there is an aneurysm, better to handle both of them at the same sitting if it is possible. Because treating an AVM and leaving the aneurysm is, I won't be feeling safe about it.
Yeah, I'll tell what the literature says. This is that when the AVM has come with a rupture, if you treat the AVM first, even if it's not ruptured, because the flow comes down, the flow-related aneurysms decreases in size. They can have natural regression also. So many times you don't need to treat the aneurysm. But that was an older concept. People were doing the AVM first and leaving the aneurysm. But now with the flow dynamic study, they tell that actually the flow in the aneurysm increases if the AVM is treated. So it is always better to treat both simultaneously, not leave it alone. And the aneurysm and the incidence of bleed of flow-related aneurysm is less than the incidence of bleed in incidentally related aneurysm without AVM. So we don't have to bother about the aneurysm first, we always bother about the AVM. Unless it's an intranidal or proximal flow related. And so, because many of them can regress also. So the flow related aneurysms are classified into 5 types. It can be away from the AVM. Suppose there is an aneurysm on the opposite side, it's like unrelated, that is type 1. They behave like any other incidental aneurysm, their natural history of bleed. But it can be in the flow, in the parent vessel, it can be a proximal or a distal. If in this distal one, they can regress in size. But the proximal ones have a higher flow. When there is an aneurysm on the venous side, they actually are protective. Then the AVM does not bleed. So the treatment depends on whether it's on the opposite side, whether it's a proximal flow or a distal flow related aneurysm or an intranidal aneurysm. The maximum chance of rebleed is an intranidal. So if it's intranidal, that has to be treated immediately, and then one can go for embolization or radiosurgery or surgery. So as I told, there are 5 types. One is not related, proximal, distal, intranidal, and venous aneurysm. So venous ectasia is actually a protective phenomena, and it has a less chance of bleed. So if it's there, we are safer, we can probably wait. So this was the patient angio, and so this is the incidence of different type. Proximal aneurysms, the incidence is more common for 46%, the distal related at 24%, intranidal at 24%, and unrelated, like on the opposite side, is 4%. And unrelated aneurysms are treated as standalone aneurysms. But the frequency of bleeding, when AVM alone, yearly, as I told, 2 to 4%, when there is an associated aneurysm, it becomes 4 times. So that is the reason one has, if an AVM comes with aneurysm, one has to be aggressive in treatment, one cannot observe them. And we actually we treated both together. And normally we take 6 or more or 7 millimeter in a standalone treatment, but in case of AVM, a smaller size aneurysm is taken as a high, like they found that 5.7 mm is more than that in a ruptured one, and unruptured 5.3 is taken that they have a high risk of rupture. So this is what we operated. We excised the AVM along with clipping of the aneurysm together. Currently, there has been no consensus in the literature regarding the optimal strategy. As you can hear, everybody had a different opinion in the panel because we don't have a consensus. So when others usually prefer to treat AVM first, some prefer to treat aneurysm first, but it's always better to treat both together. Distal flow related can regress 80% of the time, but the proximal flow related 80% of the time do not change. And if there is a proximal flow related, one has to treat them, but distal one can treat the AVM and leave it and see if it regresses, one will not treat. As I told, that was the older concept, but with the computational flow dynamic study, they have seen that actually the flow actually, the biomechanical stress is more in the flow-related aneurysm, hence it's always better to treat both together. So the recommendation is if you have a grade 1, 2, and 3 aneurysms, grade 1, 3 AVM with proximal or flow-related aneurysm, the best is to treat together surgically if it's possible. And if it's not possible, then do at least targeted embolization of the intranodal aneurysm and give radiosurgery. It is always preferred that if there is intranodal, one can excise the AVM aneurysm together. But if it's in higher grade, then if surgery is not possible, then stage embolization followed by radiosurgery is preferred. This is the last case. This is a young patient, 24-year-old, came with a bleed, and with a bleed in the posterior fossa, and he had a AVM with an intranodal aneurysm. What will do, Dr. Dalai?
So this patient has bled.
Bled, huh?
So we must treat the AVM, especially targeting the intranodal aneurysm. And if you can just excise it completely, that is welcome.
Yeah. So we suggested excision without any embolization. Patient did not want any surgery. So we did targeted embolization and they said it's a diffuse type of AVM, they cannot embolize, and then we sent for radiosurgery. So my time is over. Thank you very much.
Thank you so much, Mike.
Thank you so much, Dr. Manas Kumar Panigrahi, sir, for an outstanding presentation. But here it's different. He has put battles for the chairpersons. This battle is also good, actually. Your expertise and insights provided us deeper understanding, sir. Thank you for joining us today, sir.
Thank you for the introduction, and it's always good to be here in this meeting done by Siva, and absolutely the most enterprising neurointerventionist that India has. So, as every speaker has said this before, that he has decided to call this a battle of this versus that and this person versus that person. And all of us at our age are battle hardened, and battle hardened not by fighting within us, battle hardened by fighting with dreadful neurovascular disease. And what we present here is completely according to our experience. So what we are showing here or saying here, it need not be taken straight away into practice, because what we mean is what we have been through. And so what we say right now, it depends completely on what our practice was for the last 20, 30 years. And so it has to be taken in that perspective. So Manas had done a wonderful job, and I will try to show our perspective on the same. Okay, so this is not, yeah, this is working. Number one is that AVM is not a simple disease. AVM is not something you can take decisions like this. It's a complex neurovascular disorder. It is not a static disorder, it's a dynamic disorder. So you have to work on it, you have to gain substantial experience in order to actually tell what's your take on an AVM and treat AVMs like complex disease. We already know by this panel that there are many, many people who are in charge of a patient who has an AVM. Unfortunately, in 80% of the times, each one of them, each one of us is looking at our perspective. What can I do? Can I add a third anticonvulsant? Can I do a gamma knife on this patient? Can I embolize this patient? Can I not just operate without even doing regular DSA? You know, this is what happens, and this is what we need to change, because we need to look at the entire animal. We don't need to look at one aspect of this dreadful disease. And so it's ideal if everyone sits together, at least the stakeholders sit together and take a call about what needs to be done. So this is not a battle. This is about, can we do this? Can we evolve a little bit more rather than taking unilateral decisions? Unfortunately, in many places, the same kind of expertise and experience is not available. And so if that is the case, then someone who has more experience in dealing with this will have to take the call. And this is where it matters. It counts that the call should not be only according to what you can do. What should be done to the patient? So the battle is not amongst us. The battle is definitely not with the patient. The battle is with this dreadful disease. It's a complex, formidable disease to treat. So Manas has said a little bit about it, and I will try and show you that how our decision about how to treat an AVM will depend on so many factors as you see on your screen, and especially the size, the location, the flow, and the presentation and seizures, of course, is important. Angio-architecture is important. Personally, after doing this for a long time, I don't give too much importance to the intranidal aneurysm. It may find as a complete surprise, but we have done or dealt with more than 1,000 AVMs treated, and I haven't found that an intranidal aneurysm has ruptured like a brain regular aneurysm ruptures within a day, within hours. It gives us time. So it is good to look at it, but I am of the opinion that most of the times the nidal aneurysms are the result rather than the cause of brain hemorrhage. So what's the intention? Can we embolize is not the intention. Can we do anything that we want? Can we treat the AVM to cure the AVM? Because we have seen for a long time, we have been doing this for a long time, that AVM which have been treated 50%, 60%, 75%, 80% offer absolutely no protection to the patient in his lifetime. Most of them are young people, and because we have practiced this a long time, the patients that we have said, oh, 75% AVM-nitis is gone and you are now protected from rebleed, it doesn't happen. Many of those patients did come with rebleeds and bad rebleeds after 8, 10, 12 years. So when you decide to treat a patient, cure should be the aim. unless, of course, you cannot cure an AVM, which is so large, and so that's a different category altogether. Manish has spoken about in natural history. It is not unfavorable. AVM natural history is not unfavorable. So whatever that you decide to do, you must do, you have time to think. Even if the patient has come in emergency with hemorrhage, you have time to think, unless his pupil is blown and he's herniating. Then of course you have to do the decompression. Otherwise, in every single AVM patient, you have ample time to think about it, to strategize, and then decide what's the best and the safest option for the patient. And when we talk about techniques, or our techniques, or my techniques, it's not always that every single patient that we treat by endovascular means is cured. So we should not be afraid to take help. We should not be afraid to say that I've done this much, can you take over? Either surgery or gamma knife, which is a stereotactic radiosurgery. And this is what this talk is about, how our strategies have evolved over the period of time. And I must say that it has become the matter of norm for us and make the treatment safer. These are the parameters. Not every AVM is the same. You cannot just show an AVM, oh, this patient has an AVM, and so he should go to this surgery or this radiosurgery or this embolization. You cannot do that because every AVM is different. The presentation is different, the size is different, the location is different. Most importantly, the flow is different. It's not even an aneurysm where just the size and anterior or posterior circulation are the only criteria. In AVM, along with all that, the flow is a very, very important criteria for an AVM, which is not the same. This is our present indications for ruptured and unruptured AVM. This is what we do. These are the AVMs who we are treating right now. Conservative large AVMs, it may seem like a lecture, but it is important. It is important that regardless of what you have, AVMs which look like this, is like the temporal lobe, posterior fossa, entire cerebellum, entire temporal lobe over here, you can see frontoparietal, massive holohemispheric AVMs, the whole cerebellum which is involved. Here, the whole temporal lobe is involved. And you see that these AVMs like these, you can of course treat, you can have surgery, but look at this, the whole brain stem is an AVM. Patient is deadly symptomatic. You have to do something about it. What can you do? In these cases, the treatment is actually more risky than not doing anything. So you have to take a back seat and say that not all the patients. What about this? It's a massive AVM with a lot of angiopathy. The whole frontal lobe is involved. But this is a different ballgame. In this, we can embolize because there is a nice long feeding arteries to it. And I will try and show you this case when we actually come to case discussions. Huge AVMs, most of them should be left alone, some of them can be treated. Now, this is what, the whole debate or the whole talk and everything that we do, it has emerged from this. Embolization cannot permanently cure brain AVMs. This we have been saying, I've become old now. I have heard this 30 years ago, I'm still hearing it today. And the people who are saying it are probably basing it on something which was published, something which was shown in the 1990s or 15, 20 years ago, without actually knowing what are the advances in brain AVM treatment that we have now, because of which we have treated brain AVMs, and the chosen brain AVMs can be cured only by embolization. And I'm not just going to talk a hollow talk, I will show you examples of everything. Because we have gone through all those decades of experience, I can tell you that the 90s decade was the worst, because we were injecting silk threads in the feeding arteries, and the angiogram at the end of it looked better, but it did absolutely nothing to the AVM, because when we repeated the angiogram after 1 month, it almost looked the same. So occluding of feeders, this is what many people talk about. How many feeders will you take? How many feeders will you occlude? How many feeders will you embolize? It's rubbish, it's nonsense. It's not the feeders. It may have a single feeder, it may have 10 feeders. It is about the nidus that you have to take. The nidus, along with its draining vein, is what you need to take, and unless you do it, you don't have a cure. So we started using liquid embolics, slightly became better, and of course it is, all the literature from that period has said that the cure rates were abysmal, 15% at best, which were our cure rates, which was very, very low. And so we agree that that was not the best time to treat the brain AVMs. But then we had the AVOH, the liquid embolics, the onyx, and the squid, from where the times have changed. And we started 2005 is 20 years ago. In the last 20 years, our parameters have evolved so much. And so now what I'm talking about is absolutely contemporary, and these are practical concepts. In spite of being contemporary and very aggressive, it's not as if every single AVM needs to be cured by us. Take help. But the AVM that we intervene in needs to be cured. So these are the advances which have happened over the last 20 years. Of course, AVOH like squid and onyx, the embolic agents, extremely important. Detachable tip microcatheters have come because when we started doing even the onyx, our dreadful experience came that after having fantastic 20-minute onyx injection and filling the entire AVM, when there is time to pull out the microcatheter, our hearts are in the mouth because we don't know whether the catheter is going to stick, and when I pull out, is the artery going to give way, is the AVM nidus going to move, or even the vein, because when you pull out, the vein which is over there, it gets pulled because the catheter is getting pulled. And so that was really frightening experience. Now we have detachable tip. So we have completely eliminated that risk. And the new techniques like the pressure cooker, venous approach, reverse pressure cooker, all these techniques are the ones because of which this is probably the right time to treat and cure brain AVMs. Now I will go to case examples. I will have many more examples till my time is there, maybe another 15 minutes or so. I will try and show you at least 25, 30 cases. And I'm not going to talk about the techniques here because you need to look at the images and how those AVMs were cured. The first example is a kid. He came with a bleed. We embolized this AVM. All the pictures are there in the same, that after embolization, we have cured this AVM. But not all pediatric AVMs are the same, because the next patient, which I'm going to show you, we did a good job with embolization. The angiogram looked good. But after 1 year, when we repeated the angio, it has annexed the supply. You can see that the embolization job was good. But after a year, when we did the repeat angiography, it had annexed the supply from the meningeal artery. Can we treat this? Of course we can. But when the father asked me that, how long can this go on? He's still a growing kid. So I said that either we can do it, and again after a year we can do a repeat angiography, or you can go to surgery. So this patient was actually, we referred for surgery, and after the surgical excision, it looks clean, it's beautiful, it's growing up well. So it is not being about one-sided, you cannot have blinkers and go straight in line, but every single patient, you need to have a strategy. And so this is what we learned. The long follow-up for pediatric age group is essential because new AVMs or multiple AVMs can grow up to the year of 18 or even 21 in pediatric age group. This is the targeted embolization. There was no doubt that this particular aneurysm had rupture. It was an intraventricular and paraventricular hematoma. So can we reach this? Yes. Can we occlude this aneurysm? Yes. Can we say that because of the occlusion of the aneurysm, the rebleed rates are going to be low? Yes. But the trick is, after we do that, and you can see that this aneurysm we will occlude, he is a pediatric age patient, and apart from the aneurysm which is ruptured next to the ventricle, he also has a large Sylvian temporal AVM, which is large, which is diffuse, and he's a kid. So we have to follow this patient up. Just taking the intranidal aneurysm is not enough. So of course we did take the intranidal aneurysm. You can see that on the angiogram, the nidal aneurysm is gone. So he's not going to rebleed imminently, but his AVM is there, and he needs follow-up, and he needs treatment for the same going forward. Now let's come to curative embo. Curative embo, I'm going to show you small AVMs to massive AVMs, because mostly the small AVMs are good for radiosurgery, small AVMs are good for surgery, small AVMs are of course good for embolization. And so from the small AVMs, I will take you to the massive AVMs and how we can, by planned strategy, cure. This AVM is a dream. It's the posterior temporoparietal AVM, which is a dream for everyone. Every surgeon wants to treat this AVM. Every radiosurgeon or gamma knife experts wants to do this. It's a small AVM, the flow is not great, the single artery, single vein, size is small, it's good for us too. So once we decide to treat this, we must absolutely cure this AVM, and this is what the contemporary techniques are about. Once we go there and we cure it, we must take it according to its blood supply, according to its nidus, and most importantly, according to its vein. Unless your liquid embolic goes into the vein, the proximal vein, and occludes it, it's like surgical excision. So if you see the surgical specimen by Maharaj or any other good neurosurgeon, it will be like this. It's the distal arteries, the nidus, and proximal part of the vein. That's what they surgically excise or take away. And so we need to do the same. It is not only the arteries, it is not only the nidus even. It's along with the arteries and the nidus, you must take the proximal vein. And once you do that, you have absolutely good cure. Small AVMs again, go fast on it because small AVM, get inside, good access, intranidal injection on this, and you have your liquid embolic. And once you have your liquid embolic, you have complete cure, which we call on follow-up. So only on follow-up, it needs to look good. Why does it look good? Because we have taken all the three, the nidus, the artery, and the draining vein. It's full cure of a small AVM, no big deal. Another one, initially, when we started our practice, it was very challenging to take our microcatheter such a long way away from down femoral artery into the distal occipital lobe. But now, it's a piece of cake. And you need to look at the AVM, and then you take your detachable tip microcatheters, go distally, and get your liquid embolic to fill, as I said, the artery, the nidus, and the vein to have absolutely good, complete cure of it. Now, small AVMs to now a little middle-sized AVM. And still, on this AVM, a ruptured AVM, a pediatric AVM, but single artery, not a very large nidus, single vein. And so these are absolutely straightforward cases to treat nowadays. Once we have arteries, straightforward access, you get inside, and once you get inside, it's not a very small AVM, mind you, but you have time because of detachable tip microcatheter, fill the whole thing, and have a cast, it's like exact replica of the entire malformation. Artery, nidus, vein. And once you do that, take your time, pull the microcatheter out without any rupture or any problem, and then you have complete cure and complete follow-up cure as well. Temporal lobe, apart from the frontal lobe, is our favorite location because the temporal arteries, like the frontal arteries, they give us length. When they give us length, we can have reflux of our embolic agent, and then we can use our detachable tip microcatheters with reflux up to 2.5 or 3 centimeters, sometimes even 4.5, 5 centimeters. And so once we have arteries like this, and if the AVM is large or small, it doesn't matter anymore, because then we can fill the entire nidus, and you can see that this is pre and this is the post, because we have filled it up completely with liquid embolic, with stable occlusion, stable result. 3 years female child. Now look at this, 3 years. So yeah, maybe the AVM will grow, but if you do a good job and keep the patients on follow-up, then the outcome will be more or less under control. So this is a temporal artery feeding this AVM. After we take the temporal artery and occlude it, then in the second session, we go to the MCA supply. It's a large AVM. So second session, nothing wrong in doing it twice. It's not as if you're opening the entire head and entire dura, and then you're working on it twice. No, it is endovascular, so it is completely justified. If you're not happy to do it in one session, do it in 2 sessions, and maybe do it after a month or 6 weeks. So this is what we did, 2 catheters and 2 arteries, both the feeders, and once you take it, the AVM is gone. Why? Again, I said, remember anything or don't remember anything. Remember, that if the AVM has to be embolized, it has to be embolized like this. The artery, the nidus, and the foot of the vein. Once you do that, it is complete occlusion of the AVM. Follow-up scan shows that there is nothing which has gone wrong because of the occlusion, and this is the follow-up DSA, after which we can now say, because it's a small kid, remember, that the AVM is now cured. So this is one more AVM, not exactly small, and this we have cured because we have gone in and replicated the nidus exactly. Artery, nidus, vein. And once you do that, you have, this is pre, post-embolization, and the last picture is control. When control DSA is done after 6 months. And once you do that, you have this. And why do we have this? Because you have the nidus, which looks like this. Stable, complete, permanent occlusion of the AVM without any clinical sequel whatsoever. This is in a different location, a large AVM, and achieve exactly the same. Now let's come to the flow. High flow, this is like an AVM with internidal AV fistula, tremendously high flow. The artery is as large, the MCA branch is as large as internal carotid artery. And this we have done, I think in 97 or 1998. Once you understand the pathology, then you can treat with what material that you have. Of course, we did not have the onyx and squid back then. So we use concentrated glue, and with concentrated glue, we have taken the internidal fistula. Once you take the fistula, this is what you find. The AVM is there, we have not cured the AVM. The fistula is gone, and now this is not the same animal anymore. This can go, either you can do it again, or even radiosurgery to follow up to cure this because the flow is not there at all. There is another category which is called as high flow pile AV fistulas, which is not an AV malformation by definition, but still it is difficult to treat because it is high flow. And you can see that those huge big aneurysms are actually on the venous side. Once you have an understanding of the disease, you can just get a small plug of concentrated glue, and once you do that, the disease changes because it's not the same anymore, and now it has changed to this. Now you do what you want. You do a second session of embolization, or let this patient go for radiosurgery, or if he prefers, then even surgical ligation. Now let's come to the size. Here, again, we did this in 1998. Large frontal AVM, no onyx, no squid, but we had the technique and we had the strategy. So we got inside and slow injection of glue. This is glue. What we have to know is that after gluing this and doing an injection for 20 minutes, without a detachable tip microcatheter, we cannot pull this out because once you pull it out, there will be bleed, hemorrhage. So we have cut this catheter in the groin. So if you understand the disease and if you have whatever material, a 99, with no catheters detachable, and we didn't have any squid or onyx, still we have cured this. And this experience has come in handy because once the onyx and squid came, then we could switch the technique immediately. Large AVM, opercular AVM, difficult area, either for us or surgery, or even for gamma knife because the size is large, but this is all that we can achieve. This is all reality, every single case. Now let's see the next one. This is where the innovations come. 2 feeding arteries. We have put, I guess, 2 microcatheters there, which you can see here. Couple of microcatheters, simultaneous injection of liquid embolic, and full cure of the AVM. Difficult area, posterior frontal, and it's right in front of the sylvian, but this patient had bled. So first, the decompression was done, and then we treated this AVM with complete cure of the AVM. This is where we differ, probably. It is not required to undergo surgical excision of the AVM, save the patient first, and we can do this most definitely days or weeks later. And here, this was the patient which I was talking about, the massive frontal AVM. It's favorable for us. It takes stages. You cannot do this in one stage. It takes stages. I think we did 3 or 4 different stage embolization for this, massive frontal AVM. And we went ahead and did it from right side, left side, MCA from the right, ACA. supply from the left side going across the ACOM, and multiple sessions of embolization, big single vein at the base of the frontal lobe, which is draining it. And we have done many such. This is one example. It's a ruptured AVM. So at the same time, we did staged embolization without any worry that between our stages this AVM is going to rupture. It's never happened. We give on an average a month or 6 weeks between the stages, and it has never happened that in between the patient has ruptured. So after you go, remember, cure is our aim. So small little AVM is still there, and we find which artery is feeding it. And we found that the dural artery is feeding it. We went there, and eventually we had to go transvenous. You can see that most of the AVM is gone. Now there are no arteries to be done. So we went from the venous side and transvenously. Finally, we were able to cure this AVM. And this is important, massive AVM, staged embolization, and full cure. Full cure from right side, left side, and absolutely patient is intact. And this image is drastic, but this is what we can achieve. And we can achieve this if you understand the disease very well. And stage embolization has definitely has a stake. 2 or 3 patients, massive, large AVMs, we cannot treat them. And right now, they are under still our treatment. These cases were done in the last couple of months or so. So first stage of embolization, second stage of embolization, and this is what we leave. We have time. We have time to think whether can we do one more or can he go for radiosurgery? Because this is not exactly not the same disease as a small 2-centimeter AVM, which I showed you at the beginning of this talk. Another one, stage embolization, story is still going on. And the third one, venous aneurysms are protective. Completely disagree. This venous aneurysm actually bled into the ventricle. It's a large AVM with high flow vein, because of which it has become aneurysmal, and it's a vein. So this vein has ruptured into the ventricle. He suffered from 2 bad hemorrhages because of this vein. And so we did 2 stages of embolization. And now, what do we have? We have a single arterial feeder, which is an anterior choroidal feeder, after which either we can do gamma knife or we can do radiosurgery. A couple of examples of gamma knife, deep AVMs. Can you operate this? Brainstem AVM, no surgery here. Why don't we have a debate about deep AVMs and brainstem AVMs, surgery versus anything else? So we can do this. We can embolize and then send the patient to surgery. Bad motor strip AVMs, we can embolize, have result like this, and still send for surgery. Probably the last I'm going to show you is the new technique, pressure cooker. There's no great deal about the name pressure cooker. We do this so that our liquid embolic doesn't have to come back on the artery. It has to go forward. And once you do that, you can completely cure the AVM. This is post embolization. And I'll skip the next 2. I'll skip this because I want to show you something. Sometimes you're sucked into it. Despite everything that I'm talking about staged embolization, sometimes you do get sucked into curing the AVM. And you need to have the wherewithal, the material especially, and the time, because this took 4 or 5 hours that we were at it. It's a large AVM, perinidal arteriopathy, and this huge venous aneurysm or fistula from which he has ruptured. So, but just taking the fistula is not going to cure him because there's a lot of supply from everywhere, from PCA, from MCA, from ACA. And so we started with taking the fistula, then we realized that this is not going to do anything to him. And so we got sucked into curing this AVM from, you can see multiple catheters, there are 2, 3, 4, no, 3 catheters, I think, simultaneously. And then we went ahead, 4 or 5 hours we worked on it, and finally we got the full result. Venous approach, maybe it's too much heavy for this, but the AVMs which you cannot approach through the arteries and the patient has bled, then you can go from the venous side, and this is venous side, we have cured AVMs which are generally riskier to treat from the arterial side. So this is the post-embolization run from the venous approach, and same on the arterial side, post-embolization run on the artery. And this has been achieved completely from the venous side. You can see that the big vein is coming towards the AVM, and we have occluded the vein as well as the nidus. Complications, we do have complications. Everyone who is doing anything surgical will have complications. You cannot deny it. And so this is a small AVM, which we went ahead with 2 microcatheters like this, and we embolized with beautiful nidus, everyone happy, because we actually took the run, and the run showed fantastic. There's nothing, there's no AVM. This is the live run that you have to see. Post-embolization, what do we see? We see nothing. We see, so everyone is happy that, oh wow, we have cured the AVM. And still, this was the pre, which we do the CD on our table. It shows the clot, which is an evolving hematoma from previous rupture. 2 days later, patient got massive headache, and then we did the scan. He has rebled, in spite of us believing that we have cured this AVM. So this is the time that we have to go back to the angio, and you see the small little feeder which we have left behind from the ACA pericallosal artery. Now we have to get back into it and then occlude it. So if the patient bleeds, some people, oh, the patient has bled, refer to surgery. It's the patient has bled, it's your responsibility. You try and do the best that you can. Sometimes for a large bleed, of course, evacuations are required, but more or less, if it is your complication, you need to take care of itself. So these are the conclusions, which is the last slide. It's not easy. 2, everyone cannot be the same. So maybe in Manash's center, his fantastic, massive experience, beautiful department, he can take more challenges than maybe some of the other neurosurgeons elsewhere in the country. Same goes with neurointerventionists. So it is not the same. It's not about technique. It's about people and their experience and expertise. I'm not going to show you the entire case, but exactly the same as Manash, you started your presentation. So this is, they are going to tell us that you have to ask each other a question. So this is my question. I'm not going to show you the case, but this is my question. What will you do here? Thank you.
Manas bhai, can you take over if you have some discussion to make?
Yeah, what are the GCS of the patient?
This patient, pupil is dilating. The pupil is dilating.
I mean GCS 3.
He's not deeply unconscious. He's not like deeply unconscious. But obviously, he is plegic on one side with a dilated pupil, right pupil.
Okay, sconing on one side.
Yes.
Yeah, I'll do an emergency CT angio and then do an emergency decompression, and depending on the CT angio, if feasible, I'll excise that. And that's what will be my approach. Unless I feel that's a very large AVM cannot be excised, then I'll just do a decompression and come out because the patient is in a bad shape. But my approach will be if I can do together.
Right. So this is what I meant, but please allow me to show me at least the angiogram, because you know what we have done here. So the angiogram shows that the AVM is not an easy AVM. There are veins everywhere, aneurysms, venous aneurysms everywhere, supply from all the 3 arteries, ACA, MCA, PCA feeders, veins looking like this, bleed, patient is in very delicate situation. And so now it is an easier answer that probably this patient needs to live first. And so you have to, or a neurosurgeon that we had, he has to first save his life. It is vital. So it's not compartmentalized that, we have to do this and it's our patient and everything I will do. So in this case, of course, it was a very large AVM. And so first thing which was done was craniotomy, save the life. It's a huge AVM. And you can see that's the first thing, a large craniotomy. Slowly the mass effect regresses, and now we have time to embolize. Maybe then you have time to operate as well. So we don't go in great emergency hurry into these patients.
Yeah, I think it depends on the people who are on duty at the neurosurgeons, but at least in our hospital we do together. Yeah.
All right. Yeah, so that was my question to him.
Yeah, absolutely. Thank you so much. I think we have reached a consensus on many of the aspects of how to deal with AVM. We don't have much of conflict. So what we understand and gather is AVM is a very complex subject,
And most of us believe that when an AVM has not bled, we don't have to touch it unless there is intractable seizure, as we have discussed. And when it is bled, we have multiple options which we have to look into. And then again, having a large hematoma and mass effect changes the paradigm shift towards basically surgical evacuation as well as excision at the same time. Embolization is again having a great role, especially doing targeted embolization and dealing with the intranidal aneurysm or a difficult posterior circulation AVM. And radiation, as Dr. Kanu has said, that is again a very wonderful tool when there is an AVM which is smaller and has not bled. So, Suresh sir.
Yeah, actually, when the AVM has bled, it is much easier for the surgeon to excise because at least 270 degrees of the AVM nidus, the plane is already dictated by the hematoma. And the rest of it, the localization value is added by the hematoma. And it gives a cavity for the surgeon to negotiate around the AVM. So it is actually easier for a blood aneurysm, AVM, to be operated, simultaneously hematoma evacuated, and gives a better decompression to the patient.
That's a great one. So, Bharas, I have a question for you. So, you said that when we embolize an AVM who has come with intractable seizure, it still have those seizures because the focus of the seizure is peri-AVM rather than AVM per se. So, my question is, it's like, so can we say that doing a radiation or an embolization is not going to change the course of seizure in such patients? Is there a proof or study?
Yeah, if the patient has presented with one seizure, then giving radiation or embolization is fine. But if it's intractable seizures, is not controlled in spite of taking multiple anticonvulsants, then surgery is preferred because you cannot then you can take care of the epileptic zone surrounding the AVM.
So, do you think the scar will have another source of epilepsy?
No, the source of the scar, which is the source, because of the AVM, that itself is removed. So that is the concept of epilepsy surgery. Means we do epilepsy surgery every day. So we don't create a scar. We take out the epileptic scar from the brain while operating.
Thank you.
Sir, there are two cases. First, which you showed as a unruptured AVM with seizures, which you operated and you removed the epileptogenic focus. That's right. There was a similar case you just showed this 3-year-old kid for which it was again unruptured AVM with seizures, which you did embolization and that patient also did. So now the difference here, both the cases are almost similar. Small
one
AVM.
is controlled seizures, it is controlled with anticonvulsants. My case was intractable. In spite of medication, it was not controlled.
Okay. So the next question, sir. Now the seizures are coming. So is it necessary to demonstrate any areas of gliosis for you to operate it as an epileptogenic focus?
Yeah, that is what the neurologists do. They do a video EEG, means they do EEG while the patient is having seizure and find the focus. They confirm that the AVM and the surrounding area is the source of epilepsy.
That is fine, sir. Now the source of the focus can be because of ischemia or gliosis. There are two things which can cause.
Ischemia leads to gliosis.
True.
Yeah.
Completely agree.
So that is, ischemia leads to gliosis, and that is why they become a focus for epilepsy.
But similarly, sir has embolized and it didn't. There was no seizure later.
No, he did not have intractable seizure. This patient presented with seizure. That is different. Controlled with anticonvulsant, and patient who was not controlled has to be dealt separately. The other thing I want to stress is a patient has 70% of them present with a bleed, and in that cases, always it's preferred to either do surgery or embolization over radiosurgery because radiosurgery takes 3 years to obliterate, and the obliteration rate at the end of 3 years also is 60 to 70%. So radiosurgery has not been the primary first modality of treatment in AVM, and only 10% of AVM are asymptomatic. 50 to 70 come with a bleed, and other come with either seizure or persistent headache or progressive deficit. A patient with persistent headache angiogram has to be done to know the angiographic finding, as you were explaining, whether intranidal aneurysm is there or not, or a proximal or distal flow related aneurysm is there or not, because they increase the risk of bleed. So a patient comes with an AVM unruptured should not be left alone, depends on the clinical finding. Only 10% can be observed, and rest 90% needs some form of treatment.
Sir, one more question. So actually being a neurologist, we see many bleed patients.
Yes.
But the cases which were shown are almost all those who are having mass effect or midnight shifts and those. So, but we get patients who are having like mild hemiparesis, they will be conscious current, they are having the bleed. So in such cases, will you wait for the resection or embolization of AVMs? Like there is waiting period for 4 to 6 weeks in some cases, if at all patient is not having any mass effect or midnight shift. And size is like suppose 3 centimeter or...
Early or delayed surgery was an controversy like 15-20 years ago, that you delay the surgery, edema comes down, surgery becomes easier. But Dr. Uday said he has not seen a rebleed, but I have seen a rebleed. That's why I have changed my strategies, that if AVM is detected without mass effect also, and depending on angiogram finding. If the angio finding is innocuous, then we can wait 4 to 6 weeks. But if there is associated findings, as Dr. Dalai told, it has to be operated in the same admission. Otherwise, you will land up in medical legal problems. The patient will come with a rebleed, and he will blame you for not suggesting an early surgery.
Good evening, sir. I am Dr. Pawan, neurophysician. I just wanted to know how the epilepsy surgery, how much of brain tissue needs to be removed, whether it depends on the MRI findings like the hemosiderin deposits or other things, or the electrocardiogram during the surgery.
Yeah, we do normally a PET or a SPECT scan, ictal SPECT before, to identify the ictal onset zone preoperatively. With the navigation, we mark it, and intraoperatively, we do a corticography and see that 80% reduction of the spikes. Before we start, we do spikes. So we keep on removing till we get 80% reduction of spikes.
Thank you, Bhai. I think that's the end of the session. Dr. Sujana.
That's a great discussion, sir. Really inspiring. Both the presentations were outstanding. So I would request Dr. Shivram sir, Dr. Charan Patro to present a symbol of appreciation, a memento for our first speaker, Dr. Manas Kumar Panigrahi sir. Dr. Manas Kumar Panigrahi, HOD and Senior Consultant Neurosurgery, KIMS Hospital, Hyderabad. An expertise with extensive experience. Thank you so much, sir. It's a great presentation. I would request Dr. Dalai sir and Dr. Anil Kashi Vishnuvardhan sir to present a memento for our speaker, our legend, Dr. Uday sir, for his great presentation with the advancement of neurovascular care with all the multidisciplinary approach. Your insights are noteworthy, sir. Thank you so much. I would request Dr. K. Satyavaraprasad, sir, to present the mementos for the chairpersons. Dr. G. Shivaram, sir, thank you for making time for a great discussion today. Dr. Anil Kashi Vishnuvardhan, sir, thank you for sharing your insights with us. Dr. Charan Patro, sir, our gratitudes for being present here today. So thank you so much, sir. Our warm greetings for making a great discussion on AVMs. Now the last but most important topic. As the CTVS people are involving now, it will become more favorite to everybody. So it is the carotid artery disease, the grand finale of the clinical reasoning
where carotid stenosis meets the carotid expertise. Surgery takes the stage, intervention counters with innovation. So the battle will be carotid endarterectomy versus endovascular management for the carotid artery disease. So first I would like to call our chairpersons. Our battle room begins with Dr. Hemant Kumar Behra sir, our one and only leading cardiologist, Medicover Hospitals. So we have to focus on discussion or we have to focus on you. Thank you for coming, sir. Dr. R. Lalita ma'am. Thank you, ma'am, for making time for us today, for joining this great session on carotid artery disease. Dr. Anuradha ma'am, we welcome you to the dais. Dr. K. Raviteja sir. Dr. Pavan Kumar sir. We welcome you. Warm greetings to all the chairpersons for this great discussion on carotid artery disease. So finally, the PhD meets the Medicover. Karnakar Padi sir, Hemant Behra sir, and Shiv Shankar Dalai sir on this grand finale. So I would like to call upon our speakers, the legends for the last battle. Our first speaker, Dr. Karnakar Padi sir, Director, Cardiothoracic and Vascular Surgeon, Medicover Hospitals. His renowned expertise, his insights undoubtedly provided valuable guidance for our audience. Then I would like to call our organizing chairman once again, Dr. Shiv Shankar Dalai sir, the Chief of Neurovascular Intervention, Medicover Hospitals, our pioneer for this academic extravaganza. As our second speaker, so Karnakar sir should speak on carotid endarterectomy for carotid artery disease. We are happy to hear you, sir, today.
Good afternoon, all. First of all, I thank the organizing team, Dr. Dalai and his whole team for organizing such a very important, educative and vibrating discussion. And it is really a good program, the theme running good, and it is very educative for all of us. So this last battle, last but not the least, good, so many people are there, so we can just go ahead with the discussion. And the last battle is a little bit important because it is not only between two doctors, it is also between two brothers. So as we know, we both hail from two villages 30 kilometers apart, and we are fighting. So as we know, when two brothers fight, sometimes it becomes very good, or sometimes becomes very serious. So let us make it a little fun. And already outside 3 platoon of police are there. So if it goes very bad, then they will come to our rescue. So don't worry, and I hope all will support for this fight. This is a very interesting area, carotid artery disease, as we know. But fortunately or unfortunately, the treatment of this belongs to either interventional people who are mostly of radiology background, and surgical goes to the cardiothoracic surgeons because we also handle the surgery of the arteries. Just for education of all other people, I made some slides of what the carotid artery disease. As you know, the prevalence of hemodynamically significant carotid artery stenosis increases with age, and it is 5 per thousand in 50 to 60 years of age. Then slowly it increases, and once the significance of stenosis increases, narrowing, then the risk of stroke, myocardial infarction, and death increases. And 50% of the patients with stroke usually have significant carotid obstruction. So any patient comes stroke, the first thing is carotid artery has to be evaluated. And in fact, when we operate patients for CABG, we screen all patients above 50 with Doppler at least to know the carotid status. Looking at the anatomy, as we all know, I am not going into detail. This is how the triangles in the neck and how the carotid arteries goes, external and internal carotid artery. External carotid artery supplies face and neck, and it will have branches, and the internal carotid artery will not have any branch in the neck. This is how they go. And very beautiful for the artery supplying the brain is there are 4 arteries, 2 vertebral arteries and 2 internal carotid arteries, and they will have intercommunication. So any slow obstruction usually gets compensated by other arteries. So many times, even with significant obstruction, some of the people will come asymptomatically. This is the circle of wheels. So looking at the history, the first report of stroke was in 1875, and in 37 the angiography done and carotid disease was established, and first successful operation for carotid artery was done in 1954. And looking at the pathophysiology, like any other arterial obstruction, we know atherosclerosis is the most common cause, though there are so many less important causes are there. And the pathogenesis also is same like any other cardiac or other atherosclerosis. It is the chronic endothelial injury which is the culprit, which makes accumulation of the lipoproteins, recruitment of monocytes, turning into macrophages, and that sets the field for inflammation and fibrosis with neovascularization, and that's how the plaque forms, grows, and either it ruptures or makes the artery narrowing. So the mechanism of stroke related to carotid artery can be because of embolization or ischemia, but most often it is because of embolization from the atherosclerosis. So it has to be dealt if patient is symptomatic. Sites of obstruction most commonly at the bifurcation most of the times. That is how the role of endarterectomy has come into the play. But sometimes the origin of the carotid artery can get blocked, or sometimes the intracranial part also get affected, as we have had a good discussion in our pre-lunch session how the intracranial coronary artery also gets affected. And besides that, there will be a lot of patients with microvascular disease of the intracranial vessels, which excludes the treatment either by surgery or intervention, and most of them has to be dealt medically. And if you look at their prevalence, their 20% will have associated history of MI, and many of the patients, they will have coronary artery disease also. Like patients coming for coronary artery disease as they have history of stroke, some lacunar infarcts or carotid artery obstruction, the reverse also will be there. So whenever we are handling the carotid arteries, we should have a cardiac clearance for the patients. Otherwise, we may do a beautiful job, but patient subsequently, perioperatively may develop myocardial infarction. And risk factors, same like any other patients, diabetes, hypertension, hyperlipidemia, smoking, and homocystinemia. Smoking makes the carotid arteries bad. Looking at the presentation, they can have minor presentations like TIA, hemorrhage, phovax, cerebral infarction, or they can develop also stroke, or clinically we can see the carotid bruit if there is a significant obstruction. So obstruction, as discussed in the pre-lunch time, it can be mild, moderate, or severe. So once the stenosis becomes more than 70%, then the choice to treat or not treat arises. There are various investigations available. The first basic investigation, as we are telling, the Doppler study has to be there. It can give correctly what significant block is there or not. But nowadays, a lot of advanced investigations came, including CT angiogram, MR angiogram, conventional angiogram, DSA, even 3D volume rendering. It can give the beautiful picture. And more important is virtual interluminal endoscopy can not only tell the site of obstruction, but the characteristic of the plaque. This is the Doppler study. Angiogram, we can see the critical block. You can see the block here. This is how we diagnose. And CT angiogram, we can see the same blocks. And more important is we should have a proper vascular analysis, because many times what the report comes, it may not be correct, because unless we know that the critical stenosis is there, either surgery or intervention cannot give a better result. So coming to the treatment options, there are 3 types of treatment options. One is medical, second is endarterectomy, carotid endarterectomy, and third is carotid angioplasty. So when to operate or when to offer the treatment? If patient is symptomatic, definitely he needs treatment, even if carotid stenosis more than 50%. With history of TIA, the lesion needs addressed. Or ipsilateral carotid stenosis of more than 70%. Concomitant COBG, if they are coming for COBG and they have symptomatic carotid artery disease, that has to be addressed. Progressive stroke and carotid stenosis more than 70% has to be addressed. Then coming to the asymptomatic. Asymptomatic, it is very controversial. Previously, asymptomatic, even significant stenosis, people were operating or putting stents, but of late the literature has changed, and in clinical practice also, we see there is not much useful. We'll come to that discussion with the literature review. Coming to the bilateral carotid disease, when to do carotid endarterectomy? If bilateral symptomatic more than 70% with intraplaque hemorrhage, that has to be addressed. Ipsilateral more than 70%, contralateral intraplaque hemorrhage more than 80%, they have to be also addressed. Bilateral asymptomatic intraplaque hemorrhage, because once there is hemorrhage inside the plaque, the chance of plaque rupture is more, so that has to be addressed. So coming to the real discussion that whether these significant blocks has to be done with stenting or we have to go for carotid endarterectomy. As you know, carotid endarterectomy is a gold standard treatment. It is there long before even the angioplasty has started. But of late, because of the progress of the and technique, high development of the angioplasty, many of the patients are going for this. But we'll see the literature, what literature says. If you look at the 30-day stroke and mortality rate for angioplasty is marginally higher in comparison to CEA. So basically, there is not much difference in the stroke and mortality. Looking at the stroke journal in 2005, they have come to the conclusion that 5-year risk of stroke and death was same. Cranial nerve injury and hematoma will be more with surgery, of course, because the hypoglossal nerve and vagus nerve, they are going nearby, so chance of injury is there. But the 5-year restenosis is definitely more with stenting. So if we go aggressively with stenting for all these patients, definitely many of them will come with restenosis. Looking at the ICSS trial, which also shows that the stroke, MI, and death are significantly higher in the angioplasty group. And in the CRASH study, which was published in 2010, they have done 2,500 asymptomatic and symptomatic, because that time the concept of asymptomatic patient does not need intervention was not there, so they included both asymptomatic and symptomatic patients. And there they also found that stroke, MI, and death rate are high in angioplasty group, but not significant statistically. But restenosis is high. So if you look at the major adverse events like death or stroke may not be different, but if you look at the restenosis, definitely in angioplasty it will be high. Looking at the other studies, when the ACAS, that is the asymptomatic patients, and some of the European and North American study, which has clearly showed the benefit of surgery in both symptomatic and asymptomatic patients. In North American study, the absolute risk reduction of stroke was 70% and 17% at 2 years. In European study, the absolute risk reduction was 6.5%. In asymptomatic patients also, the absolute risk reduction was 5.9%. Coming to the CAVA-TS study, the peri-procedural stroke and death were 6.4 versus 5.9, but restenosis was again significantly high in the stenting group in comparison to endarterectomy. So restenosis, and another interesting find they found, the restenosis was more when the pre-procedure stenosis was high. Suppose if you do a stenting in a 70% patient, 60% patient and 90% patient, the 90% patient restenosis is high in comparison to done in a 60%. So that has to be also kept in mind. There is another study, ICSS study, which was started, but it was stopped prematurely because of lack of enrollment and very early inconclusive data was there. So our major discussion of asymptomatic patients, what to do, because if you look at the stroke rate, annual stroke rate in the asymptomatic patients, if it is less than 70%, the annual stroke rate is 1.3%, whereas if more than 70% stenosis, annual stroke rate is 3%. So if we are planning any surgery or stenting, our peri-procedural or down the year, the stroke should be less than 3%. Suppose we do a carotid endarterectomy, the stroke rate comes 6%, then it should not be done. That is what we have to assess how our center or our procedure works for the patient. So coming to the contraindication, I don't know whether angioplasty should be done in acute stroke or not, but definitely for surgery in acute stroke patients, the carotid endarterectomy is absolutely contraindicated. Severe non-rehabilitated stroke, high cardiac risk, and short life expectancy. These are the patients should not be put further in procedure, and they should be managed medically. So overall, the carotid endarterectomy is prepared if there is a concomitant CABG. Many times we do along with CABG carotid endarterectomy if they are symptomatic. Before even asymptomatic also we are doing, but of late we stopped. So if they are going, then same incision, little extension to neck, we complete both the procedures. And less involved ICA. This is a technically thing, because when we go for carotid endarterectomy, the site and the maturity of the plaque is very important. If it is not matured and if it is extended into the internal carotid artery beyond a certain point, then the internal carotid artery will enter into the skull. Then it will be very difficult for us to have a distal control and do a proper job. And if we do not remove the proper plaque, the distal disturbed plaque will obstruct, the benefit of surgery will not be there. So early bifurcation, they are better. And if plaque is limited only at the bifurcation, they will have best result. And if they have a well-developed circle of wheels that is protective, so we can happily clamp, and no need of even shunt also, we can finish the job quickly. And if it is more stenosis, it can work better. Where the stenting is preferred, if restenosis after CA instead of again going for surgery, that is very useful, those areas. Post-irradiation, hostile neck, very stiff neck, or patient is high risk for CA for any other systemic disease. We also get complications like hematoma, infection, hypo or hypertension, intracranial hemorrhage because of reperfusion injury, hyperperfusion. Even patient can develop perioperatively stroke, and nerve injury, hypoglossal nerve injury or restenosis. Though restenosis is less in comparison to angioplasty, but still it can happen. We can do a conventional technique or eversion technique. This is one of the exposed bifurcation. We can see the hypoglossal nerve there. And this is how we remove that, or by eversion also we can remove and re-anastomose. And this is how the incision happens. And sometimes if that is very difficult, sometimes we have to bypass with a synthetic graft the carotid artery. This is a different, this carotid body tumor, I just put the picture. So we can do an internal or external bypass, but if circular wheels is well formed, there is no need of doing bypass. In my experience, I have done around 45 cases with concomitant CABG, most of the cases. Internal bypass was done, and we used synthetic page in 15, and pericardium, because along with CABG was done, it was used in 30 cases. There was no mortality. One patient developed stroke. In last 5 years, actually, I stopped CA doing in asymptomatic cases. So if they are coming even with critical lesion also, we just go for CABG and observe them. If they are symptomatic later, we think of, or if they want, they can go for stenting in some of the cases. Angioplasty followed by CABG also can be done, so to have a less operative time. Some of the patients, even angioplasty result less than carotid endarterectomy, but sometimes I send to Dr. Dalai to do that. And it's an evolving option in a selected group of patients. And carotid Doppler, we do all the cases, as I told, to see that they are having for risk stratification. So before I conclude, I just, 2 days back, it has come New England Journal of Medicine, CREST-2 trial. It is one of the important trial. I think all of us should go in detail. It is a trial they have done medical management versus revascularization in asymptomatic patients. It has 2 parallel trials. One is medical management versus angioplasty. Another is medical management versus carotid endarterectomy. So in the first trial, 1245, second 1240 patients were enrolled. So very interesting finding has come. In 0 to 44 days, no stroke and death in the medical therapy group, but 1 death and 7 strokes in the stenting group, early result. Whereas in the endarterectomy group, there was 3 strokes in the medical therapy group and 9 strokes in the carotid endarterectomy group. So it is very important for us to decide to go for any intervention in the asymptomatic group, even if the number is less, but a patient comes to prevent stroke, and by doing an intervention, we develop a stroke, even if a less number of patients, still it carries a significant concern for the patient population and us. But at 4 years follow-up, the stenting has lower composite event than medical group, but carotid endarterectomy had no benefit at all. So this we are practicing 5 years back. That's why asymptomatic patients, we stopped carotid endarterectomy. But maybe in selected groups, we can think of doing angioplasty, but still it is not a foolproof thing. Even patients coming, walking for a asymptomatic patient, we may get into develop stroke in the perioperative, at least within 44 days. So we have to be very judicious for treating asymptomatic carotid artery diseases. Thank you.
Thank you, sir. Our heartfelt gratitude for an outstanding presentation, Dr. Karnakar Padi, sir, for sharing your expertise and a vast experience. Your emphasis on the importance of timely intervention and the benefits of surgical management has shed light on the best approaches for the patient care. Your outstanding presentation and your contribution for the field of CTVS is really honored that we have you today for giving us this opportunity. Now I would like to invite our second speaker for the battle, Dr. Shivshankar Dalai sir, the Chief of Neurovascular Intervention Team, Medicover Hospitals.
I think the last line of Dr. Padi sir's presentation would boost up Dr. Dalai. in asymptomatic group of population. The Riker already made him win, it seems.
Sorry, I just
wanted to add something, sir. We are only looking at the carotid doctor before CABG. What about the intracranial atherosclerosis that has become more rampant now, especially in the post-COVID era? So wherever possible, I think we should look at the intracranial vasculature also.
Respected seniors and dear friends, thank you for being here till the last talk. I thought only me, Arvind, will be there. I was also not hopeful about Marlene because she's a young lady. She might disappear. She's there? You see? Dr. Marlene, not there. Good. So I expected the same. So now, if there is any discussion, we can start, or yeah, the presentation ready. Perfect. We are doing carotid artery stenting since 2006. So for past 19 years, we are doing this procedure. I myself. And we have done carotid artery stenting to multiple international meetings. We do all kinds of complex carotid artery stenting with tandem lesion, with intracranial disease, with posterior circulation, with complex medical histories. So as Suresh sir has told in the morning time, that maybe a procedure is relevant for a disease, also an operator experience has to be considered when you want to deliver something. Maybe a Michael Schumacher can drive at 190, but that is not approved or appropriate for everybody. So by the course of time, we have gathered different type of experience in different expertise has been achieved by different people. Today, we don't find a contraindication for doing carotid artery stenting in 99% of the situation that we come across. As Padivai has already told, that we have the CREST-2 trial results came in just 3 days back. And these are the findings of this CREST-2 trial findings, which is saying that the 2 parallel randomized trial in patients with asymptomatic high-grade carotid artery stenosis with more than 70% lesion. One trial compared intensive medical therapy alone versus medical therapy plus carotid stenting. The other compared medical therapy alone versus medical therapy plus carotid and arterectomy. In the stenting arm, the primary endpoint, this is stroke or death within 44 days of ipsilateral ischemic stroke in the territory of the disease up to 4 years, occurred in about 6% of the in the medical therapy and 2.8% in carotid artery stenting group, which is clearly showing that a recanalization is vital to give patient asymptomatic disease-free time. Just leaving them with optimal medical management is not enough, and that is not what is said by me, but this is the trial result which has come very, very recently. And the primary endpoint, that is stroke or death within 44 days of ipsilateral ischemic stroke up to 4 years, occurred in 6% in the medical therapy arm, 2.8% in the carotid artery stenting, as we discussed. The number needed to treat is 31 to prevent one composite event. In an endarterectomy arm, the event rate was 5.3% in medical therapy, which is again equivalent, that is 6% in the stenting group. And then medical therapy plus endarterectomy, when it was done, then it's about 3.7%. Not a significant difference. Carotid stenting patient had 2.8% complication over 4 hours compared to a little increase, that is 3.7% in the endarterectomy arm. This did not reach statistical significance, so the two brothers are not fighting. I'm sorry to disappoint you, there is no battle here. We agree that both arms yield similar result. On a good day, please do endarterectomy. On another day, I will do the stenting. So all patients received intensive medical therapy. The targets included systolic blood pressure of less than 130 millimeter of mercury, lifestyle coaching, smoking cessation, and glucose control. Now I will go through some general slides in 5 to 10 minutes and then we can stop, because it's a very simple it's a very simple disease which can be treated in a very simple manner by putting a stent, which is not a very complicated intervention. So we don't have to really discuss a lot about it. The theory part and what is the evidence that we have today is already discussed in these first two slides, which are actually the most relevant slides that we discussed. Stroke is the third leading cause of death and disability in the world. Extracranial carotid artery disease account for 20 to 30% of all stroke. Intracranial carotid artery disease account for 5 to 10% of strokes. Carotid artery stenosis due to atherosclerosis in almost all cases. Atherosclerotic progression leads to compromised flow in distal vascular territory. Hence, carotid artery stenosis can be an incidental finding or can manifest as a TI or stroke. Most commonly affected side are proximal ICA or the carotid bifurcation. Prevalence of carotid stenosis is high in individual with risk factor of acute stroke, elderly age group, coronary artery disease, peripheral artery disease. Implication for carotid artery disease. Carotid disease is culpable for roughly 50% of all TIAs. Risk of stroke after TIA is as much as 20% in the first month. If treated, TIA can result in stroke. If untreated, TIA can result in stroke with 2 years. The risk of stroke is high for 10 to 15 years after TIA. So it is better that we address those TIAs with carotid artery disease with some form of recanalization. Patients who are having significant carotid artery disease can present with a headache, loss of balance or dizziness, loss of vision, sudden weakness or numbness in the facial limb, aphasia, carotid bruit, and of course the two most important things like TIAs and stroke can also be caused because of significant carotid artery disease. The risk factor for having carotid artery disease are hypertension, dyslipidemia, diabetes, smoking, obesity, age, elevated CRP. The imaging modality that can be used for evaluation of a carotid artery disease is a Doppler, contrast-enhanced ultrasound, CT angiogram, MR angiogram, and digital subtraction angiogram, which are the gold standard, and it can actually tell us about the type of plaque, the ulceration in them, and how tight it is, and the dynamic flow into the cerebral circulation. The indication for carotid stenting, any patient with a significant carotid is a candidate for carotid stenting. Other indications are patient not suitable for CEA. Unstable angina or recent mitral infarction, left ventricular ejection fraction less than 30%, congestive heart failure, prior eradication of the neck, prior irradiation to the neck, contraindication, contralateral carotid occlusion, and the previous CEA with restenosis. Absolute contraindication for doing a carotid artery stenting are floating thrombus in the carotid artery, reaction allergy to contrast, inability to gain vascular access, active infection, and severe plaque calcification and severe carotid tortuosity. But again, these are all we have come across in many situations that we can get rid of it. I remember doing severe carotid artery disease with a heavily calcified lesion in Vijayawada for a VIP, and we had a stent fracture. After putting the stent and doing a balloon angioplasty, the calcium broke the stent, but we can manage to put another stent inside the stent and we can get rid of the situation. Like here in this case, we said that if you have a difficult neck, that's going to be a situation. But again, this is a paper which we have published long back, Dr. Arvinara and Dr. Rajeshpati and me, where we demonstrated that a carotid artery stenting can be done from a non-femoral arterial access, right from radial, from the brachial, or a direct carotid puncture, and we have done it and we have published it in the Indian Journal of Neurosurgery. Patient selection recommendations, stenosis less than 50% don't need any kind of treatment. And if it's more than that, up to 70%, you just keep a close watch and close monitor. If it is more than 70%, definite indication for revascularization. And the procedure for carotid artery stenting is informed consent, loading the patient with a double antiplatelet, test for contrast allergy, baseline neurological examination, and you decide the site for endovascular entry according to suitability. Access site could be femoral, axillary, brachial, radial, direct puncture of the carotid, as we have already demonstrated. Intraoperative anticoagulation not required. Embolic protection devices are a very, very important part of carotid artery stenting. So it is just like an umbrella-like device. We just take it from the groin axis or the radial axis, and we cross the carotid artery lesion. We deploy this umbrella-like distal embolic protection, and we do a carotid angioplasty as well as stenting. So when you are doing the procedure, if any clot goes from the lesion, then it will be held by the distal embolic protection, which can be later brought back. So this is how it looks like. This is the carotid artery lesion, and you have crossed with a distal embolic protection. You have deployed the distal embolic protection somewhere here. So when you're doing the stenting, if there is any embolic material that goes up, then it can be held by this umbrella-like device, the filter, and then can be brought back. And once that is done, you can put a stent, do a little bit of angioplasty to the stent, and you can get a nice, good lumen. There could be complications because of carotid artery stenting, which are absolutely rare, but it can happen like an exercise complication, hypotension or bradycardia. This we have seen. This is persistent for 72 to 96 hours in some patients. And dissection. So what we do is that whenever we plan to do a carotid artery stenting, we stop the antihypertensive immediately from the day of procedure, because most of the patient will have a drop of blood pressure because of the vagal stimulation due to carotid stenting. So dissection, dystalizis, spasm, cerebral embolism or stroke, hypoperfusion syndrome, myocardial infarction, contrast-induced nephropathy, stent fracture, instant thrombosis are some of the rare but possible complications that has been described. CREST-2 trial is what is now in vogue, and this has come very recently, which is demonstrating that it's a fantastic and a robust procedure to address carotid artery disease in form of recanalization. And there are multiple trials that has come back, but we don't have to go back because this is what is evident today in November 2025, the CREST-2 trial, which stands as a solid gold standard for carotid artery revascularization, could be a carotid artery stenting. The pros of carotid artery stenting are less invasive, potential safer in sicker patient, quick recovery, low risk of wound-related complications, low incidence of cranial nerve injury, ability to treat the entire length of the carotid artery. Because when we are doing a carotid endarterectomy, we have a limitation to explore the carotid beyond certain level. But here, we can do an angio, we can do a tandem lesion, we can look at the carotid artery all the way into the bifurcation, into the intracranial circulation. We can address those things, which is a limitation in surgery. And then the safety is not impaired by the hostile neck, and the permits rapid visualization of cerebral vessels and neurological rescue should distal embolization. So there can be multiple case example. Let's see one or two. So this is a very critical stenosis you can see. And here we have gone across this lesion. It's an acute stroke patient. And you did a little balloon angioplasty, and then you put a stent, and then you do a little angioplasty to the stent, and you can start recollecting. This is just a spasm which goes off after about 15, 20 minutes. Case 2, 63 men, hypertensive, diabetic, dyslipidemia, recurrent TIAs, and there is a significant carotid artery disease here. Again, you go ahead and you put your distal embolic protection, you do the stenting, and a little post-stent balloon angioplasty, and then you can get a carotid as good as that. This is a 56 female, diabetes, dyslipidemia, recurrent TIAs, bilateral disease, again a critical stenosis, and you go ahead. This is a distal embolic protection, umbrella-like device, just cross the lesion, deployed it over here, and you deploy your stent. You want to dilate it a little further, you can do that, and then this is the balloon for post-dilatation, and you get a very nice carotid, and you take out your distal embolic protection and do a cerebral circulation to understand if the patient is having some kind of stroke or occlusion. 3 months later, on the opposite side, the same patient we discussed, Dr. Pari told that whenever we have patient with bilateral carotid artery disease, So we just stage them. We don't do it at the same time because of the risk of hyperperfusion bleed. So we do a carotid at one go and then allow the patient to go home, come back after 4 to 6 weeks, and then we can address the other side of the carotid, and this is how it can be done. 68 men, recurrent TIS, bilateral disease again, right ICS, this is again a vertebral osteostenosis and carotid artery disease, very, very high risk patients because they will have multiple TIAs. And this is again the carotid artery lesion, very tight. And this is again the other side, which is having an ulcerated plaque, very dangerous plaque. They will have recurrent stroke because of the clot going from this lesion. And this is the cerebral circulation. You have no ACA filling. And then you address this by carotid artery stenting. This is the distal embolic protection. And put a stent and did a little bit of angioplasty of the stent. And you have the ACA came in. The flow improved in the cerebral circulation. And then the other side, left side, you can go similarly. Again, there is hypoperfusion. You go into the second side and you go with the distal embolic protection. You put a stent, do a balloon angioplasty. And again, this is the distal embolic protection on the left side. And the stent and the balloon angioplasty. And you can see that there is stent on both the sides. They're pretty safe. Just you give little time. Don't do carotid artery stenting both sides on the same go. So give it a little 4 to 6 weeks of time between each procedure. So this again, you see the very improved cerebral circulation. So we have published our data on carotid artery stenting. The entire data has been compiled by Dr. Arvind, my good friend, and he has published it. And this is what we have been doing about carotid artery disease. Thank you for your attention.
Sir, I have a question. Is age a factor in selecting between carotid artery stenting and endarterectomy? And the CRUST trial mentions that the incidence of stroke is more after in the pre-procedural period of stenting, whereas MI is more common in carotid endarterectomy. Have you faced any cases with embolic stroke during stenting? And how useful is the embolic prevention, umbrella use during stenting?
Right. So first of all, this has been said in literature about the periprocedural stroke and MI. But we have never seen a patient having stroke after carotid artery disease, stenting. Actually, I presented my data long back in Neuro Club, Visakhapatnam. So when I said I have 0 complication doing a carotid artery stenting, people were skeptical. Then I said, whatever carotid artery stenting I have done, at least all of you have referred to me, right? So please, any of the neurosurgeon or neurologist can please stand and say, Dr. Talai, I have sent you a patient for carotid stenting and you had a complication. So I could convince them that it is a relatively safe, simple, straightforward procedure. We have not seen a complication doing carotid artery stenting so far. But as for whatever you quoted, in literature, it is so, yes. And second part of the answer, about the distal embolic protection. There are a lot of discussion about whether we should have a distal embolic protection or not, but we prefer to put a distal embolic protection almost all the time. Where we don't use a distal protection, where the patient is having acute stroke, like first 2 cases I have shown there was no distal embolic protection because there was a carotid artery disease and there was a tandem occlusion of ICAD. There we don't put a filter because if some clot goes off, anyway it is occluded, anyway I have to address that. So I don't make the procedure complicated, expensive or lengthy. So put a stent and then go through the stent and retrieve the clot. But one has to be very careful when you have done a carotid artery stenting and you want to treat a stroke, never put a stent retriever. Use an aspiration device. Because if you put a stent retriever and try to drag the stent retriever through this carotid stent, you are going to have a tough time because the first stent will hold the second stent and you might have a complication. So these are the things I have to be careful. But given a choice, and most of the cases, more than 95% of the cases we do for carotid artery disease, we use a distal embolic protection. Where it is not indicated again, the radiation related issues, and you have a really fibrous plaque where you don't have an ulcerated plaque, you can take your chance if you want without a filter device. There is no age cutoff for doing a carotid artery disease. And suppose you have a doubt. Suppose you see a patient who is like short and looks very old. Better to do a carotid, better to do a CT angiogram of the carotid cerebral vessel, including from the uptake of this carotid. That will give us if there is a osteal stenosis, how is the uptake, and is there a calcification anywhere on the way, so that you have a preparation for yourself for the stenting or endarterectomy in case you are choosing. So my answer to you is that if you have a very elderly patient or a patient having neurofibromatosis, or you have a patient with a lot of spinal deformity where you think that I am going to have a challenge, you better do a CT angiogram from the aortic arch till the cerebral circulation, and get your anatomy ready before you jump into doing a carotid intervention.
I just wonder, Dr. Dalai, why is the interventional person is on the defending side all the time? Something which is developed in 1953, carotid endarterectomy, 1989, stenting. I think the basic discussion itself is, the foundation of the discussion itself is a little dicey. I certify what you have said. 2008 onwards, you have been doing a lot of cases, my own cases you have done, and all of them really went well. As you said, there's nothing. See, there is a gap of 30 years between the two methods which are developed. That's something which is very important. And why should the interventional person defend that what I'm doing is right? He is right, absolutely, 100%, we agree. Why should he be the defending champion?
Madam,
you tell me, Dr. Behra.
Madam,
Yeah.
Madam, because I am younger to him, I always have to say I am also good. Similarly, because carotid endarterectomy is the first procedure.
See,
Madam,
sir, actually,
because the carotid endarterectomy is the procedure first introduced to address carotid artery disease, and we are the younger people doing carotid artery stenting. So we have to jump around and say we are also equally good.
See,
Right.
sorry, like I'm interrupting you. The end of the day, what matters is how your procedure going to give the future of the patient, how safe it would be. That's what the debate is on. Suppose both are same, they're not, debate has to be there. What things matter is how beautifully you are crafting that part. Suppose your surgical arm is very good and interventional team is not that great, so natural surgery dominates there in the hospital. But when both are equally skilled, that's like Dalai and our Padi Bhai, they are a highly tempered person. Dalai is too aggressive and he is too sensitive, and both have exclusively besides they execute their skills in such a way, you wouldn't expect there's a complication anyway. So that's I'm confused. Suppose our patient comes, where to refer, surgery or this one? So naturally, we have non-surgical armies, they're always going to go to that side, but it's a bit surgical, but as it's very good, but expensive. Here you have another non-expensive person. Probably I would think that way the patient is not affordable.
Arrogantly, doctor.
You have to look at certain other endpoints.
Yes,
also.
yes, I was about
we
to
are
come to
only
that
looking
point.
at the primary endpoint of periprocedural stroke,
Exactly.
myocardial infarction, and death.
Exactly.
There are certain other composite endpoints.
Yes.
No, there are,
for
I
us,
think,
for a neurologist,
2-3
what
points
is it?
I think we have to concern. One is carotid endarterectomy also has its limitation, as I told, because once the internal carotid extensively involved, once it touches the base of skull, I think our hands are up. We cannot hold that area. And beyond that, if disease is there, so that is where the role of stenting is definitely good. Coming to endarterectomy, where technically it will work better than the stenting, particularly if it is isolated in the bifurcation itself, maybe 1 centimeter into the ICA, then it will come out in a very nice way and you will get a very large, good lumen. So the long-term patency will be definitely good. If you see all the literatures from 95 onwards, the CREST-2 trial has not made anything difference because the major adverse effects like stroke, death, or myocardial infarction is almost similar in both the groups. From the beginning, the stenting has almost managed the result what carotid endarterectomy has given. But the only question comes is the restenosis, because where we are operating for a stenotic lesion, and if the restenosis is more, then we have to look into why. 2 days, no have time. I don't know what they've written about restenosis. But if restenosis is more, then we have to think of that. But even if that is there, when we work with our personal experience, we can know where, like as I am telling, where the carotid nephrectomy cannot give good result. Only I as a surgeon with my experience I can tell. So if we analyze, introspect into the things, we can definitely give a better outcome for a particular patient where we have been. And another thing I think I missed on that slide, actually if there is a 100% block in the carotid artery, there is no use of any intervention because that is already taken care of it. And I had one case long back when we were very young, whatever comes we want to operate. I operated that one, operation went nice, and night patient has a bleed. When I opened, the carotid artery was full thrombosed. But patient didn't develop any stroke, which already it was 100%. So that day onwards, I know that if it is 100%, just leave it like that. So that is another area we have to see. If it is a totally 100% blocked, it is collateralized, there is nothing to go aggressively to do that. That is another thing. So restenosis is the main area where we have to think. But still, there is definitely some of the edges of the stenting is there. But in a subset of patients where there is a discrete block in the bifurcation, the long-term results will be definitely better with the endarterectomy.
Uday sir, please.
Presentation, Siba. So you already showed a couple of cases where you said that the calcium broke the stent and you managed it well. Tortuosity, I saw some of your cases that extremely tortuous cervical loops of internal carotid, and you could do the stents well. But you have been doing it for a long time now, and so this is the time that we have to raise the bar. We have been told, and which have been repeatedly said again and again and again. One of it is the floating thrombus. I want to know your take on it today. And the second one after that is what Padi sir said about total occlusions. Because we do have patients with chronic total occlusions, documented carotid artery occlusions coming with hemodynamic symptoms, not acute stroke, but hemodynamic symptoms. Not because the collaterals are not there, but because they are not enough. So I want to know your take today on these two things, the floating thrombus.
Very interesting observation.
And one second, Siva. And the third thing, Manas also wants you to talk a little bit more about calcified clots.
Exactly. I was about to ask that point actually, because how would approach that part? Yes.
There are three excellent questions. One is about floating thrombus and what you do today in 2025. Number two, there is a 100% block of carotid. What is the role? There is a calcific carotid artery. What you do today in 2025? Very beautiful questions. Let's come one by one. Floating thrombus. Actually, last 1 year itself, we have treated more than 5 floating thrombus with carotid artery disease. What does that mean? Because of a paradigm shift in treatment of acute stroke, because of excellent navigable aspiration catheters are available to us today, we don't really worry about taking a floating thrombus out from the carotid or from the intracranial circulation. So what you do is, we go ahead, take the excess, we do an angiogram, we see a floating thrombus, we have a 6F neuron max ready with us, you put a red 72, you just aspirate the clot out. Most of the time, you can take the floating thrombus out. Here, I'm talking about a situation where the floating thrombus is resulting in over 90% stenosis. Not that there is a carotid artery disease, atherosclerotic, which is 90%, and beyond that there is a floating thrombus. I'm talking about a floating thrombus per se, which is causing significant disease for which patient is presented with TIA. You do an angiogram, you see the bifurcation might be looking great, but just beyond at the petrous or below, you see a thrombus which is almost 90% or 100% occluding. Then you can aspirate. We don't leave such patient without treatment. We aspirate the clot out. Very easily we can aspirate it out. And if you see that there is a cervical lesion associated with it which needs to be addressed, we can put a stent. Number one. Number two, coming to a 100% occlusion. Let us understand 100% of occlusion of a carotid means there are variety of clinical scenarios. Now, I get a carotid, suppose I get a stroke patient today. I go and do an angio. I see that the carotid is 100% occluded. Now, what do? I treat this patient because 100% occlusion of carotid leading to stroke. So, my suggestion always is, if you see a carotid artery occlusion which has just started 6 hours back, it is an indication for treatment. You have to treat. So, acute carotid artery occlusion leading to stroke within 6 to 8 hours with your diffusion weight showing a stroke, there is no hemorrhage on your susceptibility, and there's a large penumbra, you should treat the carotid artery.
No, that will be thrombotic occlusion. It cannot be chronic. What I am telling.
I'm coming to that.
About the chronic occlusion over a period of time.
I'm coming to that. That's a part B. It is not acute. Suppose you have a 90% carotid artery disease with a little bit of thrombus going from the heart or somewhere, it might get occluded. So it's an acute on chronic, not necessarily a clot has gone and just sitting there. There you just aspirate the clot, you don't need to do a stent. Now coming to part B, chronic carotid artery occlusion 100%. Suppose in a clinical scenario, we have a patient 100% carotid artery disease. Now you have another side which is also equally bad. That means let's say 99% stenosis. So you address the 99%, but you don't do anything to the occluded carotid artery.
Yes.
So clinical scenario, chronic carotid occlusion of left side, let's say, right side 99% stenosis, you address the 99% stenosis by a stenting or a carotid endarterectomy. But we have patients where you will see both carotid arteries are occluded. Patient is on 2 vertebral artery in the posterior circulation with 2 PCOM supplying to the entire cerebral circulation on the anterior side. The entire cerebral circulation are taken care of by 2 vertebral arteries. Both carotids are occluded. You don't do anything, but if the patient becomes symptomatic, multiple TIAs, there is an indication to open this chronic carotid artery occlusion. That is a very good indication. Yeah. So either Manas Bhai is there, I have to tell bypass, otherwise he will ask multiple questions. So you can do a bypass in such a patient, or you can open a carotid artery. Anything, Bhai? No. So either you can do a bypass if you have a great surgeon like Manas Bhai, like our Suresh sir, or he can send the patient 3rd floor. We can do a carotid artery stenting in a chronic carotid artery occlusion also. Coming to 3rd clinical scenario, calcified carotid artery. We don't care about calcium anymore. We have IVL. Last week I was talking about IVL, intravascular lithotripsy. Now, which calcific lesion in carotid are a difficult lesion? The case I was talking about in Vijayawada, we just broke a stent. What it was? It is a concentric calcification. That means there is a calcium ring all around the carotid. It's like a ring. So now your stent might break. So it is very difficult for you to do a stenting. But suppose this is the carotid artery and you have a chunk of calcium outside this, on this anterior wall or posterior wall, medially, laterally, you don't have to worry, because the moment you start doing a stenting, the calcium gets pushed out, you have no issues. So the issue is concentric calcification of the carotid. What we do, we take a IVL catheter, we run some 60 pulse, and it breaks the calcium. It breaks the calcium, and now it is eligible for doing a stent, because the concentric calcification will start having breaks, and you can just put your stent. So these are the 3 clinical scenarios, and that's how we deal with it today.
Nice to know that IVL in the carotid stenting, because usually you do in coronary world, the calcific lesions, but it's very fascinating to see in the carotid world also.
And they are super effective, the IVLs.
Yeah, about to ask. Mama is asking whether any kind of rotablation. I said rotablation is not tried in.
I said Behra will do rota.
Though we do in coronaries, but not in the Sweden. Never tried. That's good anyway. Good contemplation in that side. So.
We heard so much about you.
Yeah, thank you so much. And actually,
every day.
Thank you so much. Actually, Dalai, actually wanted to have one more question. What about no reflow in acute setting? Have you ever come across no reflow is very important area during acute stroke intervention.
No reflow?
no reflow of the carotid after intervention. Suppose you put a stent, but then no reflow, no flow. What would you do?
Means acute occlusion of a carotid stent.
Yes.
You put a stent and the stent got occluded.
Yes.
Okay. So it is a procedural complication that we might have to understand. Starting with, suppose your assistant has forgotten giving antiplatelet and the patient was not on antiplatelet, you put a stent or you put a bulky stent like a C-guard, it will acutely occlude, number one. Number two, if you have a very tortuous carotid artery with a loop which is just distal to the bifurcation, you put a stent, this stent will cause a lot of spasm in the C loop and you might have a shutdown of the flow. Number three, there can be a hematological disorder for which the patient is prothrombotic and you have not checked the effectiveness of clopidogrel or the ticagrelor that you are giving. Even we are now seeing patient resistant to ticagrelor, although it is less common than clopidogrel, but it is still there. So these are the scenario where you can have a acute stent block because of this technical region. Now, another most important area where you can have a stent block is when you're putting a stent into a thrombus. Like we were discussing about a floating thrombus, instead of removing a thrombus, if you think that I'll get rid of it, I'll get over it by just taking a wire and putting a stent, that stent is going to occlude immediately because this acute thrombus will promote more thrombosis with a foreign body there, and it's very difficult to address them.
Another cause of no reflow, what he was asking, actually what we get in the coronaries and all, if there is a distal runoff is poor. So even if you do it, maybe because of microembolism or protective device not used, or there is already ICAD with microvascular disease, that can also lead to no reflow phenomena, particularly in acute settings. So that we can't predict, but sometimes if it is not properly assessed or something.
Why we don't have such a situation? Because we do a cerebral angiogram to see the distal flow, ICAD, and any other situation in the brain and the distal flow, number one. Number two, we personally give the antiplatelet ourselves, and then we take care of the other issues.
Do you keep
Sir has told it is a basic neurological evaluation before any procedure, whether surgery or stenting, and a cardiac evaluation also. We had a patient with LA appendicular clot.
Now we have a question.
Before the procedure.
No, means you can do break the calcification, and it's like whether you go in a Mercedes car or a Maruti car, your destination is same, the journey is different, and it's not that the complications are less, because a simple bypass has far less complication and is the cheapest way, least expensive way of benefiting the patient than going through all these measures.
Life is all about experience. If
Correct.
you're traveling
Experience in a Mercedes, I think
you might reach the same destination with a better experience.
Yeah.
So let us not discount the experience part. Thank you.
Yeah, Maruti also gives a good experience.
Sir, I have a question to Padi.
I cannot debate that. Bhai jo bola wo final hai.
Usually these studies have shown that there is a risk of myocardial infarction more with carotid endarterectomy than stenting. And also in one of Dalai sir's slides, he has shown that acute MI is a history of recent MI is a contraindication for endarterectomy and also cardiac dysfunction. Drastically, your cases, most of them went both CABG and carotid endarterectomy. So how did you select the cases for endarterectomy?
In the recent MI, we don't do CABG also, even if cardiologist will be telling us, because we feel that it is an inflammatory stage. The same thing will be their whole arterial bed. So in acute MIs, we don't do CABG also, but if symptomatic triple vessel disease, when we go CABG, you evaluate there is a carotid artery disease, symptomatic, then we combine both. So in that case, the risk of procedural MI is not there, unless there is some technical issue or something with the arterial grafting, so coronary artery grafting. Usually they will not develop MI. The risk of MI comes with stenting or carotid endarterectomy if the cardiac evaluation is not done properly. That's why, as we for CABG, we do the carotid Doppler routinely. For any carotid stenting or endarterectomy, complete cardiac evaluation is a must. And if required, suppose by doing cardiac evaluation comes triple vessel, so that has to be addressed. So if you have not done, you just go for it, then procedural MI we have to face.
So two questions from my side. One, what are the timelines after a recent TIA or stroke? When do you do the stenting? Number one. Number two, if you come across a patient who has an asymptomatic significant carotid stenosis and extensive intracranial atherosclerotic disease, do you still go for stenting?
So those are very important questions. So madam is asking that if a patient is having a TIA, how soon we can stent? In a case of TIA, we stent immediately because there is no established infarct in the brain. So what could be a risk in such patient? The risk we are talking about is when you have a patient with an acute stroke, you put the patient on double antiplatelet, the patient might bleed. So that is our worry. Now in a case of TIA, because there is no established infarct, so there is no chance of having an hemorrhage because of antiplatelets. Hence we don't wait, we treat a patient with TIA and carotid artery disease immediately. Now coming to the stroke, if the patient is having a large stroke, 1/3 territory or more, we definitely don't stent immediately. 4 to 6 weeks time is given and a reevaluation with an MR is done to understand that there is no active disease in form of a bleed or something, then we can go ahead and stent. So that is...
If it was a large infarct and the patient has a disabling stroke, has had a disabling stroke, would you still stent the patient?
If we have
it was a large infarct and the patient had a disabling, like the clinical neurological deficit is very significant, do you still go ahead and do stenting?
We give that decision to the patients and the relatives. Clinically, what we understand scientifically, if the carotid artery disease is very significant, but distally it is also supplying a good amount of intracranial circulation, we suggest. But as you know, stroke is a very debilitating disease medically, financially and socially. So we don't really force them that it has to be done, but we tell them that there is a carotid artery disease. If we improve the flow, whatever intracranial circulation we can see can improve, that might help because we are not sure how much it is going to help. And if finance is not an issue, we can stent it. And mostly we give that
reperfusion injury will be more, no, in that setting.
Sorry,
if you revascularize, reperfusion injury will be more.
That's why we wait for 6 weeks.
Yeah, if we wait, then we can think of that.
That's
acute setting, I think we should
no immediate
avoid.
stenting.
Yes.
We wait for 4 to 6 weeks. What are the next question, madam?
With extensive intracranial atherosclerotic disease.
Sorry?
Extensive intracranial atherosclerotic disease with...
Yeah. So that's again a good question. So we treat them. Last week also we had a patient with severe intracranial disease and carotid artery disease. So how we decide on this patient? Suppose we do an angiogram in Doppler patient with a TIA, Doppler was done, significant carotid artery disease, and they cannot see intracranially, so they come for a carotid stenting. We do an angiogram and we see which lesion is limiting, the carotid or the intracranial. So suppose we have a very significant intracranial disease and also a very significant carotid artery disease, then we try to treat both of them in the same sitting. And because they are supplying to the same area, so we are not really worried that it might lead into hemorrhage or something. So my answer to your question is, even if there is tandem lesion of intracranial atherosclerosis and carotid artery disease, we treat them simultaneously. Suppose the carotid artery disease is 99% and the intracranial disease is 70%. You do a carotid, put him on optimal medical management, and then evaluate the patient for further management.
Even if it is small vessel disease?
Small vessel means up to M1.
If the intracranial disease is predominantly small vessel disease.
That's right. So
will it benefit the patient?
Up to M1, up to basilar, we call it as a LVO, large vessel. So in medical nomenclature or literature, large vessel in intracranial circulation means up to M1 and up to basilar. So if there is disease there, we address them. But going into P1 or M2 or A2 or A1 even is not the way to go for us.
Sir, any experience on instant restenosis post-stenting or any incidence of hyperperfusion injury post-stenting?
Great question. I do not have personal experience of hyperperfusion syndrome, as I told you. But yes, intracranial stent occlusion acutely we have seen. We have seen few, and most of them are in acute stroke setting. So I think a couple of weeks back, we were treating a patient who had a 9 o'clock stroke, posterior circulation, came to us, and we did an angiogram. We saw that there is an intracranial V4 critical stenosis. And we did basically aspiration, opened up the basilar beyond that, and we did a gentle balloon angioplasty. We waited for 25 minutes to 30 minutes. We did an angiogram. We saw that the lesion has again reoccluded. Again, we did a balloon angioplasty and waited for half an hour. Again, we did an angiogram. We saw that it is occluded. Then we decided to put a stent, and we put a stent. And after 30 minutes, we saw the stent got occluded. Because it's an acute stroke setting, there is a lot of thrombus, and the stent got occluded. Then again, we recanalized the stent by aspiration, but finally the patient did not do well. Because 9 o'clock morning was the stroke onset, and we were doing this at 6 o'clock in the evening, and there was a, may I request silence, BALT people? BALT team, please. So then this is an acute stroke setting, and this was 9 o'clock in the morning stroke onset, 6 o'clock in the evening we were doing the intervention. There was already a well-defined infarct in the midbrain, so patient did not do well. So this is the acute stent thrombosis scenario.
Any role of, if patient has 50%, let's say moderate or mild moderate, where we can't decide according to the severity, if the patient is still symptomatic after having ruled out all the causes, will you
That's
go
a
ahead?
very, very interesting question. So patient has 50% stenosis but symptomatic. I will say that 10 times think before putting a stent. Look for all other possible things. You might be thinking this 50% stenosis is giving rise to a problem, but there might be something else. Generally, 50% stenosis does not cause a symptom. Unless there is an ulcerated, highly unstable plaque, and you see all the irregularities of the vessel lumen, and there is pouching and pumping and this calcium, then even if 50%, it might, but we don't see such lesions honestly. So don't put a stent in a 50% stenosis. It's not recommended, first of all. And second, if the patient continue to have stroke after the stent of a 50% stenosis vessel, you are in a problem, because you will have a lot of questions that why do you put a stent? After stent also the patient is having multiple strokes, and you don't have a data to back you that you should not have put a stent in a 50% stenosis. So stay away from there. That's my suggestion.
Thank you. Can I just add to that? Okay.
Yes. Yes.
So unless there is an entity called capsular warning syndrome, where the carotid artery disease is not going to be as significant, but at the same time, these patients continue to have repeated TIAs and even strokes, and finally, they land up in a big stroke. And if the carotid artery disease is not symptomatic, it is symptomatic but not significant, then by putting in a stent here, we are not really solving the problem up there, which is the capsular warning. So in that situation, maybe putting in a stent proximally has no meaning. But what Siva said, I have to disagree with him, because if there is no, repeated TIAs or strokes with small embolic infarction, carotid artery disease is an embolic disease. Carotid artery disease is not just the 70, 80, 90% of carotid narrowings are symptomatic. Even the milder narrowings, if, as you said, if it's an unstable plaque, it will still have emboli. Carotid artery disease is an embolic disease. One aspect of it is reduction of blood supply. That can happen in hemodynamic. But mostly it causes trouble by emboli. And not just the 70, 80, and 90% of the carotids embolize. Even
Uh, Sending to Spotify. Thank you so much. That's what one-way trafficking.
That's why you are big brother. I'm a little.
He's smart guy.
Huh?
He cancels vacation and come back. And he's always presents his
Remote
gurus.
robotics.
Let me tell about one word. He has high regards to Uday Nimeshar and Matthew Syrian sir. He always talks about like God. Truly, we see God here with us. I'm truly blessed, sir. So I think it's a cherished moment for all of us to have Dalai and his guru and putting conference. And I was asking, what is I didn't know actually. I'm very sorry to know that today only Pariwai told me, you don't know what is Really bless you. God bless you, Dalai, and your gurus. And we are all, of course, we are blessed in your presence of your gurus here. Thank you so much. Wonderful conference. I think concluding month.
Thank you so much.
I think she's the best person we have, the Miss India for VIZAG, Sujana. She's,
Better you stop, otherwise I would have to sponsor dinner again.
I think you should, Dalai, you should have introduced her actually. See, people don't know who is she.
There is no memento for me.
Yeah.
Dr. Srujana is medical superintendent for Medicover Hospital. She is a very able anesthetist and an administrator herself. And she is Miss VIZAG and participating in Miss India in December 2025. So wish her all the best.
Thank you so much, sir. With all this positivity on December, I will try to win the Miss India for us, for our state. Thank you so much, sir, for all the inspiration. So today I got so many inspirational insights, how to battle with the rest of the states, 28 states. So I would call upon Dr. Hemant Behra, sir, Dr. Pawan, sir, and Dr. Raviteja, sir, to present a token of appreciation, a memento to Dr. Karnakar Padi, sir, for an outstanding presentation and discussion. Come on, ladies and gentlemen, a round of applause to both the brothers who have battled, and in between Hemant Behra, sir, stopping both the teams. Oh, pictures. I would ask sir to come on to the stage. Dr. Uday, sir. So the you Dr. Uday, sir. I think Dr. Mathu, sir, has left. I would request to give a memento to Dr. Padi, sir, by Dr. Hemant, sir, Dr. Pavan, sir, and Dr. Raviteja, sir. Dr. Karnakar Padi, sir, our Director of Cardiothoracic Surgeon team. And I would request Dr. Lalita ma'am and Dr. Anuradha ma'am to give a token of appreciation, a memento to Dr. Dalai sir, our organizing chairman, for today's Stroke Update 2025. And I would announce for all the chairpersons today, thank you for making time. Dr. Hemant Behra sir, Dr. Lalita ma'am, Dr. Anuradha ma'am, Dr. K. Raviteja sir, and Dr. Pavan sir. I would request Dr. Karnakar sir and Dalai sir to present mementos to all the chairpersons. And I also need a picture with all of you.
call the organizing team, kindly come and make an honor by taking the mementos. Dr. Arvind Verma Datla, sir, for this great work. Please come on to the dais, sir. We want you here. You're our back support and guidance for today's program. Your efforts made it into reality. Dr. Merlin Alice Abraham, Mr. Devarapu Durga Prasad. Without you, this conference wasn't into reality. So kindly come on to the dais. Miss Parvati, Miss Gaurishwari, Mr. Srinivas. I would like to thank all the organizing team. Please take the token of appreciation for making today's event into reality. So today our legends didn't just battle or debate, they have enlightened us. This event stands as a proof that when great minds work together, come together, our healthcare moves forward. Thank you for all the legends and dignitaries for being a part of this historic battle. As we come to the end, this incredible battle of legends on Stroke Update 2025, I would like to extend my heartfelt gratitude to each one of you for joining us today. Our esteemed speakers, chairpersons, their contributions are truly enlightening. Thank you for all our delegates for active participation and engagement throughout the conference. Your presence has made the event a grand success. Thank you from the bottoms of heart for the organization team for their tireless efforts for making this conference into a reality. I would like to thank the sponsors for Stroke Update 2025, the BALT, Merrill, Abbott, Medtronic, Boston Scientific, Boehringer, Teramo, Maxim, Dr. Reddy's, and Ralabella International School. Thank you for sponsoring us today and standing with us today. Hope you all have taken the valuable knowledge and insights that will help you in your patient's practice. Let's continue to strive for the excellence in stroke care and make a difference in the lives of our patients. So my heartfelt gratitude to everyone over here. Signing off for today's event, Stroke Update 2025, which created a history of battles. Myself, Dr. M. Srijna Devi, Medical Superintendent, Consultant Anesthesia, Medicover Hospitals, Indian Medical Association, National Director for Sports and Cultural Affairs, State National Council Member, IMA JDN Andhra Pradesh, and FSIA Forever Star India, Miss Vishakhapatnam, Miss Andhra Pradesh 2025, participating for Miss India, Miss Universe India 2025. Thank you all, signing off. Thank you so much for making this event a grand success.